From organizing committee of COVID Heart Rhythm Summit, we welcome you all for this wonderful meeting. Thank you for making it on a Sunday morning. Let's start with the meeting. Let me first invite moderators for this first session, Dr. Nambirajan sir, Dr. Susil Kumar sir, Dr. Sujay Nikhil, Dr. Ramasamy sir and Dr. Ateep sir to take over the dais. Thank you, sir. Let me also invite my friend and colleague, Dr. Ranganathan, to start the session with this topic on hypertension. Thank you.
A very good morning to one and all. At the outset, I'd like to thank Lawrence sir for the opportunity. I'll be talking on a simplified approach to hypertension. This is the outline of my talk. For the next 15 to 20 minutes or so, I'll walk you all through the following topics. We'll see how the hypertension guidelines evolved, what is the importance of proper blood pressure monitoring, how do you classify hypertension, what are the thresholds for initiation of therapy, and what is the choice of therapy. And then I'll close with few major takeaways. This picture was taken in the year 1945. It is a very important picture in the context of this presentation. You can see three very important personalities here in this picture. On the left is Winston Churchill. In the middle is Franklin Roosevelt, who was the US president then. And then on the right is Joseph Stalin. All three of them had one thing in common. All of them died because of hypertension-related complications. And Franklin Roosevelt died because of hypertensive intracranial hemorrhage. And his blood pressure was found to be 300 over 180 just before he passed away. Until this event, hypertension was considered to be a compensatory mechanism and not much interest was shown in the evaluation and management of hypertension. It is only after this incident that US took an initiative and then started this Framingham Heart Study. This is a study, it's a landmark trial wherein they assessed if hypertension and dyslipidemia are risk factors for myocardial infarction. The results of the trial came and the rest is history, as you all know. Now fast forward to 2023 and we have the latest European Society of Hypertension guidelines. I put this classification here from the European Society because it is very similar to the Indian hypertension guidelines. This classification of blood pressure is applicable for individuals above 16 years of age. And this classification is based on recording of blood pressure in the clinic with the patient in sitting position and using an automated oscillometric BP apparatus. They have categorized the blood pressure into 7 categories. A person is said to have optimal blood pressure when the systolic is less than 120 millimeters of mercury and diastolic less than 80 millimeters of mercury. And then further categorization of blood pressure is based on the highest BP reading, be it systolic or diastolic. By that I mean, for example, a patient has a systolic blood pressure of 140 and diastolic blood pressure of 80. Although diastolic is in the normal range, we have higher reading as systolic, which is 140, and so this patient has to be categorized as having grade 1 hypertension. Likewise, suppose a patient has systolic of 130 and diastolic of 100, then he comes under grade 2 hypertension. Even though systolic is in the high normal range, we have diastolic blood pressure as 100, which comes under grade 2. So categorization is based on the highest level of blood pressure. That's why I put and/R for systolic and diastolic blood pressures. And a patient is said to have isolated systolic hypertension when the systolic blood pressure is more than or equal to 140 and diastolic less than 90 millimeters of mercury. So hypertensive range is systolic more than or equal to 140 and or diastolic more than or equal to 90 millimeters of mercury. Before I go further into the presentation, it is very important to accurately determine the blood pressure because this is the cornerstone for the diagnosis and management of hypertension. So I thought it's worthwhile spending a couple of minutes on how to accurately determine blood pressure. First, going to the devices, there are several sphygmomanometers that are currently available in the market. We have manual devices and then we have the automated devices. In the manual devices, we have mercury sphygmomanometers, which are now phased out in many countries and is in the process of being phased out in India as well because of the hazards which mercury causes to the environment. And then we have the aneroid sphygmomanometers, and then we have the hybrid LCD sphygmomanometers. This one is very similar to the mercury sphygmomanometer. But one difference is that the mercury column is replaced by a digital screen which gives you the systolic and diastolic readings. And then we have the automated devices. There are two types. One is automated oscillometric device and the other one is automated auscultatory device. The difference is in the mechanism by which they record blood pressure. In automated oscillometric device, we have a small sensor in the cuff which records the pressure and the volumetric changes within the brachial artery, and then it generates an oscillometric waveform, and from which we estimate the systolic and diastolic blood pressures. In the automated auscultatory device, we have a small microphone in the cuff which records the Korotkoff sounds, and then based on this, we estimate the systolic and diastolic blood pressure. Both look the same, it's just the mechanism by which they work is different. So what is the recommendation for BP measurement? What device does the guidelines recommend? Guideline recommends an automated electronic upper arm cuff device for blood pressure measurement, both in the office and out of office. And aneroid devices and hybrid devices can be used if automated devices are not available. And make sure when you buy an automated device, you buy a validated one. And we have to keep checking the integrity of the device once in a month or so. Look at the tubing, look at the cuff, everything, so that we record the blood pressure properly. This is a very well-known slide to many of us. This is how we record blood pressure. When the patient comes to the clinic, make sure he is in a quiet environment. He shouldn't have smoked, he shouldn't have had coffee or food in the prior 30 minutes before we check blood pressure. With regards to the sitting position, he has to be seated on a chair with a backrest. The feet has to be on the floor. The legs shouldn't be crossed. And when you tie the cuff, make sure you tie it on the bare arm. And then if the blood pressure is being recorded in the home, we have to take 2 recordings 1 minute apart and then use the average reading for the measurement. If it is in the clinic, take 3 recordings each 1 minute apart, ignore the first one and then take average of the last 2. So what blood pressure do we use to diagnose hypertension and to initiate therapy? According to the guidelines, it is the office blood pressure that is recommended for diagnosis of hypertension because all the studies, the hypertension related risk assessment, benefits of therapy, treatment thresholds and goals are all based on office BP recordings. But that doesn't mean out of office BP measurements like the one we use with home BP monitoring and ambulatory BP monitoring are not important. They are very, very important because they give multitude of information regarding blood pressure. You get nighttime readings, you can assess white coat hypertension, masked hypertension, everything only through out of office blood pressure measurements. So whenever feasible, you can use HBPM and ABPM for your patients while managing hypertension. This is ambulatory report of an ambulatory blood pressure monitor. What we do in this ambulatory BP monitoring is, it's a device that is similar to the automated device. There is a cuff that is tied to the arm and then there is a smaller device that is tied to the waist. Patient comes to the clinic, we put in the ambulatory BP monitor. The patient is made to be in the hospital for at least 20 to 30 minutes and we program the device in such a way we record blood pressure every 20 minutes throughout the day and night. That is the recent recommendation. And then the patient comes back the next day to the clinic to hand over the device. So when we generate a report, it comes this way. You can see here, the systolic blood pressure is slightly on the higher side during the awake period. Diastolic blood pressure is okay. And then the blood pressure begins to dip during the sleeping period. That is, the blood pressure begins to dip. This dip has to be between 10% and 20% of the average daytime readings. If it is between 10 and 20%, we call it a normal dipping pattern. And this, once the patient wakes up, the BP again starts rising. This nighttime dipping is very, very important. People who dip extremely or who do not dip have adverse cardiac prognosis. This is another reading. You can look at this one. The patient has slightly elevated systolic and slightly lower diastolic, but look at this nighttime sleeping period. Instead of dipping, in fact, the blood pressure rises here. So we coin this patient as a nocturnal riser, and this also carries adverse prognosis. And this clearly shows how we diagnose white coat hypertension. The patient has come to the clinic, we put in the device, and then the first 20-30 minutes he is in the hospital. You can see here the blood pressure is high initially in the hospital, and then once he gets back home, blood pressure starts coming down. It dips normally, and then again the next day morning he goes to a meeting where he attends a meeting, and then blood pressure starts shooting up. So this is a classical example of white coat hypertension. All these we'll be able to make out only when we use out of office BP monitoring. So we get additional information like white coat hypertension, we can diagnose masked hypertension, we can assess the dipping status if the patient is a non-dipper, if the patient is a riser or extreme dipper. Now that we know what device we use, how do we, what is the threshold for diagnosing hypertension and all that. So what is the significance of measuring blood pressure in both arms? It is very, very significant because normally there is an inter-arm blood pressure difference. When this difference is less than 15 millimeters of mercury, it doesn't matter. But when the blood pressure difference between arms is more than 15 millimeters of mercury, then you need to assess for atherosclerotic vascular disease. And whenever there is a blood pressure difference, make sure you record the blood pressure in the arm with higher reading. In subsequent visits, you need to make sure you record blood pressure only in the arm with higher blood pressure reading. Even if you're not able to measure blood pressure in both arms during every visit, at least during the first visit, it is very, very important that we measure blood pressure in both arms. And this is a data, Indian data, done by Gurpreet S. Wander et al. It's a large study wherein more than 1 lakh patients were studied and all of them had an automated BP monitoring. What they found out was, by measuring blood pressure in both arms, they were able to diagnose hypertension in additional 6% of the participants, which means blood pressure was normal, blood pressure was in the normal range in one arm and it was in the hypertensive range in the other arm. So if you had measured blood pressure only in one arm, you might have missed this 6% of patients with hypertension. So it is very important that we measure BP in both arms. So how do we diagnose hypertension? Patient comes to the clinic, you check blood pressure, it is in the grade 1 range or grade 2 range. You immediately cannot deem the patient to have hypertension. If it is in the grade 1 or grade 2 hypertension range, let the patient go, get back in 2 to 4 weeks time, recheck blood pressure. If the blood pressure is still in the grade 1 or grade 2 hypertension range, then you diagnose hypertension. Scenarios where you diagnose hypertension even during the first visit is even if the blood pressure is in the grade 1 or grade 2 range, but if it is associated with hypertension mediated organ damage like LVH in the ECG, albuminuria in urine routine, or retinopathy in fundus examination, then you can diagnose this patient to have hypertension. Or if the patient has grade 3 hypertension, when the blood pressures are more than 180 over 100, then you can diagnose hypertension even during the first visit. How do you initiate therapy? What are the thresholds for initiation of drug therapy? You categorize patients into two groups. One group is 18 to 79 years and the second group is the older population, more than 80 years. So for patients between 18 and 79 years, initiate therapy when systolic is more than 140 and or diastolic more than 90. You can initiate therapy earlier if the patient has associated high cardiovascular risk in the form of established cardiovascular disease. You can see this here, 18 to 79 years, when the patient has established cardiovascular disease, initiate therapy even when the blood pressure is more than or equal to 130 over 80. And for patients more than 80 years, initiate therapy when systolic blood pressure is more than 160. All these are class 1 recommendations. That's why I've shaded it in green. And then now you have the class 2 recommendation. Any patient more than or equal to 80 years, you can initiate therapy when systolic blood pressure is between 140 and 159, but it's a class 2 recommendation. And for frail patients, you need to individualize because frail patients may not tolerate better. So depending upon their tolerance, you initiate therapy, and target levels are also based on the individual patients. So we initiate therapy. What is our goal? What is the target blood pressure? Systolic blood pressure, we want it to be between 140 and 120. We do not want to reduce systolic blood pressure below 120. Likewise, diastolic BP, the ideal target is between 80 and 70. We do not want to reduce diastolic BP below 70. And for elderly individuals above 80 years of age, our ideal target would be to attain a systolic blood pressure below 150 millimeters of mercury. And what happens, why do we not want to reduce blood pressure below 120/70? You can see this data here. When the systolic blood pressure is reduced to below 120 here, the hazard ratio starts increasing. So the sweet spot is between 120 and 140 where the hazard ratio is minimal. Likewise, diastolic blood pressure, do not reduce below 70. When you reduce it below 70, again the hazard ratio starts increasing. So now we have looked at the threshold for initiation of therapy and target levels. So what antihypertensive medication do we start with? According to the latest recommendations, BP lowering is prioritized over selection of specific antihypertensive drug classes. That is, reduction is more important over selection. So whatever drug you may use, our goal is to reduce the blood pressure. Whatever drug it may be, reduction of blood pressure results in better cardiovascular outcomes. There are 5 drugs which are considered as first-line drugs for treating hypertension. They are ACE inhibitors, angiotensin receptor blockers, beta blockers, calcium channel blockers, and diuretics. And when blood pressure is not controlled with these medications, either as monotherapy or with combination, then we use second-line agents like alpha blockers, example prazosin, centrally acting agents like clonidine or moxonidine, and mineralocorticoid receptor antagonists like spironolactone. These drugs come under second line category because we don't have enough outcome based trials on these drugs, and these drugs are associated with slightly higher risk of adverse events and side effects. So this is the first line therapy. We have ACE inhibitors. I'll just give a couple of points for each drug. Why do we choose this drug? ACE inhibitors, ARBs, we have large outcome data. They are very safe, well tolerated. We can use ACE inhibitors or ARBs in patients with heart failure, in patients with CAD, in patients with CKD, in patients with LVH. But one contraindication, very important contraindication is please do not use these drugs in patients who are planning for pregnancy or who are pregnant. Also, it's contraindicated in patients with bilateral renal artery stenosis. CCBs, talking about the dihydropyridine calcium channel blockers like amlodipine, benidipine, and azilnidipine, extremely safe, well tolerated, can use in any group of patients. They have no specific contraindications. And then we have diuretics. We have thiazide type diuretics and thiazide like diuretics. Thiazide type is hydrochlorothiazide, and thiazide like diuretics are indapamide and chlorthalidone. Generally, thiazide-like diuretics like indapamide and chlorthalidone are more potent, they are more longer acting, so it's better that we use thiazide-like diuretics. One caution is when you start a patient on diuretics, see if the patient has any dysalkylatemia, avoid when the patient has hyponatremia or hypokalemia. Likewise, when the patient has gout, be extremely cautious. And then beta blockers. The latest guidelines have upgraded beta blockers in the management of hypertension. Previously, beta blockers were not included in first line therapy for hypertension because they were not neutral on lipids. They increased the incidence of new onset diabetes and so on. But now with newer beta blockers, especially vasodilating beta blockers like carvedilol and nebivolol, they do not increase the incidence of diabetes. They are neutral on lipids. They have 24-hour action. They are very well tolerated. They have very minimal airway resistance. So beta blockers have now found their place in the first line drugs for management of hypertension. And while what the guidelines recommend is any patient on hypertension start with a combination therapy. The initial combination is, you can see the dark blue lines here. It is going to be either ACE or ARB with a calcium channel blocker or ACE or ARB with a diuretic. This is the first line combination. If this combination does not work properly, patient still continues to have elevated blood pressure, then you can use this triple drug combination, ACE, CCB, and then diuretic. All these 3 blue lines. Now the latest addition is this combination of beta blocker with ACE inhibitors. I'll just finish in 2 minutes. Beta blockers with ACE-ARB combination can be used in multitude of conditions. It can be used in patients with arrhythmia and hypertension, pregnancy and hypertension. ARB cannot be used. I mean, beta blockers are used in patients with pregnancy and hypertension, arrhythmia and hypertension, patients with tremors and hypertension, migraine, hypertension. And one important point to consider is any patient with hypertension and resting heart rate more than 80, then beta blockers are the first choice of therapy. So this is how you approach a patient with hypertension. Any patient you diagnose hypertension, make sure you suggest them all the lifestyle modifications like weight reduction, to quit tobacco, to increase the dietary potassium and reduce dietary sodium. Start with combination therapy. As we discussed, it's RAS plus CCB or diuretic. If the blood pressure is not controlled, RAS inhibition with CCB and a diuretic. 90% of the times the blood pressure is controlled here. If still it's not controlled, then you need to evaluate for resistant hypertension. And as we discussed, beta blockers can be used at any step of combination therapy. The rationale for why ARB plus beta blocker combination is coming up. This is a very interesting article published by Stewart Julius et al. You can see here on the y-axis is the event rate. The first one here, the heart rate is less, blood pressure is controlled, the patients do well, the event rate is less. But if the blood pressure is controlled, but still the heart rate is more than 80, the hazard ratio or the event rate is very high. So it is not enough when you just control the blood pressure. You also have to make it sure you reduce the heart rate as well. The magic number is 80. Any patient with resting heart rate more than 80, make sure apart from controlling the blood pressure, you also control the heart rate. Now that we have given all three medications, still the BP is not controlled. What do? We have to first rule out white coat hypertension or white coat effect. So what we do is we put the patient on an ABPM to rule out white coat effect. If the blood pressure is still more than 140/90 even at home, then we need to verify adherence. This is very important because in our day-to-day practice, we have many patients who are not adherent to the medications. And then we also need to rule out OSA. Still the blood pressure is high, you check for drugs that interfere with antihypertensive medications efficacy, like NSAIDs. Even paracetamol is found to increase blood pressure. We have nasal decongestants, antidepressants, sodium-containing antacids, glucocorticoids, and so many other drugs. The list is incomplete. Even immunosuppressive agents, azole antifungals, all can increase blood pressure. So what happens? You patient is adherent, ambulatory BP monitoring shows no white coat effect. Still the patient's blood pressure is high. What do? You can add spironolactone. If not, you can add an alpha blocker like prazosin or centrally acting agent like moxinidine or clonidine. You can also consider renal denervation if all these fails. And renal denervation is a class 2 indication for resistant hypertension treatment. With this, I'll close and thank you one and all for the patient listening.
Thank you, Ranganathan, for your step-by-step approach of hypertension. I'm proud to share that he is our PhD alumni. He is a gold medal student in DM cardiology. Right from the student days, his presentation is always very crystal clear. Yes, it's agree with Ranganathan. The basic of measuring blood pressure makes a lot of difference in initiating hypertension drugs. Also, the adherence and concurrent medication. Yeah, it's nice that these three world leaders had a hypertension emergency. The Winston Churchill BP was keep on shooting from 180, 180, 200, 240, 250, 260 like this. How we came to know, how people came to know is his physician has made a note in his personal diary that our leader BP was today this much, that day this much. It was during World War time. So what does it mean? So it indicates, it indirectly says that documentation is very important in our field. That's why even after so many decades, we remember that the world leader, his BP was going on during the second world period. Finally, he's died of intracranial hemorrhage. Okay, any queries you want to ask from the presentation presenter?
Ranganathan, it was a wonderful talk,
Thank you,
especially a note on the non-dippers. So the emphasis on the ABPM. One small query: the target you said was around 130, 80 or something like that. From the sprint trial, any more reduction around 110, 80 or 110, 70? Will it be useful? Any comment on that?
As far as the sprint trial, the outcome was good. But as far as the recommendations are concerned, they say below 120/70 in general, it increases the hazard ratio, tolerance goes down, patients can have postural greenness and all those things. So as of now, the recommendation is not to reduce blood pressure below 120/70. But still we can individualize therapy. Even elderly patients, you can bring it down to 130/80 if provided they tolerate the therapy well.
Thank you.
Thank you.
That was a very crisp presentation. One important thing that you highlighted was the checking for OSA. I think there is one very overlooked factor when we screen patients for hypertension. And we actually find, I have personally seen a lot of patients with OSA who have been undiagnosed before. And they do much better with the home CPAP, and the hypertension control is much better with them. So OSA is one very important factor.
Beautiful presentation, Ranganathan. here a lot of physicians are there, and we get a lot of references from lady doctors regarding hypertension, pregnancy induced hypertension. So we see the pregnancy induced hypertension is very high nowadays, especially when pregnant ladies, women are slightly on the overweight side. We start on labetalol and they keep on increasing 50, 100 and all that. When do we start decreasing after delivery? What is the time gap? They
So many
generally they
patients,
don't come back again to check their
it is
BP.
very, very important. Even diabetes, they have just to start with, they have gestational diabetes, and then it is very imperative on the treating physician to inform the patient even once when they deliver. It is very important they keep checking their blood sugar and blood pressure every 3 months, because many just continue to develop chronic diabetes and it goes untreated for quite some time, and they have all the complications starting. So once they deliver, many of them, they have just pregnancy induced hypertension and blood pressure starts coming down. But it's very important we screen them every initially a couple of weeks later, and then a couple of months later we need to keep screening them. The blood pressure is in the higher range, like if it is more than 140/90, then we need to counsel them to continue medications.
Thank you very much.
Yes, nice presentation, Ranganathan. Actually, I don't remember which guidelines is on also that. There is a recent concept that that resistant hypertension they increased to 4 drugs, which the one drug should include aldactone, because the Con syndrome, as we think, it's not very rare. It's very hyperaldosteronism is very common. So I don't remember whether it's the recent AHA or which guidelines is this. They increased the drugs to four, which the fourth drug should be an aldactone. I don't remember which guidelines. Please refer to that.
It's not definitely not from the European Society, because this many of the slides are from the European guidelines.
Yeah,
According to their recommendation, it's 3 drugs. It's ACE or ARB with calcium channel blocker and a diuretic in optimal or well tolerated recommended doses. After excluding white coat effect and after verifying the adherence, still blood pressure is high, we call it resistant hypertension. You add spironolactone only when you diagnose resistant
potassium
hypertension.
is high, but we have actually there is a recent update.
I'll look into it.
Recent update that we should have four drugs that one should be an aldactone. Should be.
Yeah, excellent talk. You have mentioned ACE/ARB as the one of the first line because as an excellent drug for modification. But we have to take it with a word of caution that no renal involvement is there. You said unilateral stenosis, right? So when patients' BPs are very high, so I would suggest be cautious, very like 210, like that. Always rule out the renal problem, anything is there, because it can suddenly worsen, and we have to check it regularly again and again, because it's a wonderful drug. But what we don't know about the patient at all. We are not seeing the first time we are seeing like 220, 120. Be slightly cautious, because the renal involvement it will be there underlying somewhere. So that has got to be cautious.
But as such, AC inhibitors, ARBs, there's no particular creatinine value where it is above which it is contraindicated. Any creatinine value, it can be given. But when the creatinine is high and you start them on AC inhibitors, you make sure the patient will come back to you in a week or two so that you recheck creatinine. If the creatinine increases more than 30% from the baseline, then you have to stop the AC inhibitor ARB. Because it is one drug that is going to prevent the progression of CKD. As sir said, any patient presenting with accelerated hypertension, before you put them on AC inhibitors, ARBs, check their creatinine, check potassium, because you might lose. There are important clues when you measure all these parameters.
Yeah, excellent. For pregnancy, second line drug, what would you recommend? Pregnancy labetalol, because now government guidelines have they put up. We start calcium channel blockers and all that, but some new guidelines have come out, I think so, right? In pregnancy.
Yeah, so the first line drugs are beta blockers, then as you said, the calcium channel blockers are second line medications.
They don't want amlodipine to be started now. I don't know from how have the persons who check the BP in this thing, they say long acting, suddenly when they are taken for surgery and all that, so suddenly sometimes BP crashes. So shorter acting, actually we don't give shorter acting at all.
Yeah,
it's been such a long time, but now newly they're saying you give shorter acting. Government guidelines.
Methyl dopa can be
Yeah,
given.
methyl dopa can be
Yes,
used as well.
Methyl dopa is not available. This way. It's very rare to procure.
Thank you, doctor. You presented very well.
Thank you. Thank you.
And I have three questions. Number one is the lifestyle modification, as you mentioned. What is the role of salt reduction with regards to the BP? And number two is what is the role of dyslipidemia, that is hyperlipidemia, in regards to the BP? And what is the role of nifedipine? As he said, the immediate reduction of BP. These are all the three questions. I am Dr. Subramaniam from PSG, Kardivabi.
With regards to lifestyle modifications, sodium has to be decreased. Dietary sodium, sodium chloride, if it is sodium chloride, less than 5 grams per day, 5 grams per day. And some patients ask, can we use rock salt instead of table salt? It is all, you can use rock salt, you can use table salt, but use both, not just, you don't completely switch to rock salt, don't completely switch to table salt. Rock salt has so many other minerals. Table salt has iodine, rock salt is deficient in iodine. So make sure you mix up both, and for some dishes you can use rock salt, for some you can use table salt. That's one thing. What they also say is, based on the recent recommendations, you also have to increase the dietary potassium, which does a world of good to reduce hypertension. Increase dietary fruits, vegetables, which are all rich in potassium. So that is one thing. And then the second question, lipidemia. And any patient with hypertension also has dyslipidemia, then he comes under hypertension with high cardiovascular risk category. So you can try to initiate therapy even at slightly lower levels. You do not wait until 140/90, even 130/80 for some patients, because they come under high cardiovascular risk category. That is one thing. And third, with regards to nifedipine, the recent recommendation, what they say is not to use sublingual nifedipine to acutely lower blood pressure. So these are the three. Thank you.
Thank you, Dr. Ranganathan, for the wonderful talk and discussion. Let me invite Dr. Prem Krishna for the next talk on utility of ECG in acute coronary syndrome, tips and tricks.
College. Again, he is a gold medal student in DM cardiology from Jayadeva Institute. Currently, he is doing not only coronaries but also structural heart disease. He has done several TAVI in the recent past.
Thank you, sir, for the introduction, and thank you, Lawrence, sir, for giving me this opportunity. Kindly excuse me because my voice is not okay. So, in case I cough in between, kindly excuse me. So, the next few minutes, I'll be discussing about the utility of ECG in acute coronary syndromes. I'll just pick on certain selected areas, so that because the crowd here is more of a physician-based crowd. We know we can classify ACS into three categories: STEMI, NSTEMI, and unstable angina. Where if you have symptoms, ECG changes, and elevated enzymes, it's a STEMI. If you have ST depression and T wave inversions with an elevated enzymes, it's an NSTEMI. And if you have no specific ECG changes and normal cardiac enzymes, it's an unstable angina. So in the ACS algorithm, the first point of entry is the ECG, and it can be normal, it can be abnormal, as we know. Always remember that you can, in 6% of 1 to 6% of ACS, you can still have a very normal ECG. So that comes, we should consider doing serial ECGs in all the ACS patients. I mean, if you suspect ACS patients, and which is shown in this slide here. If you see the first 30 minutes, the diagnostic yield of ECG is very, very high. A lot of patients in the first 5-10 minutes, usually they have a very normal ECG, and by the end of 30th minute, you have the maximum changes which are picked up. So that's why the class 1 recommendation is, if you have a high suspicion of ACS and if your initial ECG is non-diagnostic, keep repeating once in 15 to 30 minutes intervals, and always try to include the adjunct leads, that is the posterior leads and the right side leads, that is V7 to V9 for the posterior leads and the V4R, which is very specific for the right side lead. And also try to put in a continuous ECG monitor so that you can see any subtle changes or ectopics which are picked up to show whether the myocardium is irritable or not. And to diagnose an ST elevation, this is very, very important point, where the J point, which we all talk about, which is nothing but it's 0.04 seconds after the onset of the QRS segment, the J point and the ST elevation starts here. And whether it's an elevation or a depression, we say if it's more than 1 millimeter, if it is seen in more than 2 contiguous leads, then it falls into a abnormal category. So there are multiple definitions which keep changing, but which is commonly followed is in the absence of LVH or LBBB, we diagnose STEMI by, you just remember 1, 2, 3, that's what we say, 1, 1.5, 2 and 2.5 criteria. So in leads V2 and V3, there should be at least 1 mm ST elevation. In all other leads, for females, it is more than 1.5 millimeter ST elevation, whereas in males less than 40 years, 2.5 millimeter ST elevation, and more than 40 years, it's 2 mm ST elevation. See, this 0.5 and all those things really doesn't matter, but though the criteria are there. And what is a contiguous lead? That is quite important. So basically, a limb leads that look at the same area of the heart. For example, the leads 2, 3 AVF, lead 1 AVL, and V5, V6. These are all leads which are in continuity or which are numerically consecutive, like V1 to V6. So these are called as contiguous leads. So this is the most important in the absence of LVH and LBB. Regarding those two, I will show in the subsequent slides. So certain abnormal points, we all know that this is the curved ST elevation or the convex down, which is the Frowney sign. So this is an abnormal which indicates cardiac injury. This we come across a lot of the time. It's an early repolarization pattern. So we still get calls for this one. So this is, if you see, it's a concave upward, where we call this as a smiley sign. So this is benign if it's asymptomatic. But again, if the patient is symptomatic, then this also needs further monitoring. And with respect to NSTEMI, we take it as ST depressions or T wave inversions. For ST depression, at least 0.5 mm. For T wave inversions, at least 1 mm. Where this is again important in leads with RS ratio of more than 1 or a prominent R wave. So that's quite important, because we have a lot of variants like Wellen syndrome, where we have a biphasic T wave, which is a very important sign of proximal LAD stenosis. And in an unstable angina, you may not have anything, or the ECG changes will slowly evolve over time. So based on duration, we can classify the STEMIs into early, less than 12 hours, evolved STEMI in 12 to 48 hours, and recent STEMI with more than 48 hours, where it is shown here. So if you see, this is the normal morphology. This is the early acute STEMI, where you'll start having a hyperacute T waves. Then you start having the ST elevation. And then once the evolved STEMIs start happening between the 12 to 48 hours, you start having a Q waves, and then the T wave starts inverting. Then the ST starts coming down, the T wave starts improving, and slowly you have only a Q waves and the T waves become upright. So this is the evolution of changes in the STEMI. And with respect to distribution, how our ECG is basically going to help is, one is localizing the culprit artery. It also shows us the amount of myocardium which is at risk, and what are all the high risk features which we have to concentrate. And we have a lot of other things called as STEMI mimics, which is not STEMI other than STEMI. So a lot of favorable points are there in our ECG, and this we all know as to we are going to identify the type of MI. Where it's a lateral wall myocardial infarction, it's lead 1 AVL V5 V6. It's an anterior or anteroseptal, it's V1 to V4, and if it's an inferior, it's 2 3 AVF. And with respect to lead AVR, I will be showing a slide separately pertaining to only this one. So anybody wants to take on this one? It's an hyperacute STEMI. Anybody is willing to take your. So this is basically nothing but an anterior wall STEMI. I'm sure you are convinced about this anterior STEMI. You have tall T waves. Okay, here you can see the tall T waves, hyperacute T waves. Why this is important? You have two morphologies of VPCs here, one here and one here. So this is a highly irritable myocardium. So you should be very cautious. Try to revascularize this patient as early as possible. Check the electrolytes for hypokalemia, hypomagnesemia, because otherwise this patient is going to go in for a VT. So you can see that the hyperacute T waves in the V2 to V6, which is most prominent in V2, V3. And you have some premature atrial complexation, and I said the PVCs of 2 different morphologies indicating an irritable myocardium. The same ECG, after a few hours, you can see the classical ST elevation which is happening. And what is this one here? Can anybody take this? So this is a PVC which falls on the adjacent T wave. So this is nothing but the R on T phenomenon. So this R on T phenomenon also indicates a very high risk feature for the patients who are going to develop the ventricular arrhythmias. So an extensive anterior wall STEMIs, usually we know lead 1 AVL, V1 to V6 has ST elevation. You have reciprocal ST depression in the inferior leads. Check for all these high risk features, and then try to revascularize these patients as early as possible. So this is another example where you have ST elevation in lead 2, 3, AVF as well as V1 to V6. So this is a classical ST elevation both inferior as well as anterior leads. Now this comes in one particular group of patients where sometimes this can be an inferior wall MA, or you want to treat it as an anterior wall MA. Okay, you're going to thrombolyze, it doesn't matter. If you're going to take up for a PCI, then there is some problem in this one. So if you have an occluded LAD that supplies the inferior wall of the myocardium also, then it's a huge wraparound LAD where you have an ST elevation anterior and inferior leads. So this is an acute anterior and an inferior STEMI because of a wraparound vessel. Sometimes it can be the other way around, as you see in this patient where you had an ST elevation in both anterior leads and an inferior leads. Angio showed an occluded RCA. There was a lesion in the circumflex and the LAD was also occluded. Now, which do you want to open up first? So this comes in handy with the echo and other parameters, where in the echo which we showed only a wall motion abnormality in the inferior leads, whereas there was no wall motion in the anterior leads. So we passed a wire into the RCA and this was the culprit, and once it was revascularized, you can see the LAD filling from the RCA. So this LAD, this right coronary artery had been collateralizing the left anterior descending artery all these days, which was a chronic total occlusion. And once this feeding artery is occluded, there's another ischemia at a distance which is happening, so that reflects in the ECG as a ST elevation in both the leads. So it's not always an anterior wall MA, it can sometimes be an inferior wall MA in an ST elevation with both anterior and inferior leads. Now, what is this? This is nothing but called as a tombstone pattern, so which is a very, very high risk feature. Basically, this tombstoning indicates acute occlusion of arteries which are non-collateralized, which have not been primed. There is no ischemic preconditioning. So these patients are prone to develop cardiac arrest at a very short duration of time. Even before we shift to the cath lab, we see such patients succumbing at the EMR itself. So this is the typical tombstoning pattern. And what is this one? Is this a STEMI? Anybody wants to take us? What is this one? Any guesses? So this is, I would say this is, yes, this is an anterior wall STEMI equivalent. So what is this? It is a nothing but called as, you can see there is tall T waves here, there's an ST depression, horizontal upsloping ST depression. This is nothing but the De Winter's sign. So this is De Winter's sign is an equivalent of STEMI where you have a tall prominent symmetrical T waves here, and there's an upsloping ST depression at the J point more than 1 mm. There won't be ST elevation in the precordial leads, and you can still see reciprocal ST depression in leads AVR. So if you can see here, this AVR, there's you're able to see some kind of an ST coving in T inversions here. So that these are all significant prognostic markers of a proximal LAD occlusion. So this is one which I wanted to point out here. There's always a confusion in patients with left ventricular hypertrophy where we want to diagnose an acute anterior wall MA. This always has a confusion even for us sometimes. So there is a simplified algorithm to see whether there is an LVH, STEMI in a patient with LVH. So this is classical ECG pattern. The patient comes to the EMD. Our postgraduate says it's an anterior wall STEMI. Okay, he has been shifted for the cath lab. We checked into the cath lab. Coronaries are clean. But why? This is just nothing but a simple LVH. So how do you want to diagnose that? So this is a simplified algorithm which was proposed by Armstrong et al., where you see whether there is an ST elevation V1 to V3. If there is no ST elevation, then you leave it. If there is an ST elevation, then what you're supposed to do is you check the ST segment elevation and you divide that by the ratio of RS ratio in the same leads where there's an ST elevation. If that is there, then you can consider that to be whether there are more than 3 leads with ST elevation. If that is there, then it's a true STEMI. If that is not there, then it is not a STEMI. The same thing, the same example I am showing here, where the V1, V2, if you see, the ST elevation is approximately around 3.5 mm here, whereas the RS will be, it's almost minus and it's coming to around 31. If you divide both, it is coming to only 11.3. So this was the same which was applied in the same patient when the coronaries were clean. So this is nothing but just an LVH. It is not a STEMI. So these are all certain useful markers which will help us to predict the patient. This is another very important sign which is called the shark fin sign. Can you see the fins here? Which is nothing but a fusion of all the QRS and T complexes, which means this is again another very poor prognostic marker of an irritable myocardium. So this is the next subset of patients where we are going to diagnose the LBBB in the presence of MI. We all know there's a routine Garbosa criteria that there's the concordant and discordant. What do you mean by concordance? That is, the ST elevation should be in the same direction as QRS deflection. Discordant means the ST elevation should be in the opposite direction of the QRS. So if there's, you can see if there's more than 1 mm ST elevation in concordant leads, there's a 5 points. If there's more than 5 mm ST elevation discordant leads, 2 points. And if there's an ST depression in V1 to V3, 3 points. Any score more than 3 fits in this criteria. This is slightly been modified here by the Smith criteria, where because this discordance generally happens in leads V1 to V3 in most of the LBBB patients. So we tend to miss a lot of MIs with LBB. So this has been modified, which has got a better specificity, where the discordance has been reduced to more than 1 mm in more than one lead in any lead where the preceding S wave ST elevation ratio is more than 25% of the depth of the preceding S wave. So this is one modified criteria as per the Garbosa criteria. So this is another ECG where in presence of a paced rhythm you can see pacing spikes. Courtesy this ECG I got it from Dr. Ranganathan. You can see pacing spikes here, and you can see the rate is 60 beats per minute. You have a regular V paced rhythm, LBBB morphology. You can see discordant and STT changes, and you have subtle concordant ST elevations in V6 with a positive QRS. So this is again an MI in the patients with LBBB. So what other things you should never always think, okay, ST elevation should never be always a STEMI. You should also remember the other causes where the mnemonic is an elevation, which could be electrolyte imbalance, LBBB, early repolarization like LVH, ventricular hypertrophy, or it could be Brugada syndromes, it could be persisting LV aneurysms, or it could be Takotsubo cardiomyopathies, or even intracranial bleed, hypothermia or Osborne base, which we don't see, hypercalcemia can be there, or it could be because of non-atherosclerotic vasospasm like Prince metal angina. So rest of the things what we want to show is I just want to show about the posterior wall myocardial infarction, how to spot a posterior wall myocardial infarction, because sometimes the circumflex territory is very silent, we don't pick it up. So always concentrate on the leads V1 to V3. There should be a horizontal ST depression. There will be a tall broad R waves with an upright T waves and a dominant R wave with an RS ratio of more than 1. So and sometimes you have to check the posterior leads. So this is nothing but you always say we invert the ECG, we used to be taught like that. So it's a mirror image pattern in this V1. So what happens is, why this happens is the anteroseptal leads are directed from the anterior precardium towards the internal surface of the posterior myocardium. So that's why everything becomes inverted. So your ST elevation becomes ST depression, your Q waves becomes an R waves, your ST depression is an ST elevation, Q becomes an R, and a terminal T inversions becomes an upright T wave. So this is the classical picture of a posterior wall myocardial infarction. So this is the classical one, which you can see ST elevation in lead 2, 3 AVF, ST depressions in V1 to V3. So this is a classical posterior wall myocardial infarction. Okay. So these ECGs I had got it courtesy from Dr. Ramasamy sir. So, and with respect to AVR, which I said there is one particular important, because we always concentrate on this, because this AVR ST elevation indicates a very poor prognosis if it's going to be a left main coronary artery occlusion, or it could be a proximal LAD stenosis, or it could be a multivessel disease. It can sometimes be a non-occlusive event where the patient has suffered a cardiac arrest, significant hypoxia, hypotension can cause a left main spasm and also cause an ST elevation AVR. So this is a 44-year-old male with cardiogenic shock. You can see there's a gross ST depression in all the leads with an AVR ST elevation here. And this is the angiogram which showed a tight ostial left main stenosis. He underwent an emergency PCI to the left main. So what happens is here, this is another same thing, left main occlusion. You can see there's an ST elevation in AVR and this ST elevation in V1 also. This AVR elevation is slightly more than V1, and ST depression you can see in V2 to V6 and along with lead 2, 3 AVF, and sometimes they often have right bundle branch block. So this mechanism is basically because this lead AVR is electrically opposite to the leads 1 AVL, V5, V6, and sometimes isolated lead AVR can also represent the portion of right ventricular outflow tract or the basal inferior septum, where an infarction of this can also theoretically produce an ST elevation. So the other things is our ECG localization also helps us to localize the culprit artery. If you want to see whether there's a proximal right coronary artery occlusion, you check the ECG for an ST elevation in lead 3, which will be more than lead 3 will be more than lead 2, and you can see the ST depression in lead 1 and AVL. Here ST depression in lead 1 and AVL, and if you see the SR ratio in AVL will be more than 3, and you can have an ST depression in V3 and ST elevation in lead 2, you can see here. So it can happen the other way around also. So this is another important point, but the most important confirmatory is you try to take a right side leads, of which the V4R is the most specific lead. So by this you can diagnose a proximal RC occlusion. Similarly, you can diagnose a distal RC occlusion. These are all distal RC occlusion, where if you have a distal RC occlusion, you have an isoelectric ST with a positive T in V4R. So that is another criteria to say. And most important, sometimes RVMI is very subtle. The initial ECG will show elevation. In a few minutes it will start being normal. So sometimes you tend to have a very normal ECGs over a period of time. So this is again to localize. I'm not going to details of this, because just to localize how an LAD occlusion will be there in the proximal. If you want to see from proximal to distal septal to proximal diagonal, you have a lot of points where you have ST elevation 1 AVL and ST elevation V2 to V6 without an elevation in V1. So that indicates there's a distal to the first septal occlusion. If you see the proximal occlusion, then you have an elevation AVR, AVL and V1 to V4, and the ST elevation V1 will be more than 2.5 mm. So you have these multiple criterias for us. We don't have to remember all those things, because nowadays we are directly going to take them for a coronary angiogram. But still, it helps us to, it's more fascinating to read about this to see the. And the next thing which I want to show is a serial ECG which I showed. This is the initial ECG at 11:52, which is normal, and subsequently at 12 o'clock you can start seeing a little bit of ST elevation. And then if you see, you can see here the frank ST elevation starts happening at 12:2 and 12:6. So that is what I was showing, that initial serial ECG monitoring is very important. Next 2 minutes, I just want to show certain mimics of this thing. So you have a 42-year-old male with syncope and profuse sweating. Anybody wants to see what is this? It's an ACS, anterior MI. There was a profuse sweating. Coronary angio was normal. Troponin was normal. That's not the case. It was actually a case of, see, you have a borderline positive troponin. Only he had a family history of sudden cardiac death in the elderly and just a minor CAD. So the diagnosis here is a Brugada syndrome. So this is the multiple patterns are there, which I'm not going into the detail. There are 3 types. There's a concave ST, and then you have a saddleback pattern. Multiple patterns are there. And this is another patient you have presented with a dyspnea. There was no chest pain, and here what you can see is, you can see tall hyperacute T waves and something like a sine wave pattern here. So this patient had hyperkalemia with potassium of 7.2. So this is again not an ACS. And this is another patient who had a shoulder pain, who had an old history of MI. Troponin was negative. And if you see, PCA was done 2 years back. There was no specific changes. There was a non-specific change. And if you see the echo, it showed a persisting aneurysm here, LV aneurysm. So these are all certain things which you don't have to hurry much into these things. And this is another patient where classically you can see, this is a ECG of a female who had left arm pain, sweating. You can have prolonged QTC T inversions in the anteroseptal leads. Yeah, obviously we will think this is going to be an acute MI. We should rule out an acute MI. But the echo showed a typical ballooning of the apex, which is nothing but a Takotsubo cardiomyopathy. These coronaries were found to be clean finally, and after a few days the ECG started normalizing, and after 6 months an ECG was perfectly fine. So this is nothing but Takotsubo cardiomyopathy, where it's a non-obstructive coronaries, only supportive care, and the long-term prognosis is good. So this is the same thing. So the take-home message is that it is of paramount importance to integrate your ECG data with the clinical scenario, and always try to achieve a quick door to balloon time without compromising the, keeping in mind the non-coronary etiologies also. So thank you.
Thank you, Prem. In spite of your bad throat, you are able to come and give a beautiful lecture about the various ECG features, including how to diagnose MI in LBB, paced rhythm, and also LVH with the case examples. Now, to add one more point, addition to that, changes in the inferior lead as well as anterior leads, not only the wraparound LED, but also when the LED is occluded distally, you can have a ST elevation in inferior leads as well as anterior leads.
Yeah, the first slide you were saying, I think you have put 60% sensitivity, or what?
Yes, sir. That's what.
Yeah, so that's the most important point. Don't trust the ECG alone. Yes. The history's got to be the most important. Risk factors, what kind of presentation it is, and serial ECGs. Many a times we would have seen classical chest pain ECG normal for 24 hours, 48 hours, and then suddenly a change comes back. The important thing is always compare a previous ECG with the present ECG. Any changes going on, acute coronary syndrome, and especially when the ECG is normal and patient has got a classical pain, you have to rule out left main. That's a sudden death and all is really associated with it. So we have to keep a watch on that. So anybody else want to say?
Any queries from the floor?
Practicing in a rural area is sometimes challenging, really challenging. We have very nice equipment in corporate hospitals, GE machines, Philips machines. Whereas in rural areas, you get ECGs from government hospitals where they don't take care of standardization. That's what I would like to tell my colleagues over here. Many a time the standardization is not correct, and either they get a very small complexes or very large complexes, and the medical officer there gets frightened and he refers it immediately as MI. So my suggestion to my colleagues is check the standardization every time, and also check your machines if the standardization is correct. Two, I've had many occasions where the patient comes with severe chest pain, classical angina, ECG is normal. When my echo shows classical hypovolemia, hypokinesia, do I need to thrombolize?
Yes, sir. When you have an evidence of ischemia, and especially in the periphery setting, definitely thrombolysis is definitely going to help you, because I mean this is what even way back in when Jayadeva, also my professor, used to teach me. He will say even for NSTEMI you thrombolize if you are not able to go take the patient to the cath lab. You assess the bleeding risk. If his bleeding risk is low, please thrombolize. Whatever burden of thrombus which is there, it is going to be reduced by the time you shift to the patient to a cath lab center. So when you have a documented evidence, probably this, especially the circumflex occlusion, sometimes it's very silent. You're not able to pick up in the ECG, or you may sometimes have to take a lead above or below, or you have to take posterior leads. If the patient's got a classical chest pain with a hypokinesia, then it's definitely an acute coronary syndrome. Slowly it may start evolving. You can very well thrombolize in the early stage.
Nobody's going to question me why you thrombolized a normal ECG.
I mean, if you don't have a cath lab in a center, nobody is going to question us for thrombolizing. I think when you have a documented evidence of a wall motion abnormality also.
Thank you. Thank you, Prem.
Good presentation, Prem. Sir, actually, for your recently we had a patient in our GH. The patient was not thrombolized, and the patient got developed via ventricular septal rupture next day. So the complications, if we are not thrombolizing, means the complications are more deadlier. Yeah, and for an information, the persistent ST elevation even after complete revascularization, look for pericarditis. We have to look for atypical pain, these pains and all. We miss pericarditis more for. That's the for information. Thank you.
Thank you, sir.
Anything from the floor? There's no more questions. We can move on to the next session.
Sir, thank you, dear moderators, for moderating the sessions wonderfully, and thank you, Dr. Prem, for a wonderful talk. Let me now invite our beloved Executive Director, Dr. Arun Palnisamy, to officially inaugurate the meeting. You can stay in dais.
Welcome, everyone. Thank you, all the moderators, faculty, all the delegates. It's been a wonderful occasion that everybody can spend their time on a Sunday, which everyone has very busy lives. I think that we do have important issues in cardiology, which we're going to be seeing forward in our future, which is why conferences like this are important. One is, I think I just had it yesterday, somebody was asking me, is cancer day incidence increasing? I said yes, or detection increasing. I said both is true. Same thing with cardiac. I used to work when I did my training at a geriatric center, everyone has to die of something, and everyone is living longer. So was that when the 2000s, when I finished my MBBS, you know, what was they saying? That you only had one cancer. You'll not get another cancer in your life. By 15 years, I've been seeing patients on their third cancer therapy, you know. Male very less always had prostate cancer. Then they had another cancer which was treated, and now they're on their third cancer. So like that, when you reach 100, all these diseases, all the heart diseases, diabetes for 40 years, which was relatively well controlled, but now you're in your year 20, 30, is now going to increase. So one thing I'm finding from all the electrophysiologists at their last conference was that they're all talking about everybody is watching the new cell phones, the new little bit wearable exercise wearable watches. They're now tracking heart rhythm. Everyone is now showing up to the doctor because they've gotten warning signs coming from their phones saying that they have cardiology abnormalities and they're detecting AFib. So now we're going to have an explosion of increased detection. Second of all, we're going to see a lot of AI come in. 20 years ago, if I were to go to US, they were already loading everything on a cardiology packs. As they correctly said, one of the best things you get with an EKG is compared to the old EKG. Half the time in the Indian setup, we don't have the old EKG somewhere. It's in a different hospital, it's in a different center, it's buried somewhere in the medical records file, and they're searching for the file. For the last time they did EKG was 10 years ago, and now they're coming. Now we're going to cardiology PAC system, and we're going to have everything, cloud-based. So even though KMCH is slowly starting, so when you get an EKG, the extra old EKG is going to be instantly available. And so it's going to start interpreting data, and that's going to make the cardiac diagnosis much easier. But we're going to see explosion of detection, as I said, wearables. Now that now we're actually recording, centralized recording of all these EKGs. So now you have a comparison record over years. So what is the old EKG? What is the new EKG? What is the difference? Is it a misplaced lead? And now you're going to have future is that I've been doing a lot of things. I went to a diagnostic conference. Everyone is talking about artificial intelligence. That means when we used to just have a PAC system, we used to have old EKG and new EKG. If somebody comes with a problem, we'll check the old EKG and the new EKG. Now we're going to have the computer automatically go into all our records, search your database of patients, and pull off the EKGs, the comparing old and new by themselves and detecting high-risk patients. Now, as you said, India is at a crossroads, as you said, rightly said. On one side, we have the government sector where the EKG machine is not even properly calibrated. On the other side, we're going into things where people are wearing high-end, their Apple Watch, 15 or something, and they're getting detected that way. So we have both people that's all going to show up at our door. So we're going to see an explosion in detection, and as we all age older and older, that person you survived the last MI, 15 years later from that scar tissue, you're going to have a lot sort of electrical abnormalities start taking place as small vessel disease starts to eat away at the other parts of the myometrium. So we all I think we need to constantly update ourselves. As I said, I don't know when the new technology is around the corner, but we are going to see a massive increase in cardiac disease. And this is all going to be key detecting what are all the changes that need to take place. Thank you all for attending on your busy Sunday. As I said, I know it's a little bit strained for everyone, but happy Sunday, and hope you have a wonderful sessions. Thank you.
So it is my pleasure to felicitate our beloved faculties and moderators. Let me invite our executive director to felicitate our faculties first. Dr. Ranganathan. Dr. Prem Krishna Anand. Dr. Jabir Abdullah Kuti. Dr. Ajit Tachil. Dr. K. Jaishankar sir. Dr. Shivakadasham sir. Let me also invite our moderators on dais. Dr. Prabhu Venkatesh sir, Dr. Ateep sir, Dr. Ramasamy sir, Dr. Sushil Kumar sir, Dr. Nambirajan sir, and Dr. Sujay. Let me also invite our TN Medical Council observer, Dr. Rajesh Babu sir. With this, we'll move on to the next session. Let me invite our new moderators for this session. Dr. Rahul, Dr. Sanjay sir, Dr. Chandrasekhar sir, Dr. Pradeep Chakravarti sir, and Dr. Palanisamy sir. There's a little change in our program. Dr. Shivagadasham sir will deliver a lecture on evolving evidence with ARNI, implication across the spectrum of LV ejection fraction. Welcome, sir.
Good morning to all of you. My thanks to KMCH Executive Director Dr. Arun Palanisamy, and a special thanks to Dr. Lawrence, who has invited me to give this lecture. As the Executive Director was telling, as the age of the patient increases, the longevity has also increased in our country. What happens is, previously we used to think if a person lives longer, he is prone to get cancer. Today, if a person lives longer without cancer, what he is going to get is cardiac failure. Cardiac failure is going to be the disease that is evolving into a very big scale. One of the papers say the incidence of cardiac failure in the age group below 60 years is only 1%, whereas in the age group above 70 years, where majority of the people go through now, is 10%. So we should know how best to manage the cardiac failure. The common garden variety of cardiac failure is what is called the HFrEF, heart failure with reduced ejection fraction. Most of the people sitting here are cardiologists, trainees, and physicians who know that today's dictum is when a patient gets discharged from the hospital to have a checklist whether we have instituted all the 4 pillars of treatment of cardiac failure. What are the 4 pillars? SGLT2 inhibitors, beta blockers, ARNI, and MRA, mineralocorticoid receptor antagonists. So these are very good when the patient has got a classical variety of heart failure with reduced ejection fraction. There are many people who get admitted with symptoms of cardiac failure, but what they have is a normal ejection fraction in the ER. When you check the echocardiogram, they have a normal ejection fraction. And this goes under the name of heart failure with preserved ejection fraction. So, when the ejection fraction is reduced, to less than 40%, do you have a pointer? When it is reduced to less than 40%, we call it as HFrEF, and when it is above 50%, we call it as heart failure with preserved ejection fraction. Can we get these things? See, our fundamental book Hutchison used to say, what the mind does not know, the eye does not see. So previously also we were getting cases, but the mind did not know that there could be an entity called cardiac failure with preserved ejection fraction. Today we get to see a lot of patients with preserved ejection fraction. Unfortunately, till today there are no drugs available directly. Only recently SGLT2 receptor blockers have been found to be useful in the management. So all that we do is they have a preserved ejection fraction, but we go and treat that comorbid condition. So we know the treatment for HFrEF, that is heart failure with reduced ejection fraction, and for HFpEF, we know we have only SGLT2 inhibitors. Now in between, we have a what is called a 41 to 49% heart failure with mildly reduced ejection fraction, and this is also common with people who have come with heart failure with reduced ejection fraction, whom you have treated and they have improved ejection fraction. So this category is both mid-range ejection fraction if you are going to find it for the first time, or it is improved ejection fraction if you have treated a reduced ejection fraction and he has improved to between 41 to 49%. What is the implication of treatment of these people? See, when you take a SGLT2 inhibitors, it is useful in all ranges. Now, are there other drugs like ARNI, which is useful? That's what we are going to see today. This is the Indian registry, the CSA Kerala registry, which clearly shows, if you look at the upper one, the black dotted one is no guideline guided treatment. Therefore, the mortality is highest. When the person with HFrEF has got what has been given in the guidelines, if you have continued the guideline recommended treatment, the mortality comes down to the lowest, the last one. See this when you do not follow that. So before the quadruple therapy, SGLT2 came, we had triple therapy, that is ARNI, beta blocker and MRA, and with the triple therapy itself, we were having very good improvement. So what is important is, you should have a checklist when the patient goes out to see that every recommendation is being followed. So whether it is a triple therapy or quadruple therapy, once we start everything, the mortality rate definitely comes down. Now, if you look at these things, in patients with LVF more than 40%, regardless of whether he has had type 2 diabetes mellitus or not, the Paradigm HF trial has very clearly shown that there is an the reduction of mortality by about 13%. Whereas if you use SGLT2, there is a reduction in mortality of about 21%. So what is important is, even in patients who have LVEF more than 40%, both SGLT2 and glyphosins, that is EMPA, DAPA and canagliflozin, are definitely useful. So percentage reduction in the composite of first event of cardiovascular death in patients with LVEF above 50%. If you look at the last two, the Paragon HF trial, which is also a ARNI trial compared with valsartan, shows a 6% reduction. So the reduction may not be robust, but it is still useful. Now, clinical facts about the heart failure with mid-range ejection fraction. Patients with heart failure with mid-range ejection fraction have multiple comorbidities, but the most important comorbidity is renal insufficiency and the similar incidence of coronary artery disease. Primary common cause of mid-range ejection fraction is coronary artery disease and has a high comorbidity burden with renal insufficiency in 26% of patients. The prevalence of heart failure with mid-range ejection fraction within the overall population of patients with heart failure is 10 to 25%. And why we should know this is, majority of patients who come to us years after the treatment for coronary artery disease, they may come for the first time for a routine checkup without much symptoms. And if you look at their echocardiogram, they may show an ejection fraction of 41 to 49%. Should we have to treat them with ARNI? The evidence is slowly evolving. Yes, they get benefited with exposure to ARNI. Now, phenotype risk of cause-specific outcomes suggest that CKD and IHD are prevalent in patients with mid-range ejection fraction. You can see the incidence of ischemic heart disease is slightly more in mid-range ejection fraction than in preserved ejection fraction. Similarly, chronic kidney disease is also more. Heart failure with the mid-range ejection fraction is a useful categorization of patients with heart failure and shares the most important clinical features of heart failure with reduced ejection fractions. Hence, it was suggested that the drugs that are effective in patients with HFrEF should also be effective in mid-range ejection fraction. And a substantial proportion of heart failure with mid-range ejection fraction patients resembling with reduced ejection fraction features have new ischemic events. So this is what we see. Patients come and get treated with us 10 years back for coronary artery disease. They have been on treatment regularly and majority of them irregularly. many of them stop the treatment. They come back with new ischemic events and their ejection fraction drops down. And these are the candidates we have to be looking for in the management of F with mid-range ejection fraction. Evidence shows higher risk in mid-range ejection fraction patients in the presence of coronary artery disease. If you look at the FREF, the incidence is only 58% number of patients, ischemic etiology, and the F mid-range, it is 56%, whereas in preserved ejection fraction, the risk is very much less. Now, the data backing sacubitril valsartan or ARNI in mid-range ejection fraction, we have had several trials after the 2014 trial. 2014, the Paradigm HF recruited people with less than 40%. The later trials, Paraglide and Paragon HF trials, included patients with mid-range and above 50% ejection fraction. Above 50% if you take, the ARNI does not show very much of an improvement. But if you take patients with 41 to 49% in Paraglide and Paragon HF, they got definitely benefited by exposure to ARNI. 5.48% improvement in LVEF with sacubitril valsartan in heart failure with mid-range ejection fraction. See, what our patients ask is, when they come for an echocardiogram, sir, does it show an improvement? They are not worried about the quality of life. The quality of life definitely improves, and then only the quantification with the ejection fraction improves. And sacubitril valsartan offer better LV dimensions. Reduction in LV dimensions is much better when you expose the patient to the sacubitril valsartan. You can see the valsartan group having 5 centimeters, whereas this is only 4.7 centimeters. When the volume LV diastolic dimensions come down, naturally the ejection fraction is going to improve. Now, lowers rehospitalization rate. ARNI definitely lowers the rehospitalization in mid-range ejection fraction post-AMI. You can see the reduction in sacubitril valsartan group to 7%, and whereas the valsartan group had 18%. So, what is important is the mortality reduction if it is agreeable. Why digoxin was thrown out? Because it does not cause mortality reduction. Whereas what are the drugs that have come to stay in are ARNI and later SGLT2 inhibitors, MRA and the beta blockers. Impact on clinical outcomes associated with renal dysfunction in patients with mid-range ejection fraction. We have already seen that patients with mid-range ejection fraction, they are more prone to have coronary artery disease and renal problem. You can look at the mortality in FREF and F mid-range, both are very high compared to FPEF. So, if you look at the renal dysfunction, sacubitril valsartan improves the EGFR in mid-range ejection fraction patients with CKD and coronary artery disease. Pre-treatment EGFR is 58 and post-treatment it has definitely improved to 66 ml. Sacubitril valsartan improves LVEF in mid-range ejection fractions, which we have already seen. That is why this talk definitely pre-treatment, this is GFR. Now, ACC guidelines recommends ARNI therapy in heart failure with mid-range ejection fraction and symptomatic heart failure with EF 41 to 49%. As usual, diuretic to unload the patient. Then SGLT2 inhibitor is class 2A recommendation. ACE inhibitor ARB ARNI 2B, MRA 2B and evidence-based beta blockers 2B. Even though beta blockers cause a phenomenal reduction of about 33%, MRA about 34%, ARNI about 20% reduction, still they are all in class 2B and SGLT2 is class 2A and diuretic in a patient with cardiac failure mid-range is about class 1 recommendation. Sacubitril valsartan may be considered for patients with mid-range ejection fraction to reduce risk of heart failure hospitalization and death. As usual, ARNI, beta blockers and MRA may be considered in patients with mid-range ejection fraction also. Now, sacubitril valsartan reduces NT-proBNP. One of the criterion is not only improvement in quality of life, improvement in ejection fraction, reduction in hospitalization for heart failure, and what is most important in the setting of acute setting is whether the NT-proBNP when you treat comes down or not. Definitely, meta-analysis has shown a reduction in NT-proBNP when you treat even patients with mid-range heart failure with ARNI. Improves the quality of life and reduces the risk of readmission and mortality rate in patients with mid-range ejection fraction. So how does it work? You can see this is the quality of life in patients with heart failure with mid-range ejection fraction, and you are able to see that it is able to work in all the ranges of ejection fraction from below 20% and at least up to 45%. So time to adopt guideline mediated treatment regardless of the ejection fraction, and this is the same slide. Over a range of ejection fraction, ARNI is helpful and useful. Paraglide HF trial, which I was mentioning, having a diverse population of ejection fraction more than 40%, stabilized after a recent episode of worsening heart failure. Patients on sacubitril valsartan saw a greater reduction in NT-proBNP than those on valsartan through 8 weeks. The latest terminology is, previously we had only acute chronic heart failure, chronic heart failure. Then came heart failure with reduced ejection fraction, heart failure with preserved ejection fraction, heart failure with improved ejection fraction. The latest one is mid-range ejection fraction. And the more later one in 2023 is, what is the definition of worsening heart failure? Worsening heart failure is a condition in which the patient has been on treatment for coronary artery disease and cardiac failure. Suddenly he comes needing an increase in either the oral or intravenous dose of diuretics or stepping up of ARNI. If a person comes with these symptoms and the treatment is increase in diuretics either oral or IV or a stepping up of ARNI dosage, then he is called worsening heart failure. So in all patients with worsening heart failure, the majority of them will have coronary artery disease associated, and majority of them would be in mid-range heart failure, and therefore all of them would require exhibition of ARNI in a higher dosage if they have been taking it already, or exhibition of ARNI if they are ARNI naive patients. So real world evidence also shows that statistically significant relative risk reduction in all-cause mortality compared with ACE inhibitor and ARB if you give them ARNI. So to summarize, it reduces the NT-proBNP, improves the cardiac structure and function, reduces the diastolic volume, reduces risk of mortality, reduces the risk of hospitalization, which is one of the main parameters that we look in all the cardiac failure drug trials, and reduces all-cause mortality. And therefore, as just to refresh ourselves, diuretics in class 1, SGLT2 in class 2A, whereas ARNI will become in class 2B for the treatment of management of patients with heart failure with mid-range ejection fraction. Thank you all.
Thank you for the wonderful presentation. Let me invite moderators to initiate the discussion and initiate questions from the audience. Thank you.
Very nice presentation. What are the side effects you come across when you're using ARNI? Number one. Number two, the patient has been already taking ACE inhibitors. Theoretically, if you are going to initiate ARNI, it is likely to have more of a bradykinin accumulation and a problem. How would you manage it?
Right. See, bradykinin accumulation clinically, I'm coming to the second question, is clinically manifest by a dry irritating cough. Majority of patients with ACE inhibitors would show that, that is at least about 5 to 10% of people. With ARB, you don't get that one. But similarly, when you start using ARNI, you don't get to see a sizable number or proportion of people getting the symptoms of bradykinin. You only get the good effect of bradykinin, that is vasodilatation, and therefore the improvement in reduction in preload, and therefore improvement in ejection fraction. And the first question that you asked is?
The side effects we come across with ARNI.
See, when ARNI was introduced in 2014 after the Paradigm HF trial, in majority of the lectures that we used to go, they used to say we are afraid to start because the blood pressure is 100/70. One of the most important thing with ARNI is, if you should not be chicken-hearted, you should be really lion-hearted. Start using them in 50 milligram half BD. And majority of them, the cardiac failure comes down, their blood pressure improves. And then you can slowly step it up to 200 milligram BD. Majority of my patients I have never exceeded 100 milligram BD, even though the guideline says 200 milligram BD. With 100 milligram BD, they all do very well. So the initiation itself is very difficult because majority of patients with cardiac failure will have a low BP, 100 by 70. I have started in most of the patients hospitalized pre-discharge when the blood pressure is 90, 70. Only thing is we have to be very careful whether we are going to have an hypotension. If the patient complains of postural hypertension in the beginning, we will have to tell him the modalities to say. And one more important take-home message is, you start the patient on ARNI, patient improves, but there is hypotension, reduce the dose of diuretic. They will be stabilized very well.
So when the patient is already on ARB or ACE inhibitors, is it right to stop the ACE inhibitors for 24 to 48 hours before you start the ARNI?
The guideline recommendation ever since the drug has been introduced is stop ACE inhibitor or ARB for 36 hours and then start it.
Sir, that's a wonderful presentation. My question is like ARNI as an antihypertensive agent, what is the data upcoming, sir? Because it has potent blood pressure reduction, which can reduce LV remodeling.
I won't call it as potent because even in, we are using ACE inhibitor for reduction of blood pressure. The reduction of blood pressure in HOPE trial itself was only 7 to 4 millimeters of mercury. Similarly, with ARNI, it is 4 to 2 millimeters of mercury, just like SGLT2 inhibitors. So I won't call it as a potent, but they are trying it out in resistant hypertension as an add-on therapy. But with all the calcium channel blockers, beta blockers, and the ARBs, we are able to reduce in most of the patients, failing which all of us have started using the alpha blockers.
What is the safest renal parameter? Creatinine allow one, sir. Second, once patients improved and stabilized, can I reduce the RNA level, sir?
Don't ever reduce the RNA level. Don't ever reduce. If you reduce, you will be in a problem. In a few patients, I have stopped RNA. They are all peripartum cardiomyopathy who have come on to above 55% ejection fraction. When they do not reach above 55%, it is only taking a risk if you reduce any of those recommended drugs.
What about creatinine level? Safest creatinine level?
Creatinine
High.
level.
Yes, sir.
Creatinine level, as I have told you, because less than 2.5, we are safe to give it. Okay. Because most of the nephrologists prefer it. Oh. Like they like ACE inhibitor and ARB. Even though the guideline says don't combine both, they are the only persons who would combine both and still be successful.
Thank you, sir.
Just regarding uptitration of medications, will you simultaneously uptitrate all the kind of anti-failure medications or go one by one?
I normally give very minor doses of beta blocker. So I don't uptitrate it. I either give 12.5 milligram of metoprolol or 1.25 to 2.5 milligram of bisoprolol. So I don't uptitrate it. And 25 to 50 milligram of eplerenone or aldactone, I don't uptitrate it. So with careful monitoring, and SGLT2 starting itself is non-diabetic 5 milligram of DAPA and or 12.5 milligram of EMPA. So what requires to be uptitrated is only mainly RNA with very due care on, as Sir has asked me, on blood pressure.
So not even the beta blocker, I mean the...
Unless the person has got a persistent tachycardia. Even then, we are worried about the BP. We add ivabradine along with the fixed dose of beta blocker. Unless the BP is very good, then you can go and increase the beta blocker. BP and pulse should be good.
Thanks.
In a post-infarction setting, ARNI, what do you think, sir? Starting ARNI. Post-antiretroviral infarct.
The Paragon HF trial was conducted in post-infarction patients just to find out the safety of ARNI, and it has been found to be very, very useful. Okay. In majority of patients, I have started using post-infarct patients when their BP is, as I told you, 170, when I shift them from ICU. And it is very, very safe. Thank you.
See, regarding the beta blockers, there is, it itself is a very big
topic.
discussion itself. Actually, sir said was correct in whenever your BP is low, low in the sense 100 systolic, but your BP crosses 100, you have to go up on beta blockers. I am a beta blocker man. Okay, so the thing is that, yeah, the target dose is very high. The thing is that you look at physiology, you look at cardiac output. So forget about all the data, forget about pulse, forget about your BP, all those things. What you are targeting in a HF ref is a cardiac output. So you have to get the cardiac output to the maximum. The two pillars which are must are beta blockers and ARNI. So not even AC inhibitor or ARB. Now with ARNI, AC inhibitor and ARB, we now know that they are not that useful. Okay, so it's beta blockers plus ARNI. Okay, so cardiac output first increases with beta blockers. You get the heart rate below 90. So once you go up on beta blockers, still your heart rate is below 90 and above 55, 60 should be okay. That's your target beta blockers. Then once you have sufficient beta blockade, like say get down the heart rate to 100, then you go up on your ARNI levels to the maximum. Because once you start ARNI, your cardiac output increases to great extent actually. The patients will be asymptomatic. You can even withdraw the loop diuretics. You can just be on the 4 pillars, whatever is needed. Many of my patients need only these 4. I have almost stopped using beta blockers in chronic, stopped using loop diuretics in chronic patients. So the notion is you have to go up on beta blockers and ARNI, depends on the situation. So if the heart rate is high, go up on the beta blockers. If your cardiac output is needed to be increased, you go up on the ARNI. That's a way to do it.
I would agree with sir. Slowly we can, once the patient is stable, slowly we can withdraw the diuretics. Because diuretics do not, they reduce the mortality, like digoxin. They are only to unload the patient. Instead, we can build upon the other 2 drugs.
Thank you, sir. Thank you for the wonderful presentation and discussion. If there are no more questions, we'll move on to the next session. Next session will be a panel discussion on dyslipidemia management. Let me invite Dr. Jabir Abdullah Kuti, sir, to initiate the discussion and let the panel and moderators be there to further initiate the discussion and thank you, sir.
Moving from a very life-threatening disease of the heart failure to dyslipidemia, which is mostly preventive, but it prevents and it saves a lot of life. When we look at the lipid therapy and prevention of atherosclerotic cardiovascular disease, we have 3 arenas. One is the lipid risk, the inflammatory risk, and the thrombotic risk, of which much efficiently treated is the lipid risk. And our concepts are now concrete. You keep the patient's milieu at a low lipid level from the very early period of life onwards to the longest period possible. So as long as the patient's milieu is exposed to the lowest possible lipid, the chance of atherosclerosis comes down. The chance of events also comes down. And we have an explosive exposure to new data in the last decade regarding the lipid control. Regarding the change in the concepts, the newer drugs, and the utility of the newer drugs. Newer drugs means we have been using statins, ezetimibe, and some of the newer new additional drugs. But now the tide is changing from a daily pill to a once in 2 week injections to once in 6 months injection to once therapy for a life. That is gene editing. The data came 2-3 days ago. You give a therapy forever, once in a life. His lipid, the PCSK9 production is inhibited completely. So we'll be discussing with the panel about the newer therapies in dyslipidemia with some conceptual changes which has occurred in the last decade. Dr. Lawrence, could you tell about the panel and the moderators?
The program will be like this way. I think Dr. Jabir will provoke questions and discussion among us. Dr. Jaishankar and I'll be part of that moderation, and panelists who are on the dais can also initiate questions and discussion.
And the floor can also participate. Somebody should keep the time, because once we start the discussions, we may forget about the time, and
timer is on, sir.
Time is there. Right. So Lawrence, why don't you lead this thing? LDL cholesterol, everybody knows, but just to start with, what is the significance of LDL cholesterol in atherosclerotic cardiovascular disease? I am fully aware that everybody knows now it's not the LDL cholesterol alone, it is the atherogenic lipoproteins. So what about the LDL cholesterol?
So I think one of the strongest data for any risk factor exists for LDL cholesterol. I think one of the linear relationship for a drug effect relationship also exists for LDL cholesterol. I think if you see other risk factors, we know diabetic control or a smoking cessation, all have a great data. LDL cholesterol has great data as a risk factor, and another excellent data, when you reduce level of LDL, you derive benefit. It's one of the unique risk factors among cardiovascular risk factors that you can modify, and you have a weapons to do it. The only problem with LDL cholesterol is understanding the risk. Unfortunately, a lot of us, and there are a lot of numbers exist in LDL cholesterol from multiple labs. We know there are labs which report 130 as normal. There are labs which report 100 as normal. And I think we have reached a stage where we don't have to have a fixed value for a LDL cholesterol level. Most of the labs, we have to initiate a discussion with them and tell them you have to give a number according to the risk. Otherwise, if you are not aware of all this, it's better to not to disclose a particular number to the patient, because you have a patient with diabetes who had a myocardial infarction. You do a lipid levels, patient comes with a LDL of 110, and when he's on a good dose of 80 mg of atorvastatin, you tell him that your cholesterol is not under control. He's wondering, normal is 130 minus 110, I'm well under control. I thought you will reduce the drug. Now you are telling me that you have to go up on the drug. So I think it's a primary importance is making patient and physician to understand the linear relationship which exists with LDL, and dynamic numbers we have to look at according to the risk factors.
Yes, because now the information is open to all. It's a world which is very close now. Everybody knows all information. The layman has a lot of avenues to get the information. So they always be looking at it now with the chat GPT and all. They give the questions, what should be a normal LDL level? Is Dr. Jaishankar, is something called a normal LDL? Absolutely. Everybody, some patients comes to us and say, sir, my LDL is normal.
Yeah.
And you are still treating me.
Yes. So what we have done in our hospital is we don't give the normal range for lipid profile alone. The others have a lipid profile, others have a normal ranges. For lipid profile, we have prevailed upon our pathology team that they should not give the normal range, because we know what is the risk, the ASCVD risk of the patient. Particularly if he suffers an event, we know lower the better. I'm sure you're going to be part of the discussion subsequently. So we're going to keep the LDL as low as possible, and we also know that it's not deleterious to keep the LDL as low as possible. So my take is LDL less than 100 for everybody. The moment he starts having an event or is a diabetic, I think we'll go on further, lower the better.
Any comments from the panel, please?
If a patient who's young and doesn't have any other risk factor, but has an LDL maybe slightly above like 120, are there any guidelines or scores, risk scores, and to say that we need to start him on a statin? Or
the panel has to answer. No questions from the panel.
You are the expert, so
the panel will be fired with questions and you answer. No, you come up with your question. I was just joking.
No, I mean, see, the younger patient with lower risk. But I mean, when do we start statin? If we see a LDL of like 120, we know it lower is better. But how do we convince him to start on statin, or should we not?
I was impressed with what Dr. Jaishankar said. His hospital has stopped using a value, that is a reference value for LDL. I think that is an excellent idea. As per the European Society, for a general population, LDL should be less than 116. That is their recommendation. That is for Europe. For India, as an ethnic group, we are more prone to develop atherosclerotic cardiovascular disease at a younger age. So I think he's right. It is better, and our lipid association guidelines are more stringent. They are keeping the LDL level a little more lower. So LDL less than 100 for a general population may be better in the long run to prevent atherosclerotic cardiovascular disease. That may not be with drugs. That may be with a lifestyle modification. It is not drug to all, but lifestyle modification to all. And depending upon their risk, that is a situation where you assess their risk. And if they belong to a high risk category because of other parameters also, other risk factors, then depends. If it's a high risk, then they may have to undergo lipid lowering therapy for long.
Sir Jabi sir, yeah, most of the Indian population, the LDL will be normal. Atherogenic lipids, the triglycerides will be high, and the HDL will be low, most of them. So with the Lipid Association of India pointing post ACS more towards the LDL numbers, when you have an extremely high risk, they have classified Lipid Association of India.
Their cutoff is 30.
30. Yeah, that's what I was about to say. With the moderate risk, less than 50, and with the extreme high risk, you need to reduce to 30. So numbers also matters. Numbers also guide the treatment.
But though it is often said that the Indian population do not have a high LDL, it's always high triglyceride, it's always low HDL. When we come across our patients, it is not like that. They do have high LDL, they do have borderline HDL, may not be very too low HDL, and of course some patients have high. It's a mixed thing, and it depends upon where the patient is coming from, which type of hospital we are seeing them. We don't have real data from what is the urban, what is the rural, what is the tier 3 city seeing, because we all are seeing all complicated patients with established atherosclerotic cardiovascular disease. But physicians may be seeing patients who don't have a disease. So it depends. Shall we move to the next question? Otherwise, we'll be sticking, we'll stuck on. So we are coming to it. The risk-based LDL cholesterol, what is it? Why is it important? How to stratify the risk of an atherosclerotic cardiovascular disease patient? I think the panel can take it one by one. Your comments first, then we'll go to the final comments by Dr. Jayashankar and Dr. Lawrence. And if any questions or comments from the audience, we welcome it.
Now, hyperlipidemia is one of the curse of modern civilization, particularly for Indian populations who are much more susceptible to hyperlipidemia, resistance, and other complications. Now, as people have discussed, if you just tell the patients regarding LDL, people don't accept the implications, what they're likely to have onto the heart or the vascular system. If you tell them to bring it down by the therapy, they just keep taking it for a few months' time and then stop it for the simple fact that they are quite comfortable. So the guidelines keep changing, less than 100, less than 70, or even less than 50, depending upon the underlying problems. So if the patient has got a atherosclerotic cardiovascular event, definitely we have to initiate with a high statin therapy. Apart from that, lifestyle modifications and additional control of the comorbid situations like diabetes and hypertension as well. Most of the times when you, as a physician, I'm seeing it, if you initiate the treatment, they forget about the lifestyle and the dietary control.
And drug is not a shortcut to avoid lifestyle modification. It should be complementary to each other.
Yes.
And two, what I call terminologies I would like to share is LDL is now considered to be a vascular toxin. It's a vascular toxin. And our Lipid Association guidelines, their editorial which came in JAPI, we declare war on lipids. We declare a war on lipids. That was their comment which came after the publication. So what about the rest of the panel?
So, any patient with risk factor, I think LDL target should be made very stiff. We should give more importance than the other control population, and the risks and benefits should be clearly explained to the patient, because they just think it has a value, but
this is the answer. Okay, a revision. This is the ESC guidelines, how they classified it into risk, the extreme, very high risk, extremely high risk, and all these things. So anybody with atherosclerotic cardiovascular disease is a high risk. Diabetes with more than 3 risk factors, or diabetes with a target organ damage, severe CKD, patients with familial cholesterolemia plus additional risk factors. So, and a score risk of more than 10%. The Lipid Association guidelines is more stringent. And if we see all these guidelines, I think it's difficult for the human brain to comprehend all these things together and keep it there. Okay. So, what do you all think? What should be our cutoff in atherosclerotic cardiovascular? Established disease, without established disease, but multiple risk factors who are prone to develop disease. I think treating people who are prone to develop disease is also important because we can prevent an event and a death.
So the lower it is best, but still I think if it's a proven cardiac disease, it should be less than 70. And if it's more than 2 to 3 risk factors, it's less than 100. That's my take on that. So
Any
Prefer established risk cardiovascular. It should be 50 to 70, less than 70. And people at high risk also, I would like to maintain at a similar range of 70. But with the risk factor, lower is possible. But sometimes if I'm not able to achieve less than 50, that's okay. Around 50 would be my target.
Without risk factor, I think 100 should be all right for subcontinental people. And the multiple risk factor, I think should be around 50. Is it practical, sir?
Practical. It's practical. And one thing we have seen is majority of the patients, our patients, their lipid comes down with lifestyle modification plus drug. And even with smaller drugs, doses of the drugs, their lipid level comes down. But there are certain patients, a subgroup of patients whose lipid levels do not come down with the standard therapy. That's where the new drugs comes in. So the panel, I think they have all of them have the opinion that it all depends upon the risk, and the risk is high, the lower should be the cholesterol. So it all depends upon the risk and then the number. What's your final take on this? What is the number for established and non-established atherosclerotic cardiovascular disease?
I think lower the better. I go up to 40 on a very high risk patients. The problem with, as you told, the problem is not with reduction. Problem is making patient understand, because our patients fortunately respond pretty well to drugs. You could see a LDL of 170, 160 dropping to below 100, below 60 with 40 mg of statin. It's not very uncommon in our patients. I think excellent response to patient. The problem is the moment you drop below 70, 100, that level, very difficult to make your patient aware. I think the most important thing from the number point of view comes, from my point of view, making people understand. I think one step forward, what Dr. Jaishankar did is an excellent step, where you don't mention the numbers so that that number is with you. So you are the person who takes a call on what is the number for the particular patient. Maybe that for every particular patient, depending on the risk, you stick a number on the prescription or on the thing, so that the patient understand that his number is different from the number what is given in the lab. So I think more important is for us to realize the number. And for me, I go below 50 for a high risk patient, and it really works. I think we have data. It's not like we have data where we could see melting of atherosclerotic plaque with good cholesterol lowering.
Yeah, I think we had a fair discussion on this. The important thing is how to motivate the patient. The moment he has 1 or 2 events, it becomes very easy to motivate. Then you can up titrate the medication. But then if we are convinced that this is the number the patient requires, if we desire, then we can definitely achieve it. It depends on how we prevail upon the patient.
The number is important because it's a simple thing that the patient understands.
I mean, we have something to express ourselves, and then that's some target to achieve. Otherwise, he's not going to follow what you say.
Very, very, very difficult to motivate them to keep the patient on drug, especially the laboratory people. Now, one problem that we are facing is whenever the laboratory people sees that the LDL cholesterol is below their cutoff value, they'll tell the patient, go to your doctor and say that it is low. So I always tell my patients, nobody is going to develop a problem because of a low cholesterol. You are all going to develop a problem because of high cholesterol, not because of a low cholesterol. Because we have data that extremely low level of cholesterol, LDL cholesterol up to 10 milligram per deciliter with PCSK9 inhibitors, no issue. Not adverse effect. So what is the gap in the current lipid lowering?
So the thing is making the patients understand, because if it's going to be hypertension, diabetes, the impact is immediate, so they understand that it has to be low. But in lipids, it's not like that. It takes time to show the effect, so they don't understand why it's so important to reduce the lipids.
And also the social media sending a lot of publicities about there is nothing called cholesterol which is producing heart attack. It is not a cholesterol that is producing heart attack. The LDL cholesterol is all a humbug created by doctors. It's all industry driven. So a lot of things are going on in the this social media. That also keeps a big gives us a big problem. Our half an hour is gone. 20 minutes. Okay. So the current gap in the current lipid lowering, I think the patient related issue is one thing to make the patient understand. Second thing, there is a group of people whose LDL cholesterol is not coming down with the highest intensity of statin therapy. And there are other lipoprotein molecules, atherogenic lipoprotein molecules, which also has to be addressed because it is the total risk provided by the atherogenic lipoprotein. So, Lawrence, you comment on this thing, early and aggressive lipid cholesterol lowering, because it's all same. We are telling the same thing under different contexts. What is its significance and what do the guidelines recommend?
As we were discussing so far, I think the moment you understand the number, it becomes easier for you to look at the drugs. We have reasonably good number of drugs available right now. I think 3 or 4 drugs which are pretty potent. Statins followed by ezetimibe and peptidic acid and PCSK9 inhibitors in multiple forms. So you have weapons to attack. Only problem is you have to know the number. It's very important for you to do reasonable number of measurements to keep patients also within your loop. So when the patient has a lifestyle modification or you have started a drug, do a lipid profile sooner, maybe another 2-3 months time, and show the patient that it's working. And I always feel that whenever you start a drug, it has to work for the patient to believe in the therapy. You start a drug at a very low dose, and patient also puts all his effort in and comes back with the lipid profile which was 150, and he has done everything. LDL is now 130, 140. So yeah, he will lose hope in the therapy and you. So the early aggressive is reasonably important. You have to go with a reasonably good dose. Lot of time, if you feel like the levels are pretty high, you can still use combinations. I think in India, one big advantage is we have a good combinations available. Now we have a statins 40 mg with ezetimibe available now. So it's a pretty potent drug. You can bring down LDL to your desired level in a very short period of time. So being aggressive in early part helps you and your patient to believe on the therapy. Like hypertension, in lipid lowering also, when the patient puts an effort, takes a pill, it has to show in his report. So you have to be little aggressive in the early part so that you show the results to the patient so that he believes in the therapy. Because the only thing which you are going to show the patient, as Dr. Sanjay pointed out, is a number. Because unlike other therapies, you are not going to see an immediate benefit or effect from lipid lowering. Only thing your patient sees is a number. The moment you see a good number, he believes in the therapy, his adherence improves. So I go a little aggressive in the early stage itself. That helps you and your patient.
The highest risk is the patient with an acute coronary syndrome. We should hit them hard to keep the LDL cholesterol below 55, and if there is a recurrence, it should be less than 40. Highest dose of statin, which produce at least 50% reduction in LDL cholesterol, 40 milligram rosuvastatin or 80 milligram of atorvastatin. Reevaluate at 8 weeks. If it is not in the desirable range, add ezetimibe. If not improving, think of bempedoic acid. Not sure whether it is guideline recommended. It is not in the current guidelines, but it is some off-label indication if you are going for an oral therapy. Or the guideline recommendation is PCSK9 inhibitor, which is injection once in 2 weeks, costly 22,000 rupees right now. Then the newer drugs in pipeline like inclisiran, which has to be taken only once in 6 months. So this is the current guideline recommendation. So what is combination lipid lowering therapy? So these are the combination lipid lowering therapy. Can we go first line lipid lowering therapy? Because mostly this is all centered around acute coronary syndrome. not the primary prophylaxis. It's the secondary prophylaxis. Patients with atherosclerotic cardiovascular disease. Can we go for a lipid lowering therapy as first line combination?
So I would initiate a high intensity statin, as you said, rosuvastatin 40 or atro 80, and reassess them. And if I'm not able to get a 50% drop in the LDL values, then I would think it's a logical decision to add a add-on therapy. My general practice and my view is like start with high intensity statin, then adding a partner therapy in the follow-up if needed.
I'll put a hypothetical question. If the patient you are seeing acute myocardial infarction, day one, the lipid profile, the LDL cholesterol is 250. The 50% reduction will take him to 120 in 4 weeks' time. But it is far above the current recommendation or our goal. So will you straight away start on a statin plus ezetimibe, or you give a PCSK9 inhibitor with certain small data available like Evopax?
I would prefer only high intensity statin because the pleiotropic effect of statin is more higher than the add-on therapies. So until there is no response, I would prefer to stick.
Is there any situation where we start straight away combination therapy?
So
In hypertension now we start straight away combination therapy. In diabetes we start straight away combination therapy because you set a goal, and if the current level of that particular problem is much above your goal level, then you go for a combination therapy. I think lipid is also going in the same direction. Initially it was hypertension, then it became diabetes. Now the third thing to follow must be the lipid. What is your final take on this?
It's definitely. I think the number what you quoted is very unlikely to respond to a statin alone. So you are going to need another drug to start with, because we know acute coronary syndrome. The problem with acute coronary syndrome is the initial recurrence in first 4 to 6 weeks. So we know very well that there are high incidence of recurrence in initial days with acute coronary syndrome with such a high LDL levels. In this particular patient, definitely I would go for a combination to start with, at least an ezetimibe. If it is not a PCSK9 inhibitor, at least an ezetimibe to start with, because this with the 80 mg statin we will reach in a best possible scenario also around 100 to 120. So I will prefer a combination in this kind of patient to start with.
Jabir,
so I think
Jabir, I will go one step further. In the scenario that you had given, acute myocardial infarction, LDL cholesterol more than 100, I will discharge the patient the high dose of rosuvastatin, ezetimibe, and in the ICU itself, I will start him on one first dose of evolocumab.
I fully agree with you. I also do the same thing, and I may not continue it for a longer period of time.
I think both of us follow the same thing. We give 2 injections only. Now I give 4 injections if the patient is admitted, because you write 420 milligram. The insurance gives 3 vials.
3 vials. So we give that injection.
Yeah.
And it will reduce we have looked at the data, our own data. It reduces the LDL like anything. And by 4 weeks time, 4 weeks time, their LDL is below 55, then the drugs will take over. That's not in the guideline. I fully agree with you.
That's what I wanted to.
Whatever you have said is in the guidelines. But this is our judicious approach.
Yeah, ESC guidelines says high dose, high intensity statin. They even don't say high dose, they say high intensity statin. And recently, the lipid guidelines also has come like if the LDL is more than 400, the 2023 ESC guidelines has said, if LDL is more than 400, go for a combination therapy. If it is less than 400, go with high intensity statins. Then only you go for a add-on statin. That is the recent 2023 lipid guidelines by ESC.
So diabetic dyslipidemia, how to go ahead? And anything particular with diabetic dyslipidemia? The diabetic dyslipidemia is basically a high triglyceride, low HDL, intermediate level of LDL.
Hypertriglyceridemia is a dominant factor, particularly in diabetes, and along with that, obesity as well. So as I told you earlier on, lifestyle modification and tight control of diabetic value to near normal. So most of the times if you just start the patient on statin, people don't accept it because they have come for the treatment of diabetes, we are targeting onto the statin. And I'm a vegetarian, I don't take much of fried items and everything. I said, Indian population or Indian subcontinent people are more liable to get a genetic background. So whether you like it or not, you are likely to have it. Probably you are gifted from your parents or grandparents. So we have to target on both triglycemias as well as the LDL levels. Apart from treatment, I will go for a high dose of statins, plus or minus STM, depending upon the side effects. Probably, I haven't come across any muscular events with statin therapy.
I think he's absolutely right. And I must put it in this way. A diabetic patient comes to you, ask, are you a diabetic? Yes, you should be on statin, no doubt. Unless you are at too low risk, for example, a patient who is less than 30 years, diabetic, no other risk factors, maybe. Anybody above 40 years, diabetic, you should be on a statin. Then what intensity of statin you require, that depends on the risk. If there is atherosclerotic cardiovascular disease, high intensity. Multiple risk factors, high intensity. Target organ damage, high intensity. More than 10 years diabetes plus one risk factor, preferably high intensity statin. So diabetes means along with the anti-diabetic medication, one mandatory medication should be a statin. Then regarding the triglyceride, despite the use of high intensity statin, control of LDL, the triglyceride remains high and the HDL remains low. Would you like to consider adding some other drug or tightly control the diabetes plus exercise plus diet? Because these three are more important in controlling triglycerides rather than a drug. Dr. Jayaprakash, will you add a drug? For example, now the icosapentane has come.
Yeah, before, not a fibrate.
Fibrate, I will.
Yeah, all the time. It's low HDL and high triglyceride. The only problem is risk of myopathy. High statins with fibrate. Then we can look at the newer drugs. Otherwise, first to fibrate.
When we start fibrate, always it is the statin first, and when we combine statin with fibrate, always keep the patient under surveillance for muscle symptoms. Some people, especially those who are hypothyroid, females, lean people, elderly, those with renal dysfunction, they can go in for a rhabdomyolysis. Mechanism of action of PCSK9 inhibitor therapy. Could you make it a little simple for the audience?
See, I think the most important factor in, we all know it's LDL. LDL, what we are looking at. What we are looking at is the LDL receptor again. So, we want to make hepatocytes to be more aggressive in taking LDL in. The way to achieve is you knock off the PCSK9. So, the way to knock off PCSK9 varies. Now, we have entered an era where we are going to have a gene editing where completely knock off the PCSK9 gene forever. So, we have now other drugs which work at a multiple levels to take care of this PCSK9. So the number of injections or number of drugs depends on how effectively you knock out. So if you knock out for a longer duration by translation level, you can give the drug at 6 months or 1 year, like a newer drug which is inclisiran. So if you are going to gene edit for a life, if you are going to do a shorter term arrangements, then you are going to require it for a once in 2 weeks. So ultimate aim is take out PCSK9 so that your LDL will go into the hepatocytes and will get processed, and you don't get a circulating LDL in the circulation as low as possible. That's a simple concept of PCSK9, and we have multiple ways to do it, and more effective ways are emerging.
Absolutely, because PCSK9 destroys the LDL receptors. PCSK9 plus LDL receptor plus LDL goes to the lysosomes. Normally, the receptor should go back to the hepatic surface. But here, if it binds with PCSK9, that is destroyed forever. So the LDL receptor level comes down, the LDL goes up. And now PCSK9 is an extremely important target to keep the LDL quite low. You give monoclonal antibody which prevents LDL cholesterol binding, receptor binding of PCSK9. It reduces LDL cholesterol by 60%. Combined with the high intensity statin and ezetimibe, it can reduce LDL cholesterol to the tune of 85%. So it's an important therapy, but not for all. How safe and effective this therapy is? We'll ask I think the questions are on, and we are going to conclude it soon. So this is a newer therapy. Injectable monoclonal antibodies once in 2 weeks. Injectable small interfering RNA. What we are going to do is we give a drug which inhibits the RNA translation of synthesis of this protein. So the protein is not synthesized, PCSK9 is not synthesized. That is inclisiran. It produces 50% reduction. We don't have a clinical outcome data, but the LDL cholesterol comes down by 50%. Then other newer therapies like gene editing is coming, which knocks off the PCSK9 forever. A single therapy for lifelong. So what do you think? How effective these therapies? When do you use it? How often do you use it? You brought the most important point which we didn't touch. Statin intolerant patients, truly statin intolerant patients, high risk, two group of high risk patients. One, secondary prevention, patients with atherosclerotic cardiovascular disease. Second, familial hypercholesterolemia who are at high risk, very high level of cholesterol which is not coming down with statin. Statin intolerance, you try ezetimibe, but only at 15% reduction. You try bempedoic acid, another 20% reduction. So if we need a 50% reduction, we have to resort to PCSK9 inhibitor. Only thing is, as you said, it's cost. 22,000 rupees per injection, twice a month, once in two injections a month. Very few people will afford it. And how long is a question. All these trials, they took it to 5 to 7 years. So it must be long-term, long injections, which I don't have a single patient on such long therapy, but I have patients on shorter therapy with PCSK9 inhibitor. No side effects, some itching around the injection site. Otherwise, the only side effect is the pocket toxicity. Otherwise, no other toxicities.
Jabir, one additional point for diabetic dyslipidemia. Majority of them come with high triglycerides, as we have discussed. There are many patients who have a triglyceride level of around 1000. Now, in most of these patients, I had found it to be useful to add a statin, add saraglitazole 4 milligram. There is a tremendous fall in triglycerides within 3 months' time. So I think we should remember saraglitazole also, because majority of diabetic patients control diabetes, had saraglitazole. That is also useful for the associated NAFLET.
Extremely important point. We didn't discuss the saraglitazole, which is a pure Indian molecule, which is a PPA gamma agonist, partial agonist, which can reduce the. One thing I have seen is there are hyper responders, there are poor responders to this saraglitazole. There are responders whose triglyceride dramatically drops down. That also is a little costly drug. So that is 4 milligram a day, which can, one thing is very safe to add on to statin. That's the most important thing. It can be safely add on to statin. So I think it's the end of the session. So we'll have the final comment from moderators, Dr. Lawrence, Dr. Jayashankar, and then the panelists, your comments. Any one or two questions or comments from the audience can be entertained.
Yeah.
Yes. Right now, we don't have recommendations regarding lipid profile. I think that it's better to have one lipid profile by the age of 12 years. But treatment, again, for the cutoff, because I have a few pediatric patients who have familial hypercholesterolemia, the LDL around 400. Right now also there is no license for using PCSK9 inhibitors. So lipid lowering therapy is usually drug is indicated after 10 years. Up to 10 years, no recommendation for lipid lowering therapy. But atherosclerotic cardiovascular disease, familiar hypercholesterolemia patients, their children should be screened quite early. And it's very difficult to treat children for lipid abnormalities. Not easy task. Yes.
So in the case of diabetic with dyslipidemia, that is a triglyceridemia, as the sir pointed out, what is the first line of treatment?
Statin. Statin. Yeah. First line, I must say, very, very tight.
Fibrates.
Lifestyle modifications, because triglyceride depends upon the lifestyle, the food, exercise. The food and exercise extremely important to reduce the triglyceride concentration. The first is always statin.
Where LDL is normal.
The statins, LDL, you come to the goal level. And once you come to the goal level, then it is either a fibrate, icosapentine, or a saraglitazole.
Thank you very much, sir, also.
I think it's a very...
One question.
Sir, I'm Dr. Mala Mahalakshmi, physician. We take care of acute coronary syndromes. So in the setting of acute coronary syndromes, we see lipid profile highly elevated like an acute phase reactant. So are we addressing the high lipid profile, or are we addressing the inflammation? Because we are giving high dose statin for its anti-pleiotropic effect, basically. That, are we targeting the lipids as acute phase reactant or as an anti-inflammatory effect in the setting of acute care, because the lipid profiles will be stable. During acute coronary syndromes, will shoot up sky high like acute phase reactant. Can we take it in that sense?
In fact, in the setting of acute coronary syndrome, the lipids drop rather than it elevates. The LDL drops. The triglyceride may remains a little high, but rather the LDL. So there was a previous recommendation that you should not look at the lipid profile in the vicinity of an acute MI.
So what is your recommendation?
Two things. We are looking at the three targets: lipid, inflammation, thrombus. So thrombus we give antiplatelets, and antithrombotics. The inflammation right now we are not targeting. We look at the HSCRP.
Yes.
To know the HSCRP, and we have data that the inflammation is also taken care of by lipid lowering therapy, especially statin. We have data with the Jupiter trial, and now we have data with monoclonal antibodies. The Canto study, which used the canakinumab, they found that if you reduce the HSCRP along with the LDL cholesterol, the event can be reduced. Now we are into a few trials with a drug called sitivelcimab, which is also another monoclonal antibody against interleukin 6, which reduces the inflammation. And soon we are going to enter into a study with acute coronary syndrome. So acute coronary syndrome, it is not only the pleiotropic effect. We have to keep the LDL cholesterol low, less than 55. It is not an acute phase reactant. It is the pathogenic molecule that produces atherosclerosis or promotes atherosclerosis. It promotes further events because there is a hot plaque inside where the lipid plaque, the lipid-rich plaque inside, there is the LDL cholesterol. So we have to passivate the plaque by keeping the LDL cholesterol too low.
So what is your take on lipoprotein little a molecule monitoring and apolipoprotein
Right now
ratio?
there is, the only recommendation is you do a lipoprotein A. And do we have any effective modalities to reduce the lipoprotein A? PCSK9 inhibitor, which reduces it by 25%. Now new molecules coming up. There is a new antisense oligonucleotide molecule. The study is going on, which can produce 85% reduction in the lipoprotein little a. It is piclacerin, which is very difficult. Pelacarsin. It is pelacarsin. So antisense oligonucleotide is coming up. Then monoclonal antibodies are coming up. Then the ANGPTL3 monoclonal antibody is there. So these are going to reduce lipoprotein little a. We had niacin, which reduced the lipoprotein little a, which was found to be futile in the clinical trials. So lipoprotein little a more than 50 seems to be dangerous, but how to reduce it, we do not know. And one more thing is the PCSK9 also goes up as a in acute myocardial infarction. And when we treat with statin also, the PCSK9 goes up. So there are a lot of gaps in our understanding and how to manage it. As you rightly pointed out, acute coronary syndrome, we look at the lipid, we look at the inflammation, we look at the thrombosis and attack all the fronts.
So do you also monitor apolipoprotein levels?
There is a lot, now the guideline is for apolipoprotein B also. In the highest risk, you keep the apolipoprotein B below 65, but the treatment is same. No difference in the practical management. So apolipoprotein B for a population should be less than 80, and for an extremely high risk, it should be less than 65.
Thank you.
Thank you, sir. I think we are soon going to have inclisiran in the market. Can you introduce that to our audience, sir?
So inclisiran, the inclisiran is the small interfering RNA molecule which prevents the mRNA translation of the message for synthesis of the PCSK9. So it's a genetically mediated effect. So we are attacking the protein synthesis, not the protein. PCSK9, the protein PCSK9 is there, its binding is inhibited. Here we are inhibiting the synthesis of PCSK9, the PCSK9 level will come down. This is usually the studies I am involved is, what we give is first dose, after 3 months another dose, then once in 6 months the dose. All the patients, they don't have any side effect. We are not, as investigators, we are blinded to the lipid profile also, so I do not know what is the amount of reduction. The Orion group of studies have found that the reduction is by and large it is 50% reduction. So it produces a significant reduction, and it's a fantastic thing. You don't have to have an injection once in 2 weeks. You give an injection, forget about it. It's just like taking a vaccine, influenza vaccine or a pneumococcal vaccine. In fact, the lipid vaccines are also on the way. So you give an injection, forget about it. After 6 months, another shot you take. Only thing is the cost. We do not know what is the cost. It's soon going to be introduced by Novartis in India. I think it will hit the market if people can afford it. At what price they are going to introduce it, we do not know.
Sir, thank you, sir. Thank you for a wonderful session, discussion, and all the panelists and audience. Let me now invite Dr. Sivatasam sir to felicitate our moderators.
And let me thank all the moderators, the panelists, as well as the audience to be a part of this symposium, which is an extremely important topic for the prevention of cardiovascular disease. Thank you so much.
Thanks, sir. Dr. Rahul. Dr. Sanjay, sir. Excellent, sir. It's good, sir. So, Dr. Pradeep, Dr. Palanisamy, sir, and Dr. Chandrasekhar, sir. With this, we'll break for tea. I think we are running little late. So, we'll have a 10 minutes tea break, followed by the session on syncope. So, if it's taking more than 10 minutes, please take your tea inside and we'll have tea inside. Okay, thank you. So, we are assembling back on 11:40. Dr. Krishna Kumar, sir, Dr. Jagadishwari, madam, and Dr. Vikram Vignesh and Dr. Saravana Babu.
Thank you, Lawrence. Good morning, everyone. So, syncope. So, let us talk something about syncope. Syncope itself is very exhaustive in itself. So, I will put forth some points to make life easier for all of us who deal with syncope patients. Syncope patient per se, it takes at least 30 to 45 minutes of my time in my OPD when a syncope patient comes. So, you have to prepare yourself to spend that much time to find a reasonable diagnosis in any syncope patient. These patients can't be dealt with in 5 minutes. So, prepare yourself to spend at least half an hour with them so that you can come at a diagnosis, because 30% of the adults will have syncope at least once in their lifetime. Cardiac syncope is a marker for mortality, and then in spite of extensive investigations, 40% of the syncopes will still be undiagnosed. But most importantly, you go back to your MBBS days, you take a proper history, you can come to the diagnosis in 50% of the patients. The key is when the patient reports to you. When the patient comes to you the same day or the next day, you are most likely to hit the diagnosis quicker, faster, and correctly also. So, what is the mechanism of syncope? You know all, ascending reticular activating system, no neurology here. So, that gets compromised by hypoperfusion and the patient loses consciousness transiently. So, what are all the key steps? First is to decide whether is it really a syncope. Second, to come to a conclusion as to what could be the etiology. Third is to decide whether the patient has any other cardiac illness and what is his future risk of recurrence for syncope or mortality. These are all the 4 steps which we need to do when evaluating the patient for syncope. So, first question is whether the loss of consciousness is definite, whether it is there or not. Transient, rapid onset, short duration, spontaneous recovery. These 3 things has to be there to prove that it is syncope. So, what is rapid onset? It should be less than a minute. Short duration of the course, which is few minutes, less than usually 5 minutes, and there should be a complete spontaneous recovery. So, these 3 things should be there to say that it is syncope. But the first thing is that to decide whether it is syncope or it is a syncope mimics. This slide is little crowded, but it is an important slide because the commonest differential diagnosis is seizure. So, in seizures you have trigger, triggers are usually present in syncope, that is situation, either blood or smell. which is very rare in seizure. Prodromes are present in syncope, blurred vision, nausea, sweating, abdominal discomfort. They become pale and become flaccid and then fall down. Late myoclonus is a feature of syncope. Very rare to have automatisms. Tongue bites is even rarer. Usually the eyes are uprolled, no postictal state. So this are the features of syncope. Whereas for seizure, they are cyanotic, they become tonic. Very early in the event, you have tonic-clonic movements, and frequent tongue bites automatisms are there. The lateral gaze is common. You will open the closed eyes, the eyes will be laterally gazed, fixed gaze, sometimes nystagmus may be there. Postictal state is very common in seizures. This slide is very important because the commonest DD is the seizure which you have to differentiate. Then syncope as a cause of TIA, unlikely because the ARAS is situated in the posterior aspect. So the TIA has to come from a posterior circulation, which is very rare because two vertebral arteries are there which go and form the basilar artery. Focal neurological deficits, signs like ataxia, oculomotor palsies, nystagmus, and pharyngeal palsies will tell us that problem is in the posterior circulation and not a syncope. Hypoglycemia, it is not a syncope, it is hypoglycemia coma because it is long lasting. Sympathetic symptoms like tremor, sweating, and delayed meals history will be there, and then post recovery confusion is very common in hypoglycemia. Psychogenic, because this syncope happens in young people, you have to be aware of the psychogenic behavioral problems. Multiple frequent episodes, they usually show a slow collapse rather than a rapid fall. It happens mostly when people are around. Significant impact trauma is very rare. Eyes are usually closed, and when you open the eyelid, they spontaneously roll the eye upwards. Lifted limb falls and then stops midair and then falls again. That says that the patient is not fully unconscious. No bowel and bladder incontinence. Recovery is prolonged with no postictal type confusion. So this you have to remember. Cataplexy, it is even rarer, is a manifestation in narcoleptic syndrome. No actual LOC happens. Loss of postural control with unresponsiveness to external stimuli is the clinical presentation. Usually it happens after laughing out loud or cry, and then they will have a slow slump to the floor. That's how the cataplexy behaves. So these are all the syncope mimics which you have to differentiate from a syncope. Now let us look at how the common variety of syncopes behave. So this is a different classification rather than putting it all in list. So the key is low BP. You have to look at the center. Low BP and then global cerebral hypoperfusion. The cause could be either low cardiac output or the peripheral vascular resistance is very low. Let us finish the cardiac aspect. Arrhythmia, structural disease, and the other causes of cardiac syncope. Next is low peripheral resistance because of autonomic system imbalance. Yeah, somewhere in between, a combination of both, you have reflex syncope and then syncope secondary due to autonomic imbalance, and then inadequate venous return related syncopes. These are all the how you classify based on pathophysiology. Why pathophysiology? Because this is the only situation where you take history, make a possible link to the diagnosis, physiological explanation, and see whether which fits into with the diagnosis. So what are all the historical features which we need to see? What is the position? Supine, sitting, standing, activity, change of posture precipitated the event, symptom occurred during or after exercise, immediately or after voiding, or during defecation, coughing, swallowing. These are all the historical features that precede the event. So that is very important. What happened the last? And nausea, vomiting, feeling of cold, sweating, visual aura, pain in the neck, shoulder, blurred vision. These are all can happen when syncope. Every history is important because the last half an hour before the event, minute by minute history covering all these points are a must. Noticed after the event, confusion, palpitations, duration of symptoms, headache, nausea, vomiting, feeling of cold, muscle ache, injury, chest pain, inability to stand up without triggering another episode may suggest a neurally mediated reflex syncope. So all these things after the event should be noted. So how to diagnose this? How to diagnose vasovagal syncope? Typical garden variety will be young, emotional people, orthostatic stress. That is, most people fall during our anatomy days, and the school children falling in assembly. These are all vasovagal syncope with autonomic prodromes. What test you have to do is head up tilt test. That will tell us whether the problem is cardio inhibitory, that is bradycardia related, or vasodepressor, which is hypotension related. Second common thing is the situation. Situation is when you see blood, when you feel pain, you feel after urination, after defecation. All these are all the situations which can precipitate a syncope. It is similar to the vasovagal syncope. Here, historical diagnosis is all that needed. No further evaluation is needed to diagnose the situational syncope. Cardiac, the keys are they usually happen during exercise or syncope in supine posture. Palpitation preceding the event is cardiac. Family history is very important of sudden cardiac death or having channelopathies, having inserted an ICD earlier generations. Yes, cardiac favors cardiac etiology. ECG will tell us, give us a lot of clue. Complete heart block, Mobitz type 2 heart block, 6 sinus syndrome, alternating right left bundle branch block, NSVT. You have an intravascular conduction disturbance with QRS more than 120 milliseconds, pacemaker malfunctions, QT prolongation, epsilon wave, all will give us a clue that this could be a cardiac illness. The echo will tell us whether there is any aortic stenosis, left ventricular dysfunction, old MI, or a structural disease which can precipitate the cardiac event. Orthostatic, the commonest thing is that history of antihypertensives and diuretic, sudden change of posture either from supine to sitting or supine to standing or sitting to standing or prolonged after prolonged rest will be diagnostic of orthostatic. So this will also be diagnosed in a head up tilt test. A drop in BP 20 systolic and 10 millimeter diastolic is diagnostic of orthostatic hypotension. Next is a carotid sinus syncope. Typical history, the shaving induced syncope. You have a carotid sinus sensitivity testing. A prolonged pause will tell us that the diagnosis is a carotid sinus syncope. Beware, before doing a carotid sinus sensitivity testing, that you have to auscultate for bruit because you can precipitate a stroke if there is a plaque sitting there in a common carotid artery. In younger people, we have two diagnoses which can come. Very young people, breath holding spells, which is very common in the age of 6 months to 2 years. Pretty rare after 5 years, usually they abate. The only child, the usual story is there is a cry, there will be an apnea, then followed by cyanosis, myoclonus, and profound limp of the body, approximately 1 minute. Then the child automatically gasps and then comes back to life. So it is a breath holding spell. Usually what is suggested is counseling. A sharp pain given during the episode cuts short the pain, the entire duration of the pain, and the child will recover quickly. The other thing is you have to remember in young people is the reflex anoxic seizures. Normally less than 2 years of age children will have it. Sudden startle or an injury will precipitate this event. Apnea, no cry, loss of consciousness, but rhythmic writhing like body contraction, recovery. But during the episode, they may have bradycardia or asystole also, but usually they settle. You need not put a pacemaker. Most children recover when they are reaching 4 to 5 years of age. So These are the DDs which you have to come to a diagnosis in history and the appropriate examination. Miscellaneous causes which you should not forget is aortic dissection, pulmonary embolism, atrial myxoma and Al-Kappa. Today morning I missed the session because of a pulmonary embolism related syncope today morning. So it's pretty common. You just have to look for it. Coming to investigation to confirm our diagnosis, ECG is a must for all. And in the diagnostic yield is about 5 to 7%. Multiple ECGs or an event recorder will increase the yield by another 3-4%. Echo, nowadays I say you have to do an echo compulsory because me included, our auscultatory skills have gone down drastically. So better get an echo, make sure that it is a structurally normal heart. Tilt table test, it differentiates between vasovagal syncope and orthostatic hypotension and the postural orthostatic tachycardia syndrome. In vasovagal syncope, like I said, it differentiates between vasodepressor versus cardioinhibitory etiology. Holter test or a loop recorder or implantable loop recorder. If at all you consider a possible arrhythmic origin of syncope, you use it. Differentiates between epilepsy and uncertain fits, because even after detailed history, there will be particular percentage of patients where you still can't come to a diagnosis. In that cases, yes, it is useful. ILR can be implanted up to 36 months. EP study, it is done to check the integrity of the His-Purkinje system. Whenever there is a bifascicular or trifascicular ECG, you check the His-Purkinje integrity. Whenever the HV interval is more than 70 seconds, then you have to implant a pacemaker. Second thing is that whenever a palpitation preceding a syncope, we don't know the arrhythmia that is causing it, then you characterize by doing an EP study. Neuroevaluation, it's a predominantly a cardiac disease. It is not needed in a typical vasovagal syncope. But when the clinical history is not conclusive, imaging and EEG are suggested to rule out complex partial seizures and psychogenic behavior. And in children, when the history or the bystander story is not clear, then completion's sake you do a neuroevaluation, which will include imaging also. So this is a long list for syncope recurrence or life-threatening consequences. We all know it. When there is a history of sudden cardiac death, when there is a channelopathy, arrhythmogenic ventricular dysplasia, and history of migraines, structural heart disease, Parkinson, epilepsy, migraine, diabetes, alcoholism, drug abuse, this will portend that there is a risk for death or future events that can come in syncope. So this is in ER. Whenever these things are there, you have to admit the patient for further evaluation. Sudden cardiac death, hypotension at presentation, older age, heart disease, ECG showing abnormality, all this will tell us the patient has to be admitted for further evaluation. Low risk patients, less than 50 years, no cardiovascular disease, no ECG abnormalities, you can evaluate them leisurely at your pace. So, in essence, syncope, initial evaluation should include a history, physical examination and ECG. Initial evaluation is clear, no additional evaluation is needed, all that you have to do is treat. Whenever initial evaluation is unclear, you do blood testing, targeted blood testing. If you are suspecting CAD, you can do troponin and all. Initial evaluation suggests new orthostatic hypotension, so autonomic evaluation is indicated. When evaluation suggests that it is a reflex syncope, you do a head-up tilt testing. Cardiovascular abnormalities, then do a stress test, transthoracic echo, EP study, MR or CT to identify the scars in the LV myocardium. So then you can do a cardiac monitoring to decide whether the patient needs a pacemaker or further EP study is needed. So this is how you proceed with whenever you encounter a patient with syncope. Thank you.
It was a very detailed review on syncope, sir. And what is your experience on the nocturnal syncope? Many times we see elderly individual when they go for urination, they have a syncope. So I feel that is the one which is very commonly I see in my clinical practice apart from the arrhythmias. And the second type of syncope we see in acute blood loss, some GA malignancy or some bleeding melena, and they have a syncope and they recover when we see the patient anemic hemoglobin 8. So these two kind of syncope should not be missed apart from the pulmonary embolism one.
Yes, you are correct. The thing is that elderly syncope, admit and evaluate, because you don't know what you are dealing with. It could be a dangerous thing, most likely a dangerous thing, and less likely a non-dangerous thing. And then the commonest etiology in elderly people are orthostatic hypotension unless proved otherwise. The etiology could be drugs, most common nowadays, because our target BPs are going down, down and down. So it's most likely hypotension due to drugs, but precipitated by an intercurrent illness like an upper respiratory infection, or they might have skipped a meal, they forgot to drink water. That could be very simple things, but it has to prompt us further evaluation in elderly. The GI loss anemia related syncope, yes, clinical thorough examination is a must, because those are dangerous subset. Without intervention, you risk losing the patient's life. So we have to be, all out, both eyes and ears, for any clues to the diagnosis.
So I want your comment regarding the head up tilt test, HUD test. Should we be still doing that as a part of evaluation? I want your opinion and also Dr. Nambudri sir's opinion on the head up tilt test.
We are still doing in our center. We are still doing head up tilt tests, basically because it is not. I won't say it will add anything, rather than telling the patient that, look, I know what you are having, just to reassure the patient that that you are dealing with such and such disease, and then you need not worry. So for these two reasons, you have to bring back the same symptoms which the patient had during the testing, and then tell the patient, look, this is what you have, and this is what your treatment is. Like, you take a lot of water, you increase your salt intake, you do the isometric exercises regularly, and then you do the exercises, which the leaning exercises, then you will become normal, just for reassurance, because as a treatment you're not going to offer anything. So you have to tell them, look, yes, I know what you're having, I'm confident that this is it, prove that this is it, and then tell them that treatment, and they will accept it. For that reason, I'm still doing it. Sir?
I fully agree. Actually, that is the point. It is quite reassuring. Probably you may not have a tilt positive test every time if the history is classical, even if the history is classical. But it is quite reassuring, and if it also helps to categorize the type of response, and in some middle-aged and all, if we consider a pacemaker and all, it's extreme case we consider a pacemaker for a malignant syncope related to neurocardiogenic syncope. So still it is, in that case also it helps. Generally we avoid doing tilt test in the elderly, because if there is a problem related to isoprenaline or a transient syncope, hypotension and all, we generally avoid after the age of 65 to 70 years. Routinely we usually do it in neurocardiogenic syncope, especially if there is a confusion regarding seizure versus syncope, because in our hospital we have a very dominant neurology wing also. We get a lot of patients with syncope versus seizure in young age. There also, if we have a positive test, it generally helps.
It is typically you make a diagnosis of vasovagal syncope, and then do the tilt table to confirm it. When you are in doubt, then it is better not, and take precautions at this age. History is more important, and then syncope, it is not an individual treatment. It should be a team. The team should contain a neurologist, a cardiologist who is interested in the syncope, and then a team of people who can do the tilt test for you, can interpret your ECGs and all,
looking at your long loop recorders and all. So you need a team to do it. So if that is there, then it becomes easy for all of us.
Thank you, sir. Thank you for the wonderful presentation. Let's move on to the next topic. Let me invite Dr. Sivarakrishan sir again for felicitating Dr. Nitya. So let me invite Dr. Ajit Tachal, the senior interventional electrophysiologist from Lisi Hospital, Cochin, for this next talk on emergency management of cardiac arrhythmias. So, to introduce Dr. Ajit, is an excellent speaker. I think hope all of you will enjoy that talk. The slides will be very, very interesting.
Thank you, Lawrence, and thank you for the opportunity. So I'll get straight to the topic. Do we have a time or the timer's there? Okay, thank you. So I'd say I'd classify arrhythmias into two types: the malignant ones and the ones which are emergency ones. I'm putting this practical classification. Malignant, I say the patient is going to die or something really nasty is going to happen to the patient very, very soon if you don't treat that arrhythmia very, very quickly. And the others, of course, I think emergency is basically anything that causes severe symptoms. The reason I put it this way is, in a malignant arrhythmia, more important than the arrhythmia is what is happening to the patient. Meaning, promptly treat the arrhythmia. Do not waste too much time trying to figure out what the arrhythmia is. Don't try to waste too much time looking at the ECG. Is it SVT? Is it VT? Is it this? If it's a arrhythmia which is malignant, you first shock and then think. So that's that. Now that we are done with that, we'll look at the arrhythmias where we get time to think. There may be bradyarrhythmias and tachyarrhythmias. Rate less than 60, rate more than 100. Bradyarrhythmias may be due to sinus node dysfunction or AV block. And tachyarrhythmias can be narrow QRS or wide QRS. Both can be either regular or irregular. So I'll first come to bradyarrhythmias. Now, once again, I'd classify arrhythmias from a practical standpoint, the ones where the patient is collapsing or almost collapsing, and where the patients have symptoms. Now, in the absence of symptoms, there is no emergency treatment required for a bradyarrhythmia. If a patient comes with a sinus rate of 35, and patient comes walking to you, there is no emergency to put him in the ICU and start some treatment. Patient comes with a junctional rhythm, he has no symptoms. There is no emergency there. Patient comes with a CHB with a narrow QRS escape rate of 40. Patient is 35 years old. There is no emergency to suddenly treat this thing. So, by and large, bradyarrhythmias which are absolutely asymptomatic is not an emergency. So, if a patient is nearly collapsing, start CPR. Think later. During the CPR, give atropine. Might repeat it. And if it doesn't work, or while you're doing it, get ready for temporary pacing. Transcutaneous pacing, if you have the facility, good. Sometimes it works, sometimes it doesn't, to be honest. But if you have the facility, don't forget to think about it. And then you have to go to transvenous pacing. So that's when the patient is really collapsing. If the patient is not collapsing, then you think, is this a sinus node problem or an AV node problem? If there's a sinus node problem, again, you go to atropine. And most sinus node problems will recover with isoprene and stopping the offending drugs. They rarely require pacing. An AV node problem, you have a narrow QRS escape rhythm or a wide QRS escape rhythm. A lot of narrow QRS escape rhythms are reasonably stable, except there are some patients who have diastolic dysfunction or an underlying bad heart. There, they don't tolerate AV block. But if the underlying heart is structurally normal, most patients will tolerate a narrow QRS escape rhythm, which means it will give you time to try atropine and isoprene and only then go on to temporary pacing. A wide QRS escape rhythm, you give atropine while you're getting ready for temporary pacing. You don't give atropine and wait for the response and decide whether you want to do temporary pacing. The patient comes with a symptomatic wide QRS escape rhythm. While you're getting ready for temporary pacing, you might give atropine. But otherwise, just go straight to that. If there is a sinus node dysfunction, make sure there is no acidosis that is correctable. It may be rarely a presentation of an inferior MI. Make sure there is no acute renal failure. If there is an AV node problem, in addition to these, also look for hyperkalemia before you jump to the final conclusion. So obviously you need to identify what the ECGs are. There may be sinus bradycardia, which is slow sinus rate, which I think all of you will be able to identify. There may be absent antegrade P waves. Here all the P waves are after the QRS complexes. So it's a junctional rhythm with a retrograde P wave. And that's AV block with a wide QRS escape. This is the one where you start getting ready for temporary pacing and you start thinking of the treatment while you're getting ready for temporary pacing. And you have the AV block with the narrow QRS escape where you do the reverse. You start treatment and then decide whether you want to do temporary pacing. Unless the patient is going into heart failure or something, you often don't need temporary pacing here. So that's about bradyarrhythmias, finished. Now we'll come to tachyarrhythmias. Tachyarrhythmias, again, you have patients who are nearly collapsing and the patients who are symptomatic. It is very rare to have a tachyarrhythmia where the patient has no symptoms. So the first thing when you have a tachyarrhythmia is see if you can see a proper well-formed QRS. If you cannot see a well-formed QRS and if the patient is nearly collapsing, stop thinking, start shocking. Don't think of what energy to give, how much to give. Just give the maximum energy that the defibrillator can give and think later. Then you have a well-formed QRS visible. Remember, this patient is almost collapsing. Please don't try to figure out if it's SVT or with aberrancy or VT or anything. A patient is significantly symptomatic. There is a wide QRS arrhythmia. If there is a pulse, if the next thing you do is see if there's a carotid pulse. If there is a carotid pulse, you give a synchronized cardioversion. So very important to synchronize. That is, you have to press the sync so that the sync markers come. Make sure the sync markers come there and only then shock. Giving an asynchronous shock in this situation can convert a well-formed arrhythmia into a ventricular fibrillation. So you might shock the atrial fibrillation also. The top tracing is atrial fibrillation, but the patient is significantly symptomatic. So the treatment remains the same. You give a synchronized shock. And sometimes you're not sure of the QRS morphology. You're not sure of the carotid pulse, or you think there is no carotid pulse. But if the patient is nearly collapsing, you shock first and then think later. Don't go to the other extreme. If the ECG looks horrible, but the patient is talking to you, patient looks okay, meaning you have a stable patient, but what I call an unstable ECG, this is usually not an arrhythmia. It's usually an artifact. So the clue is, if you look carefully, you can see these well-formed QRSs at regular intervals in them. So important thing is look at the patient and then look at the ECG. Now we come to the patients who are symptomatic but not collapsing. First step is please record a 12-lead ECG. Don't treat based on a strip. Okay, a 12-lead ECG might show a regular narrow QRS tachycardia. But if the patient, if at all the patient gives you 2 minutes to record this ECG, even if it's a wide QRS tachycardia with just about enough blood pressure, please record this ECG before going on to the final treatment, the next treatment, because this one ECG will provide multiple very important clues on how to do the long-term management of this patient. So if the patient is not collapsed, please record a 12-lead ECG. That will tremendously help the cardiologist or the electrophysiologist who has to come up with a definitive management for this. So now wide and narrow QRS. Why do we call this wide and narrow QRS? Because more than 95% of narrow QRS tachycardias are SVT. That's a simple reason why we classify them as wide and narrow. So there are two types of SVT. The ones that start in the atrium and go down to the AV node, and the circuits which travel between the atrium and the AV node. Mechanistically, it's easy to think of it this way, treatment-wise. So there are three SVTs which start in the atrium and go to the AV node. One is sinus tachycardia. When the focus is somewhere else, it's atrial tachycardia. When it's a continuous focus, it's atrial flutter. But mechanistically, they start in the atrium and go down the AV node. And then there is an irregular tachycardia, one irregular tachycardia starting in the atrium from all over the atrium and going down the AV node, that's atrial fibrillation. So 4 starting in the atrium and going down the AV node. Now, the one starting in the atrium and going down the AV node, next important thing is look at the shape of the P wave. Here you can see that the P waves are positive from V1 to V6, which means it's coming from a posterior structure, which means it is coming from left atrium, so that's a left atrial tachycardia. It's very important to understand the morphology of the sinus P wave. The sinus node is located in the superior and the posterior part of the right atrium, and the right atrium itself is an anterior atrium. It's not the posterior atrium, which means that the sinus P waves will be negative in AVR and positive in all the other limb leads. It will have a negative component, it will have an initial positive component, and then a negative component in V1. So V1 is here, it will activate the right atrium towards V1 and then the left atrium away from V1. So initial positive and subsequent negative in V1. It's very important to understand that whether something is sinus tachycardia or not, because when you have sinus tachycardia, you treat the underlying cause. When you have atrial tachycardia, you treat the tachycardia. The underlying cause is there in this ECG. I won't come to that because that's not the point of the discussion. You don't treat this tachycardia, you treat the underlying cause. This is pericarditis. Atrial flutter is where you don't have gaps between P waves because it's a continuous activity. You see these sawtooth P waves, best seen in 2-3 AVF, and there are no gaps between P waves. Atrial fibrillation, of course, is irregular and you can't see the P waves. So now we made all the diagnosis of all the 4 tachycardias starting from the atrium and going down to the ventricle. And then we have the tachycardias which reciprocate between the atrium and the ventricle. By and large, in these tachycardias, you don't see the P waves. So unless proven otherwise, if you have a regular narrow QRS tachycardia and you don't see the P wave, you assume that this is an AV node dependent tachycardia and treat as a re-entry. Sometimes you can see a P wave. When you see a P wave, it can be an AV node dependent tachycardia. That is, this P may be going to this QRS and this QRS may be going to this P. Or it may also be an atrial tachycardia. This P may be causing this QRS. This QRS may not be going up to this P. There is no way of conclusively knowing that from the ECG. So from a simple standpoint, treat it as a re-entry. If that doesn't work, well, your diagnosis is wrong, then you treat it as an arrhythmia from the atrium. So that's how you go about it practically. It's a different thing when you're going through an ECG class. Here we're talking about how to manage an arrhythmia. So next thing is you have to figure out how to treat a re-entry, that is an arrhythmia which goes through the AV node. First thing is carotid sinus massage if there is no bruit. But then this is practically impossible. Who can make out a bruit in a patient where the heart rate is 170? Not me. So generally, you just give a carotid sinus massage if you think that there is very low risk of a carotid plaque. If you think there's a very high risk, you don't give a carotid massage. You give adenosine, and if that doesn't work, you give diltiazem, verapamil, or metoprolol. And very rarely, if it's a symptomatic, severely symptomatic patient, you cardiovert. Sinus tachycardia, you treat the cause. Atrial tachycardia, first drug would be beta blocker, followed by either flecainide or sotalol or amiodarone, and if unstable, cardioversion. Atrial fibrillation, you first try AV nodal blocking drugs always before. You don't have to jump and go to amiodarone to all the patient. If that doesn't work, then you go to getting rid of the arrhythmia. Atrial flutter, by and large, drugs don't work, but if you want to give one drug, that would be ibutylite. This is very important. I'm not going to go through this, but you must know the drug doses used for all SVT. I'm not going to go through this in detail. You can, but you must know that these are the standard dose of drugs used for treatment of SVT. Now coming to adenosine. Put a large IV line, flush rapidly, and please record an ECG strip during adenosine, not before adenosine, after adenosine. All the information is contained in that ECG strip during adenosine. So here is where there is a QRS and a P. You can see that when the tachy is terminated, the QRS has not gone to the P. So by and large, if you see this is an AV node dependent tachycardia because the QRS not going to the P has stopped the tachycardia. Here you can see during adenosine, an atrial flutter has been unmasked. There are multiple P waves which are continuous with each other. So you unmasked an atrial flutter during adenosine. And here you can see it's a little confusing thing. There is a P and a QRS, and when we give adenosine, there is no P. So this is an AV node dependent re-entry. This is an atrial flutter. This may be an AV node dependent re-entry. That is, adenosine may have stopped this QRS to conduct to the P, or it may be an adenosine sensitive atrial tachycardia. About 8 to 10% of atrial tachycardia are sensitive to adenosine. So just because something stopped with adenosine, that doesn't mean it's dependent on the AV node. But here is a practical example of why you need to use record during adenosine. This is a patient with RV cardiomyopathy, came with some symptom and a BP of 110/80. Not sure what is his tachycardia, we cannot see the P waves. You give adenosine, this happens. P waves with multiple isoelectric intervals in between, and so that's an atrial tachycardia. And a short while later, it starts and goes back to the original tachycardia. So if you had to record an ECG during adenosine, before adenosine, after adenosine, it looked the same. And very often you come to report saying adenosine did not work. But the whole information is during adenosine. So please record ECG during adenosine. And if there is no change with adenosine, but you think it should have worked, it looked like a reentrant tachycardia, then think of whether you gave adenosine the wrong way or the wrong dose. Give up to 18 mg after cutting down sympathetic stimulation. A highly sympathetically activated patient, adenosine may not work. Sedate the patient deeply and then give 18 mg of adenosine, preferably through a central line or at least an external jugular way. And if that doesn't work, then you say, okay, now adenosine did not work. But before going through this step, don't say that adenosine did not work. SVT reverts with adenosine but comes promptly. Now what to do? well, if you have center which you can ablate, you go ahead and ablate. But if not, you give a drug which will prevent reinitiation of SVT and then repeat that adenosine. So I would give a diltiazem infusion for about half an hour or so and then give the adenosine on top of that infusion, and very often it will stay reverted if you do it that way. Of course, this is atrial fibrillation, irregular narrow QRS tachycardia. You could chemically or electrically cardiovert, or you could opt for rate control if the patient is stable. But what I want to tell is that, see, the risk of embolization is there with chemical and electrical cardioversion. Don't think that you give a shock and the clot will go to the brain, and you give amiodarone, it will terminate, the clot will not go to the brain. So the risk is in the substrate. The risk is not necessarily in the arrhythmia itself. Okay. So if a patient has an atrial fibrillation of unknown duration, please don't jump to give amiodarone before you sufficiently anticoagulate the patient. That is what I want to tell here. So if, while giving amiodarone, please look at the blood pressure. If the blood pressure is on the lower side, please do not give that bolus of amiodarone. If you want to, if you still insist on giving amiodarone, you can give a low dose. I'd rather cardiovert if the blood pressure is on the lower side. Personally, I'd prefer ibutylite for flutter and amiodarone for AFib because I found that that's the way it works better. Before cardioversion, please start a noradrenaline because you have to sedate for cardioversion. Once you sedate, the BP is on the lower side, you want to cardiovert. And if the BP is on the lower side, when you sedate, the BP is going to crash. Anticipate that, start NORAD and then sedate and then cardiovert. If a patient has some significant ventricular dilatation or atria are significantly dilated, it is better to initially load with amiodarone if possible for 1 or 2 days and then cardiovert. That enhances the success of cardioversion. So don't jump to cardiovert. Chemical cardioversion of atrial flutter, ibutylite. If it works, it will work in 15 to 20 minutes. If it doesn't work in 15 to 20 minutes, usually it will work in 5 or 10 minutes. If it doesn't work in 15 to 20 minutes, it's not going to work. If it works, it's beautiful. Give it one shot. If not, well, go to the next step. Now coming back to that patient, this patient, we just give beta blocker, got the rate down, got the patient to be comfortable, and then took him to the lab and ablated the atrial tachycardia. So I'm just saying that there are different ways of dealing with it. It's not that every patient should have rate control, every patient should have rhythm control, every patient should have cardioversion. You individualize it. By and large, in stable patients, I would prefer to give rate control, study the arrhythmia, and then come up with a long-term plan. Now coming to the white QRS tachycardias. I'm not going to go through how to differentiate white QRS tachycardia into VT and SVT. That's not the purpose of this talk. I'm talking about the management. So we have this white QRS tachycardia already diagnosed as ventricular tachycardia. Now what to do here? If the BP is reasonable, I would always give drugs. Give drugs time to wait, time to act. And the most important thing in drug is give as much beta blocker as possible. And then give a small dose of amiodarone. At the same time, I wouldn't continue this drug for a long time because when you terminate it, you might end up with bradycardia. So it would be reasonable to give amiodarone something like overnight and then go into cardioversion rather than cardiovert straight away. And in that time, you get time to anticoagulate, you get time to look at other things, whether any underlying precipitating factors, what is the LV like, what is the atrium like, is there mitral regurgitation, what's the patient like. Also look at triggers for ventricular tachycardia, hypokalemia and ischemia. Now, I want to tell this very clearly. Most regular monomorphic ventricular tachycardia are due to scar and not due to ischemia, which means that if you have a patient with a ventricular tachycardia which is monomorphic and you find a coronary artery disease, most likely that coronary artery plaque, what you found, is not the cause of the ventricular tachycardia. I'm not saying that that plaque doesn't need treatment. Don't assume that if you treat the plaque, the ventricular tachycardia will go away. If it is a regular monomorphic ventricular tachycardia. Troponin may be positive because the VT caused hypotension or because of cardioversion or because of ischemia due to the VT. A troponin positive with a VT doesn't mean that it's an ACS causing VT. If ischemia is present, it is often difficult to decide whether the ischemia is the cause of the VT. You have to treat both. But I'm just saying that if you find a coronary artery disease and a VT simultaneously, don't always assume that if you treat the coronary artery disease, the VT will go away, especially if it's a regular monomorphic ventricular tachycardia. Now, another situation of treating the underlying cause. Permanent AF on diuretics, sudden recurrent loss of consciousness. Obviously, it's a polymorphic VT, it's a torsades, and the reason is here, it's hypokalemia. you need to, it's a QT prolongation due to hypokalemia. So you need to stop the drugs, give some empirical magnesium, and then treat it. So the only safe drug in this situation is lidocaine, and this is the dose of lidocaine. But by and large, these things will respond to magnesium and correcting the underlying precipitating factors. It's the usual precipitating factors too much diuretic. What if the arrhythmia recurs after cardioversion? Now you have a problem. You have cardioverted, that's your last therapy, and the arrhythmia has come back. If it's an SVT and the patient is stable, you usually have time. You can start some IV diltiazem, might start amiodarone infusion, and consider ablation. At this stage, refer the patient promptly for ablation when the patient is still stable. Don't wait till the patient starts crashing. But what if it's a VT which has recurred after cardioversion? Please don't keep the patient there and try one drug after another drug till the patient becomes unstable. If a ventricular tachycardia has recurred after cardioversion, please send the patient for ablation. Please start making arrangements to send the patient for ablation. Rather than keep the patient for 1 or 2 days and try multiple drugs, it can really become nasty. And very important thing, keep the defibrillator patches connected to the patient. Don't waste your time to bring the defibrillator, put it on the patient, shock. Those 2 minutes may be the difference between life and death. So if a VT recurs after cardioversion, keep the patches connected on the patient so that next time the VT comes, at least you can shock promptly and start making arrangements for ablation. So here is another point I want to mention. So here's a person who had a surgery for a tetralogy of Fallot and came with a ventricular tachycardia, was cardioverted. A little later, the ventricular tachycardia recurred. BP is now 160, it's not too bad. Okay, another morphology of ventricular tachycardia, each way cardioverted. Now, next ventricular tachycardia is 60 blood pressure. Now, at this point, please do not try one drug after another drug. At this point, the patient is still reasonably stable enough to transfer for ablation. But you keep this patient, try one drug after another drug, then you have a point of no return where the patient is hypotensive. Now, already the LFT is bad. Now the renal output will reduce, and then it's gone. Then you ablate, the tachy goes, the patient also goes. Not because of the tachy, but due to the hemodynamic compromise suffered while the patient is getting ready. So, and very importantly, implantable cardioverter defibrillator is not the treatment for recurrent ventricular tachycardia. If a patient gets an ICD for secondary prevention for VT, it should, I think, be standard practice, like we do, to observe the patient for 2 or 3 days before deciding to implant the ICD. That's at least what we do in our center. Patient comes with a VT, scar-related VT. We cardiovert the VT. We keep the patient there in the ICU on only beta blocker and see for the next 3 days if it's going to recur. If it is going to recur, please ablate and then implant the ICD. The worst thing that a patient can get is to get recurrent ICD shock. So you want an ICD to shock, but you don't want it to shock too frequently. So before you put an ICD for secondary prevention, make sure the patient is in a state where he's not going to get recurrent shock. Simple thing is keep the patient only beta blocker for 3 days before deciding to implant the ICD. If he has a recurrence, please don't implant the ICD. Ablate and then implant. Now, what if the arrhythmia does not respond to cardioversion? That is really, really bad. That's worse than what we told. So this needs start planning for an emergency ablation, and there are some things which you should do while you start planning. Look for underlying triggers. What do you do when you plan? So this happens only in 2 situations where there is recurrent VT which is not responding to. One is very, very sick patient. There the patient and the family and everybody is more or less anticipating it. Class 3, class 4 patients who've been very sick for a long time. Somebody gets recurrent VT like that. It's still, I'm not saying that it's a good thing, but it's not an unanticipated problem. The situation where it comes unanticipated is early post revascularization, especially if a patient is revascularized more than 24 hours post MI. Take you should have your thoughts very clear if it's going to delay revascularization. That is one situation where you'll end up in this mess, and that is unanticipated. So then you have to do something. So here's something. Patient is getting recurrently cardioverted, the VT is coming back on and on. So what do you do in this situation? First thing is medical therapy. The best beta blocker in this situation is thought to be propranolol because it also acts on the central sympathetic system. Blood pressure will be low, obviously. Patient will be on high inotropes. If you have an ECMO, put the patient on ECMO. Most centers will not have an ECMO, but if you do, put the patient on ECMO at this situation. If you have an IABP, put an IABP. Simultaneously start all these things. Amiodarone is going to be hopeless in this situation. Patient not going to have any blood pressure. It's hardly going to work. Lidocaine is going to take time to work. Probably the one drug that you can try is phosphonatoin, 1 gram over 1 hour in 100 ml NS. And try rapid atrial pacing. The moment you cardiovert, start pacing. So you start with this. The next thing is, see, the sympathetic stimulation to the heart is what drives this ventricular tachycardia, recurrent VT. So you treat the tachycardia, you also cut down the sympathetic stimulation to the heart. These are all things that you do while you get preparation for ablation. And then you also try to get preparation for ablation. This would be another good resource. This is Dr. Lawrence's phone number. That's another good resource in this situation. Now, what I mean to say is, don't hesitate to take help. It's a crash and burn situation. Don't try to manage it yourself. So coming back to the sympathetic modulation, now you can either, the simplest way of sympathetic modulation is deep sedation. Gently, straight away anesthetize the patient. Straight away put the patient anesthesia and make sure the patient is not woken up even for meals. Patient should not move. Straight away put the patient under gentle anesthesia. The anesthetist would be, totally against this. Patient BP is, 60 systolic, 70 systolic. You say, no, let us stabilize. There's nothing like stabilizing the patient. Put the patient under anesthesia. This is either life or death. So anesthetize the patient and then think. The second thing which we can do is cut down, work on the thoracic epidural anesthesia if it can be done, or block the stellate ganglion if there is local expertise to do that. A good anesthetist can often do this. Give a bupivacaine infusion in the T1 to T2 or the T2 to T3 space, or get a needle and get 3 to 5 ml of bupivacaine in the thoracic sympathetic chain, which lies in the fascia of the longus colli. Can be done in 3 ways. If it's a very dire situation, just pull the sternocleidomastoid away, pull the carotid away, poke a needle down till you scrape the trachea at the C6 level and inject 3 to 5 ml of bupivacaine there. Even if you do it blindly, it will work in 50% of the cases. Or if you have time, it can be done with ultrasound guidance, with a little more refinement. You have to inject on top of the longus colli. Here you can see the carotid artery and the longus colli in ultrasound. It's not difficult to do. Or if you have access to a cath lab, do it in the cath lab. You just aim for this particular foramen. The sympathetic plexus lies in front of this foramen, just on the vertebra. It's not a complicated procedure. It takes hardly 5 minutes to do this. Once you put the needle there and you scrape the vertebra and go backwards, once you feel the needle hitting the vertebra just in anterior to this foramen, pull the needle back just a little bit, inject a little bit of contrast first. It should go up and down vertically. That's when you know that you are in the longus colli fascia. And once the contrast goes up and down vertically, then you follow it up with bupivacaine in the same area. This works in about 80% of the cases and gives you a day, almost a day's time to transfer the patient. So these are the things that you do when you stabilize the patient for ablation. In this situation, in the post-MI situation, it's very often due to peri-infarct Purkinje fibers which have become automatic. The myocardium has died, but the Purkinje fibers are not died. They are more resistant to ischemia and they can survive with blood just from the cavity. And when you're revascularized, you have woken up the sleeping Purkinje fiber, which is now no longer connected to the rest of his Purkinje system. So it becomes automatic, starts firing. So this is not an uncommon situation of delayed revascularization. If you have facilities to do, it's a beautiful therapy to do. You can ablate the peri-infarct Purkinje fibers and get excellent long-term results. So I'll stop with that. And I don't know if you have time for questions. Yeah, I think we have time for questions. Good. Thank you.
Very vast topic covered in a short term of 20 minutes. Difficult to manage, but very well done, sir. Great emphasis was done regarding cardioversion. It's a must that everybody in the hospital, starting from the consultant to the staff nurse and the trainees, they should know the art of cardioversion. There is no excuse for that. The one arrhythmia which respond very well to cardioversion is flutter when compared to fib. Many a time, whether it is flutter or fibrillation, we will miss. It won't respond. Flutter many a time won't respond to the medical therapy, and it will respond very well to the cardioversion, whereas the fibrillation won't respond very well to cardioversion.
Absolutely right. There is hardly any medical therapy for flutter. In fact, many of the flutters actually just spontaneously terminate if you give it 24 hours. So flutter is like you rightly said, you control the rate and then you cardiovert.
And many a time we'll have a doubt whether it is a sinus tachycardia or atrial tachycardia if the rate is very high. And if we keep on, if we try to cardiovert it, if it respond, probably it may be atrial tachycardia, provided the atrial tachycardia is of re-entry type. There are 3 types of atrial tachycardia: automaticity, triggered activity, and re-entry. All the arrhythmias which responds to the cardioversion is preferentially re-entry type. So if it is not getting cardioverted, probably you are shocking a patient with a sinus tachycardia. These things can happen in hospital setups. And regarding cardioversion for atrial fibrillation, it's, if you have time to anticoagulate the patient, give anticoagulation, at least give heparin. And don't forget to continue anticoagulation for at least 4 weeks after the cardioversion, because the risk of embolism still persists till 4 weeks after the cardioversion.
Absolutely. Yes.
That was an excellent talk, sir. Sir, in an unstable VT or a VF, when it is resistant to DC shocks, do you resort to this double sequential cardioversion that has recently been described?
Yes, that is, yeah, thank you for bringing that up. That is something that you should be aware of. If a patient has not responded to cardioversion, I'll first go to atrial fibrillation and ventricular fibrillation. If a patient doesn't respond to standard cardioversion for atrial fibrillation, please put the patches anteroposteriorly. In fact, for all atrial fibrillation, it is better to put paddles anteroposteriorly. The reason why we put paddle from here to here is because we are trying to get as much of the ventricle between the two paddles. But if you want to get as much of the left atrium between the two paddles, remember that the left atrium is a midline posterior structure. There is equal amount of left atrium on the right side and left side. So if you want to cardiovert the left atrium, put your patches anteroposteriorly, the front patch right on the sternum. And the second thing, like Vikram said, is don't forget the reasons why cardioversion fail. One reason why cardioversion fails is you've not got enough energy into the heart. And one simple way of getting enough energy into the heart is use 2 sets of patches. Use anteroposterior paddles as well as paddles from here to here. 2 people operate the 2 paddles, and you count down to 1, 2, 3. At the count of 3, you shock simultaneously. So if you do that, you get more energy into the heart. The other very important things to take care of is another reason why energy doesn't get into the heart is air. If your cardioversion doesn't fail, it's an emergency situation, intubate the patient, cardiovert in exhalation. Tell the patient, tell the anesthetist to hold the breath in expiration. So there is no air between the heart and the outside part of the thorax. Often works. You just have to repeat the same cardioversion in an anesthetized patient with the breath held in expiration. So these simple things people must know of why cardioversion fails.
And a quick comment on your phosphenitoin, because phosphenitoin, the advantage of phosphenitoin is the over phenytoin is the rapidity of infusion.
Yes.
We usually give the 600 or 800 or 1 gram within 10 minutes span.
Yes.
But what is the reason for you to give over 1 hour?
It's in a stable, it depends on the extent of stability of the patient. If like somebody's had a VT now and has the VT after 3 or 4 hours, I give it over 1 hour. But if the patient is going to have recurrent VT, I'll definitely give it over 10 minutes.
Can you quickly say how a patient who is having an ICD comes with a shock in a peripheral or non-EP setup, what should a physician do? Patient who is on ICD having a recurrent shock, appropriate or inappropriate, what is the next step in the management?
So the first thing, if a patient comes with an ICD and a shock, is ask the patient what he felt before the shock. If the patient says that before the shock I was feeling bad, I was feeling giddy, I was feeling dizzy, this is very likely this is an appropriate shock. There is a problem. Please refer the patient to a place which can handle an ICD. The patient says that no, before the shock I was perfectly fine. I was talking and I was walking down the stairs. Then I got a shock. Then I got 2 more shocks. Then I got 3 more shocks. And he says if you get 6 shocks like that, then very likely that this is an inappropriate shock. In that situation, what you do is admit the patient to the ICU, keep the patient on a monitor, and don't do anything. Just keep the patient under monitoring. And if the patient gets an inappropriate shock, it's getting under monitoring, you just put a magnet on the ICD, it will disable the shock. But most important thing, before you can interrogate the ICD, is ask the patient what did he feel before the shock. That will give a good clue whether it was appropriate or inappropriate.
Thank you for the wonderful talk, Dr. Ajit. I think we'll move on to the next presentation. This will be by Dr. Narayan Nambudri, Professor Sri Chitra Trinal Medical Science and Technology from Trivandrum. He'll be talking us on rate versus rhythm control in atrial fibrillation, the final verdict. I think you will all know Dr. Nambudri sir, and you will enjoy the session. It will be a wonderful presentation. Thank you, sir.
Thank you, Dr. Lawrence, my dear friend and an accomplished electrophysiologist, for having invited me to deliver this talk, and respected faculties off and on the dais. This is not a final verdict, especially just before the lunch. And this debate has been going on for the last 2 decades, whether rate or rhythm control, what is better in a case of atrial fibrillation. But every other year we get new insights to reiterate this concept, to continue this debate with the evidence coming from ablation wing, that is the rhythm control strategy. These two strategies obviously are two major approaches in the management of atrial fibrillation. And this debate will go on, like whether the PCI is better or a CABG is better. We get more evidence towards PCI. Of course, some trials are against that too. But this debate, there is nothing like a final verdict. But before I go into this topic, I'll just summarize what I'm going to talk on, that is rate versus rhythm. What are the advantages and disadvantages from the pathophysiological and clinical point of view? What are the important trials with some insights and the limitation in the current context? Recommendations as per the new guidelines, limitations of rhythm control with certain scenario, and advances in rhythm control with RF and cryoablation. Before we move on, we should have certain we should reiterate certain fundamental concepts in atrial fibrillation management. Atrial fibrillation is not a single disease at all. It is a disease of multifactorial origin. One patient with a paroxysmal atrial fibrillation in a 20-year-old male, 20-year-old person is totally different pathophysiologically from another person of 70 years having multiple comorbidities, obese, obstructive sleep apnea, diabetes, hypertension, diastolic dysfunction. These patients they're totally different, though we call it atrial fibrillation together. Another important feature is atrial fibrosis. The extent of atrial fibrosis is one of the most important deciding factors for rhythm restoration and maintenance. Many times it is not pulmonary vein isolation only. Atrial fibrosis in turn is decided by many factors like left atrial hypertension, left atrial volume, left atrial stretching, remodeling related to chronicity of AFib, AFib begets AFib, obesity, obstructive sleep apnea, etc. And the propensity of thromboembolism is decided by AFib, but it is not significantly modified by the strategy one adopts, especially in patients with multiple comorbidities and high chart score. Absolute rhythm control or absolute rate control are often overstated in clinical practice. If you do a long-term Holter monitoring of a patient who think it's always in sinus rhythm, you can see runs of atrial fibrillation. Similarly, a rhythm control, if you see a Holter, many times you can see absolute control less than 80, but at times rates going up to 150 or above. And rate or rhythm strategies are equally applicable only to a minority of patients in real world scenario. Like if you have a large atrium, 60 millimeter mitral stenosis, probably there is no question of any rhythm control. Similarly, in young patient with heart failure, having multiple episodes, needing hospitalization, you have to aggressively pursue rhythm control. These concepts are based upon the hemodynamics of AFib. We know the loss of coordinated atrial contraction leads to reduction in ventricular input of around 10 to 15%, and this cardiac output comes down. High ventricular rate, short diastolic filling time, irregularity of the ventricular response leading on to autonomic stimulation changes, decrease in the myocardial blood flow, and chronic atrial fibrillation leading to atrial and ventricular cardiomyopathy. These are all very well known. What are the clinical correlates? You have this uncoordinated movement of contraction of the atria leading to thromboembolism, decreased exercise capacity, quality of life, and worsening of LV function and decompensation of the heart failure. Look at the recommendation of 2020 ESC, the latest one. You look at this lifestyle modification and the oral anticoagulation therapy. They only lead on to change in the life expectancy. Neither rate control nor rhythm control would affect significantly the overall longevity of this patient, though it significantly affects the improved quality of life, autonomy of life, and social functioning. But predominantly, life expectancy is affected by management of hemodynamic unstable rhythms, cardiovascular risk reduction, lifestyle changes, management of obstructive sleep apnea, hypertension, diabetes, and also stroke prevention. What is ideally a rhythm control? It is either management with either class 1 or class 3 drug. I think pharmacological part Dr. Jaishankar is going to discuss in detail as a regular daily therapy or pill in the pocket when the patient gets in atrial fibrillation, as such either with a flecainide or propofenol, cardioversion electrical or pharmacological, and catheter ablation whether RF based or cryo based. Then we have in the right arm, we have AV nodal blocking agents, AV nodal ablation or modification. It could be either lenient or strict as defined in the guidelines. If you have a resting heart rate, office ECG showing less than 110, lenient, less than 80, it could be called strict. This debate is also not applicable for the first episode of AFib because majority of them terminate within 48 hours. If not, it has to be cardioverted. What are the advantages of rhythm control? It causes better improvement in quality of life, no doubt. Greater exercise capacity, especially in patients with a diastolic dysfunction, where atrial kick is very important. More complete relief of symptoms, and potentially lower risk of thromboembolism, probably stopping oral anticoagulation, and potentially reversing atrial structural or electrical remodeling. If you go for rhythm control, there are potential concerns as well. The majority of them are related to drug toxicity. If you give amiodarone, flecainide, propofenol, any of these medication, there is a chance to have torsades, serious bradyarrhythmias, worsening of the heart failure. Atrial flutter can become 1-to-1, especially with the flecainide, excess mortality in patients with a structural heart disease, and significant non-cardiac side effects with the amiodarone. Even when if you want to pursue rhythm control, you need to admit multiple times, repeated cardioversion, repeated hospitalizations with worsening heart failure, proarrhythmia, long-term oral anticoagulation may still be needed, and there could be lot of overlaps, crossover between them. These are the major trial. You can see the crossover that happened at the end of follow-up period. In the rhythm control, almost only 2/3 of them remained in rhythm control, and in the rate arm, as up to 35% of them were in sinus rhythm at the end of follow-up. There is a lot of crossover, but majority of these trials were unanimous in the outcome that more adverse drug effects were noted in rhythm control, not in the end. In fact, rate control fared well. But this is much before radiofrequency ablation has evolved as an important strategy. Most of them were done in late 90s, and atrial fibrillation ablation has become an important approach in the later part of the first decade of this century. And of these major trials excluded younger patients, non atrial fibrillation, highly symptomatic, which are the categories they respond very well to ablation. Rheumatic atrial fibrillation, CHF were underrepresented. We know from the Cassilia AFib study that patients with heart failure, they respond very well with atrial fibrillation correction. Factors that could have influenced the verdict, again, more than expected sinus rhythm in the rate controller that is showed, some crossover, and the potential side effects and inefficiency of antiarrhythmic drugs. So when you look back at these trials, one important point that you should know is intention to control rate is not inferior to a strategy intending to control rhythm. That is the main point. You can use rate control strategy as an important one, and it is not inferior to an aggressive rhythm control strategy because of the associated drug effect, and there is a potential groove where rhythm control may be beneficial as far as the clinical endpoints are concerned. Another concept is to look for a lenient rate control. Race trials have shown that the heart rate, if it is less than 110, that is fine, unless the symptoms, patient is symptomatic, or there is deterioration of LV function, or the patient has got a cardiac resynchronization therapy and there is no proper biventricular pacing happening. So in fact, these four conditions you can consider rate control strategy as the primary one before you adopt a rhythm control. That is a background therapy in all AFib patients. First choice therapy in patients with a no or minor symptom. Therapy after failure of rhythm control, and therapy when risk restoring sinus rhythm outweigh the benefits. Some trials have come after this since 2020. Two major one. This is actually East AFib net trial where they have looked into randomized these patients within 1 year of onset of atrial fibrillation and looked at the endpoints with these strategies. They have shown that early ablation strategy would definitely improve, benefit in reduction in endpoints on a long period of time. So there is an important early rhythm role for an early rhythm control strategy. You can see years since randomization, rhythm control fared better. Another one is catheter ablation or medical therapy to delay the progression of AFib. This was a test trial. This also showed that radiofrequency ablation is superior to guideline directed antiarrhythmic therapy in delaying the progression from paroxysmal to persistent atrial fibrillation. This is an important concept. If you address these arrhythmias quite early with an aggressive ablation strategy, the progression of these arrhythmias, atrial fibrillation from a paroxysmal subset to permanent subset or a persistent one, comes down drastically. So it can actually early approach can delay the progression of AFib by delaying the remodeling of the atrial substrate. Based on that, this is a JACC state-of-the-art review by John Kahn. This clearly mentioned that early rhythm control may effectively reduce irreversible atrial remodeling and prevent AFib-related deaths, heart failure, and strokes in high-risk patients. It has the potential to halt the progression and potentially save patients from years of symptomatic AFib. Therefore, it should be offered more widely. So the indications for rhythm control is primarily to reduce AFib related symptoms and improve quality of life, and also to prevent rates of AFib progression because they are significantly lower with rhythm control based upon the East AFib net and ATTEST trials. So which are the subgroups where we should pursue a rhythm control strategy over and above rate control one? The patient has severe symptoms related to AFib, tachycardiomyopathy, patients with a heart failure, younger patients, patients with a low atrial fibrillation, substrate or trigger that has been corrected, limited comorbidity, normal or moderate increased left atrial volume in DICE. All these conditions one should go for and aggressive rhythm control strategy either with antiarrhythmics or preferably with pulmonary vein isolation. What is pulmonary vein isolation and what is its relevance in the management of atrial fibrillation? This is by a landmark article from Bordeaux Group, Michel Hasagure, published in NEGM in 1998, which has it's caused a paradigm shift in the approach towards AFib management across the world. Spontaneous initiation of atrial fibrillation by ectopic beats originating in the pulmonary vein. This can be ablated and the symptomatic episodes of atrial fibrillation can be curtailed. So like this case, I have origin of the these beats coming from the ectopic beats coming from the pulmonary vein, and when you ablate this within the pulmonary vein, atrial fibrillation terminates and these patients remain symptom free long. Like some of these cases, the response could be as in you ablate AVNRT or a pathway, and some of the patients you may have substrate changes where it could be more difficult and sustained. But if you isolate the pulmonary vein in almost all these subgroups, the response could be dramatic. What are the indications for? You can either consider as a first line therapy or more preferably after failed drug therapy. Failed drug therapy essentially means failed class 1 or class 3 flecainide or amiodarone or beta blocker therapy. The indications in the class of evidence would vary. But 2-3 important points where we should know is, one is patients with tachycardia induced cardiomyopathy. It's a class 1 indication even without going through drug therapy. Another one is heart failure with a reduced ejection fraction. It is very important to consider ablation in this. And the third one, often we forget, is patients coming with a tachybrady syndrome and symptomatic pre-automaticity, the post-termination pause, if it is significant, there also they respond very well to atrial fibrillation ablation. I can show one scenario. A 53-year-old male businessman, episodes of palpitation and giddiness for 2 years, referred for the management of paroxysmal AFib, no history of hypertension, diabetes, dyslipidemia, not a smoker, no history of obstructive sleep apnea. It's a clean case for ablation otherwise as per this category. Occasionally consumes alcohol, which is not very uncommon even amongst ourselves. So ECG at presentation, patient has atrial fibrillation. Then this patient had a long history, but predominantly the latest ECGs and Holter showed significant post-termination pause. Runs of atrial fibrillation, post-termination pause, and as per the guidelines, it is class 2A indication to consider ablation. And when we ablate these cases, you can see this is just look at these electrograms. This is surface ECG, atrial fibrillation going on. This is within the pulmonary vein recording during a cryoablation of the left inferior pulmonary vein. And this goes on, and as we ablate, you can see the atria is in sinus rhythm, but this focal triggering runs in the pulmonary vein goes on. So here this is going on, and you can see at the end, even this gets terminated. It's a long video. It took some time to ablate this. So there you can see it terminates, and this patient is a remarkable response. And as at 12 months of follow-up, this patient is in sinus rhythm and off drugs, not only on Concor 2.5 milligram. Just we have always afraid of recurrence. Of course, that is routine also. Similar cases are not represented adequately in any of these trials. So we no need to have long-term antiarrhythmic drugs in this patient and avoids a pacemaker as well. Atrial fibrillation is traditionally done with pulmonary vein isolation is with RF ablation, but cryoablation is a important energy source and alternative source. You can see the here the -6, it comes up to almost -60, and the pulmonary vein gets isolated, clearly demonstrated. You can use 3D CT prior to it, merge, esophageal probes, eyes, everything, and improve the outcome in this case. In Chitra, we have done 38 cases since March 2022, 18 months. That was one of the first cases. In fact, mean age is 57, 3 redo cases. 14 cases had LA dimension more than 40, 3 had more than 50. Largest was 63 millimeter inlay in a HCM case in a doctor, an anesthesiologist from North Kerala, and he is doing very well. All cases used 3D electroanatomical mapping. ICE was used in 2/3 of them. Hybrid approach, that is touch up with RF, FU, 3 out of 38. Mean follow-up of 10 months, maximum follow-up 18 months. Age 57, the range, Ajit was asking me what is the highest age. It is 85 years, is retired surgery HOD from Tirunelveli who had 5 admissions, ventilatory requirement in the last 1 year. 6 months back we did not a single hospital admission afterwards, and he said he started doing surgery as well. So other cases, structural heart disease in 3 of them, and AFib duration was around 26 months, LA 43, that is a mean diameter, left atrial volume indiced, and most of them had prior requirement of drugs. We do 3D mapping in all, prior CT in all, image fusion in all, esophageal monitoring in all, eyes in only 2/3 of them we used. LA dwell time is only 71 minutes, fluoroscopy 38 minutes. Pulmonary vein isolated all of them except one we couldn't isolate. Every other vein we could isolate, and ablation results, time to isolation is only very minimal. Overall the procedure time is less than 1.5 to 2 hours, and hardly one patient had a transient phrenic nerve palsy. local site, small AV fistula, which responded to local compression. Hardly any other thing. One patient had a dengue fever after 1 year. TIA 3 months after stopping Novak in a patient with a less start score. Recurrence within 3 months, 2 out of them. Late recurrence after 3 months, 4 of them. They were all paroxysmal AFib. And except this, out of 37 surviving patients, 33 had no recurrence after the blanking period of 3 months after the cryoablation. So these things work very well in patients if provided the patient selection is optimal, and clinical follow-up we have in 100% of them. Important thing is to isolate these pulmonary veins. These are the healthy myocardium, and here the pulmonary veins are isolated totally. And look into each of them. We take care of this. You can see the signals here. Pulmonary vein signals are gone. Here you can see 2 signals, on one here, 2 on the left side, 1 only. It's atrial signal, and the pulmonary vein is isolated from the atrium. But is it applicable to every case? And the answer is no, because as I mentioned, atrial fibrillation is not a single illness. It has multiple etiologies, varied presentations, and also underlying pathophysiological substrates are entirely different. You have top, even in the original article, not more than, I think, 86% of them were from the pulmonary vein, and you can have extra pulmonary sources as well. Dr. Jabir is here. Baghlain sir, myself, and Dr. Jabir, we, along with other important team members, we published this Kerala atrial fibrillation. It's the largest series in the country. We looked at this, the proportion of the patients having comorbidities. 53 had hypertension, 34% had diabetes, and the dyslipidemia was also very common. Looked at our cohort, it's exactly the same. 54% had diabetes, hypertension, and 34 had, in fact, diabetes in the cryo population. So it actually, the case population we did also represent the exact replica of representing the population from the registry. Chart score was 2.9, but significant comorbidities happen in the population, and many of them could be something beyond paroxysmal AFib in a structurally normal heart. A significant proportion may not be ideal candidates for PVI. There could be non-PVI triggers. Economic burden could be very high. Potential risk of complication, limited facilities, and many times rate control is not an inferior strategy in many of them, unless there is tachycardiomyopathy, heart failure, or refractory symptoms related to AFib. The non-pulmonary vein triggers are many. There are unresolved areas regarding that, and even in the procedure there is difficulty to identify the trigger. Here is a patient, an isoprenaline initiating the source onset. It is not very clear where it comes from, whether pulmonary vein or not. Atrial tachycardia can degenerate into atrial fibrillation, and you can have activation time mapping could be very difficult if it is fast. Sometimes other tachycardia can degenerate into atrial fibrillation. There could be some complications, especially with RF, with the cryo. These local complications are in fact quite less, as it is a simple procedure. So how to optimize the results of rhythm control in the country? Screening for and treatment of all potential contributors and comorbidity. That is the most important thing. Discuss the likely success rate with the patient. Discuss on potential complications. Select the subgroup that would optimally respond to PVA alone strategy. Non-PVA triggers should be targeted in a separate session. Maybe after pulmonary isolation in the first one. Post-ablation, optimal selection of anti-arrhythmic drugs to maintain sinus rhythm. Proper training or well-equipped centers like Dr. Lawrence and his team, and other centers which are well-equipped to do pulmonary vein isolation. So concluding, going through all this, we have gone through the rate versus rhythm, advantages and disadvantages, some insights and limitation of the trials, recommendations, limitation of the rhythm control with a certain clinical scenario, and advances in the rhythm control with the RF and cryoablation. My final conclusion is rhythm control by pulmonary vein isolation provides excellent clinical outcome and could be an early approach in selected group of patients with atrial fibrillation to improve the quality of life and to prevent the progression of atrial fibrillation. Thank you all for the patient hearing.
Thank you for the wonderful talk, sir. We'll have discussion at the end of all the talks. After the end of all the talks, we'll have the discussion. Next, to speak on the topic of cryoablation, I call upon Dr. Lawrence.
I'll just touch upon things which I feel may be important in the management of atrial fibrillation. So as already been shown by Dr. Nambudri sir, I think we have a new modality for managing patients with atrial fibrillation, which is cryoablation. So as we all know, AF is a progressive disease. We have been hearing about arrhythmias since last 45 minutes to 1 hour. We have heard about a lot of arrhythmias like atrial tachycardias, AV nodal re-entry, or pathways which are due to connections between atrium and ventricle. And one different thing about atrial fibrillation is the progressive disease. A patient who had an AV nodal re-entry some 20 years back was managed medically, comes to you for an AV nodal re-entry ablation, it hardly changes your outcome or the procedural success or procedural complications because the arrhythmia remains same. But atrial fibrillation, if you see a patient with atrial fibrillation who has got into atrial fibrillation some 10-15 years back and comes with the atrium of 60 millimeter, you hardly will be able to deliver anything for this patient. Because a patient with proximal atrial fibrillation with a non-dilated left atrium has the best results. Because of all this, you have a lot of things which is going into the left atrium when the patient has atrial fibrillation. So atrial fibrillation, which starts at the proximal atrial fibrillation, during every episode, there is a atrial remodeling. A lot of structural changes happen in the left atrium. So patient slowly progresses into a proximal to persistent to a permanent atrial fibrillation. Why we have to be worried? Because treatment changes. There is a significant outcome changes when the patient progresses from paroxysmal to permanent atrial fibrillation. So, one of the largest study, Rocket AF, where the patient were followed up for a atrial fibrillation, around 18% had a paroxysmal atrial fibrillation, around 82% had a persistent atrial fibrillation. When they looked at both the curves, you can see the curves are diverging very early and very far away. So, there was a significant increase in all-cause mortality. There is significant increase in stroke, and a composite endpoint of stroke, systemic embolism and death was significantly higher when the patient has progressed from paroxysmal to permanent or a permanent form of atrial fibrillation. So this is what happens when the patient progresses. You have a 2.5 times increased cardiovascular event rate, 6.5 times more prevalent of stroke, and 2.5 times more increase in heart failure, and 1.5 times more increase in hospitalization, and definitely you have a health related quality of life which significantly goes down when the patient moves from paroxysmal to permanent form. We all know one of the largest study, AFFIRM study, which showed that rate control and rhythm control curves hugged each other and closely followed, and slide move on. Close me down. Move. Yeah. So you can see both curves are closely to each other. This is what put all of us into a notion that rate control should be as good as rhythm control. The problem here was when you go in and see deep into the study, when you keep the patient in sinus rhythm for a atrial fibrillation, that is a rhythm control arm, there was significant 50% lower risk of death. The problem is the way you keep the patient on sinus rhythm. When you are using high dose antiarrhythmics or antiarrhythmics which are toxic to keep the patient on sinus rhythm, you have increased the mortality by 50%. So the sinus rhythm was good. The problem was the way you keep the patient in sinus rhythm. If you are going to use antiarrhythmic for the modality for keeping the patient in sinus rhythm, there's a possibility that you will not enjoy the benefit of keeping the patient in sinus rhythm. So rhythm control, who are the patient you will prefer for rhythm control? The patient who are younger, less than 65, a patient who present with a tachycardia-induced cardiomyopathy, a disabling atrial fibrillation symptoms, a patient who are at the risk of stroke, AF with a recurrent transient ischemic events, who are not able to achieve a rate control, pregnant patient, no or minor structural heart disease, no or few comorbidities, normal or only moderately enlarged LA, a patient who have a heart failure and patient wants rhythm control. You have a rhythm control strategies. One of them has already been explained in detail by Dr. Raji, direct cardioversion. You have drugs which are going to be discussed in detail in the next talk. You have flecainide, propafenone, sotalol, dofetilide, amiodarone available in India, while dronabinol is not available in India. These drugs can be used. Class 1C drugs have a excellent efficacy. Only problem is you have to use them ideally in a patient who does not have a structural heart disease or coronary artery disease or does not have an LVH. Sotalol can be used in most of the patients except for a QT prolongation. Amiodarone is a drug which can be used in most of the patients. The problem is long-term toxicity. So that's the reason most of the guidelines have started recommending ablation for atrial fibrillation early. If you have a patient with symptomatic AF, refractory to antiarrhythmics, proximal atrial fibrillation, catheter ablation is class 1 indication. Persistent AF is a class 2A indication. When you have a long-standing persistent, still you can try, it's a class 2B. For a patient, there's another recommendation. You have a symptomatic atrial fibrillation. You have not started an antiarrhythmic drug yet, but before that, you can consider a patient, even on patient who was on beta blockers. Here, the recommendation is class 2A for a proximal atrial fibrillation and persistent atrial fibrillation. For a long-standing persistent is a class 2B. That means a patient who was on antiarrhythmic, recurs with antiarrhythmic, if it is a proximal atrial fibrillation, it's a class 1A. And if you have a patient with a symptomatic AF, even before you want to initiate an antiarrhythmic, still consider a catheter ablation if it is a proximal atrial fibrillation. This is how you treat a patient with atrial fibrillation if you are looking at a rhythm control as a strategy. If a patient does not have a structural heart disease, you can use flecainide or propafenone. And if patient wishes and you are interested, you can use catheter ablation as a primary strategy. If this fails, you can consider amiodarone. If a patient has a structural heart disease, a coronary artery disease or a heart failure, your options are limited. Only drug most of the time you end up using is either sotalol or a amiodarone. And if this fails, you can consider catheter ablation. So catheter ablation has two options. One is what we use as a point-to-point ablation, otherwise called radiofrequency ablation, or you can use a cryoablation. In our center, we use cryoablation, as Dr. Nambudri sir has already shown you. Cryoablation is a technique by which we achieve a pulmonary vein isolation. It's an anatomical approach. It delivers a good, long-lasting pulmonary vein isolation. So this is how we do it. Hopefully, please. Yeah. So if you look at a cryoablation, the primary technique is we go across septum transeptally, go from a femoral vein, take a transeptal axis, go into pulmonary vein. Once you enter the pulmonary vein, we record what is there in the pulmonary vein. We record the signals in the pulmonary vein. We know one of the common reason why patients with atrial fibrillation develop atrial fibrillation is the firing or arrhythmogenic focus inside the pulmonary vein. We try to isolate pulmonary veins electrically from the left atrium. We put a catheter inside, record the potentials inside the pulmonary vein. Once you know you are inside the pulmonary vein, we take the cryo balloon. The cryo balloon is taken inside. We occlude the pulmonary vein. We check how well we occluded the pulmonary vein. Once you occluded the pulmonary vein, we deliver a cryo energy. Once you start delivering cryo energy, you can see how the pulmonary vein gets isolated. There's another picture on the side where you can see some electrograms are shown. Few electrograms have been already shown. Whenever you see a recording from the pulmonary veins, you will record something called a pulmonary vein potentials, which are marker for electrical activity inside the pulmonary veins. When you start freezing, then you will see that pulmonary veins are getting isolated from the LA endocardial tissue. So you know you have achieved a good pulmonary vein isolation. So this pulmonary vein isolation by a cryoballoon is long lasting. So a lot of studies are there which have shown that when you have done a pulmonary vein isolation with a cryoballoon, and when patient gets an AF recurrence, you go and check your pulmonary veins. Most of the time they are totally isolated. The AF is coming from some other location. So this is how it is done. So cryoablation is better in compared to radiofrequency, because It offers some unique advantages: shorter procedure time, you preserve a extracellular matrix, thereby reduce the incidence of thrombus, and your, as I told you, your cryo balloon induced pulmonary vein isolations are long lasting. So already we have seen some cases, so I'll not go into detail. This is how it looks like when you do a pulmonary vein isolation. You have electrically connected pulmonary veins with LA. The moment you do a isolation, you can see gray areas which are extending from the pulmonary vein ostium into the LA. One other good thing you see with pulmonary vein isolation by cryoballoon is you take care of good amount of posterior wall of left atrium. We all know posterior wall of left atrium can be arrhythmogenic in patients with atrial fibrillation, because cryoballoon, the balloons are bigger, 28 millimeter balloon. When you deliver a cryo energy, a significant portion of posterior wall also gets isolated from the pulmonary vein along with pulmonary veins. So you get a better results than a radio frequency ablation where you deliver a antral isolations. So this is the reason why single procedure freedom from ATAF or AFL across globe has been pretty good. There are centers which are reporting success rate as close to 90% across the globe. This is another reason why the global numbers for cryoablation have significantly gone up. Now we have more than 100 literature, peer-reviewed journals which quote cryoablation as a therapy. More than 14 years of experience, and in India we have experience close to 2.5 years now, and around 80 plus countries along with India now using cryoballoon as a source for energy for doing a pulmonary vein isolation. So this is how you do a AF management in present times. You can have a permanent or non-permanent AF. If a permanent AF which is asymptomatic and heart rates are doing well and patient LV function is okay, you continue with the rate control drugs. If you are not able to maintain a asymptomatic status with the rate controlling drug, sometimes you may have to resort with the AV nodal ablation. If a patient with a non-permanent AF is asymptomatic, you can continue with your rate controlling drug. If the patient is symptomatic, you can move on to a rhythm control strategy where you can use either a antiarrhythmic therapy or a pulmonary vein isolation. If doesn't work, then you can consider in these group of patients also an AV nodal ablation. So this is how AF is managed now. Previously, a patient with a non-permanent or paroxysmal AF comes for a treatment. You will look at the symptoms. You use rate control drugs. If patient is still symptomatic, you will consider antiarrhythmics, and still symptomatic, you will consider ablation. Now what we are doing, a patient with paroxysmal AF comes with symptoms, you use rate control. If patient is still symptomatic, you will consider adding a rhythm control either with an antiarrhythmic or an ablation. If a patient is still symptomatic, then you can consider either of them. If the patient you have used antiarrhythmic, symptomatic, you use catheter ablation. After catheter ablation, patient develops recurrent AF or a recurrence of symptom, you use antiarrhythmics. How we are looking at future, if a patient with paroxysmal atrial fibrillation comes, you can use rhythm control as a primary strategy. On rhythm control, you with cryoballoon with such a safety record, which Dr. Nambudri has already shown, you can consider as a primary mode of ablation. If the patient recurs with rhythm control strategies, then you can use rate control as a last resort. This is for, you should always remember, this is for a proximal atrial fibrillation. We are not talking about a permanent form of atrial fibrillation where your success rate of most of the rhythm control strategies are not good. Why we consider this? Because of excellent safety record of cryoablation. You could see in most of the trials, the adverse reactions with antiarrhythmic therapy and cryoablation are comparable. You could see that 3 and 4%. So, lot of studies have come, and the recent studies have shown cryoablation is superior to antiarrhythmic therapy in prevention of atrial arrhythmia recurrence. First line cryoablation was associated with a larger improvements in AF specific quality of life compared to antiarrhythmic therapy. More patients were asymptomatic at 12 months post blanking period in cryoablation arm than antiarrhythmic therapies. So with this, a cryoablation can become a first line rhythm control strategy with an acceptable safety profile. With this, I'll close my talk. We'll go on with the next talk, and if there are any questions, we'll take the questions at the last. So let me invite Dr. Jaishankar for the next talk. It is about drug therapy for atrial fibrillation, both rate and rhythm control. Thank you.
Thank you, Dr. Lawrence, for inviting me. Respected chairpersons, dear friends, much of what I'm going to speak has already been discussed. So my job is simplified. So try to rush through because I'm standing between you and the sumptuous lunch. So the epidemiology of atrial fibrillation, I think, is now well known and understood. So epidemiology is what determines, and we understand the enormity of the problem. It is the most common sustained arrhythmia now. As has been told in the previous two talks, there's a paradigm shift evolving in favor of rhythm control rather than rate control for even a new onset atrial fibrillation. The prevalence, I'm sure we see it's ever increasing. I don't have to go into it. And what's important is the lifetime risk of developing atrial fibrillation is pretty high, from a prevalence of about 1 to 2 at age 80. It's something like 10 per 1,000. So the prevalence is going to ever increase as the aging population increases. The risk factors for incident AF, this is given in all standard textbooks, but importantly highlighted by the ESC. Aging is a very important risk factor, and we're going to have all the so many comorbids which affect atrial fibrillation. So this determine the eventual success of us favoring rhythm control. Why it is important to treat atrial fibrillation? Because the outcomes are pretty pathetic, even in asymptomatic patients. To symptomatic patients, they can be directly or indirectly responsible for death, can cause stroke, we all know that, LV dysfunction, heart failure, cognitive decline, depression, impairment of quality of life, and frequent recurrent hospitalization. So that needs to be borne in mind too, and that's the reason we try to maintain these patients in sinus rhythm all the time. The contribution of individual risk factors to development and sustenance of atrial fibrillation is very important to understand, because it translates into poorer control when we are going to adapt a rhythm control strategy. For example, if a patient has all of this and I'm trying to achieve a rhythm control, is going to be very difficult. It's foolhardy. So I have to have a very judicious approach right from day one, from the word go, whether I can maintain and sustain these patients in sinus rhythm. So these factors, they act in isolation, and when they are multiple factors together all the time, they are multiplicative, and our response to rhythm control strategy is not going to be favorable. If you look at the recommendations, catheter ablation for as far as pulmonary vein isolation, whether it is fire or ice, whether RFA or cryoablation, is strongly recommended. Class 1 for rhythm control after one failed or intolerant class 1 or class 3 antiarrhythmic drug. So it's very important. Even today the guidelines are very clear. We need to try one drug unless the patient himself asks for an ablation upfront. So paroxysmal AF, the subset of patients whose left atrium is not big, who are the ones who respond best. Persistent AF without major risk factors. I showed you so many risk factors there, so we have to scratch our heads and see if the patient fits into this the criteria for a favorable rhythm control approach. And persistent AF with major risk factors for recurrent atrial fibrillation despite ablations in the past. So AF catheter ablation at this point of time after drug therapy of failure, because that's what it's readily available with us, and that's what, and this has been shown before. We have to understand this. If these patients, this is the subset of patients, younger patient as told earlier, tachycardiomyopathy, LV dysfunction, disabling symptoms, recurrent AF, rate control difficult to achieve, patient's preference, recurrent heart failure, not many comorbidities, you can offer them AF ablation. That's a general rule, and age less than or equal to 65, these patients do well. Anything above that, it's very difficult. Rhythm control is recommended for symptom relief and improvement in quality of life in symptomatic patients with AF. Class 1 indication. How we achieve the rhythm control is our problem. So there are certain set principles of antiarrhythmic drug therapy. It aims to reduce AF related symptoms. The efficacy of antiarrhythmic therapies is at the best modest. So that's very important. It is not as good, not as effective as ablation. Clinically successful antiarrhythmic drug therapy can reduce or eliminate AF recurrences. That's why we persist with these drugs even after successful ablation for a period of 3 to 6 months. If one drug fails, we are duty bound to try other group of drugs so that we can achieve rhythm control. More importantly, drug-induced proarrhythmia should be borne in mind, and extra cardiac side effects with the most common drug, amiodarone, should be borne in mind. Safety rather than efficacy should primarily guide the choice of antiarrhythmic drug therapy. So, we have to see there are certain rules when we initiate the drugs. Is the patient symptomatic? Is it symptomatic enough to warrant an antiarrhythmic drug? When to start the drug? Usually not the first episode, but can enhance the efficacy for cardioversion if you want to. If you want to make sure the cardioversion works, maybe give them antiarrhythmic drug along with anticoagulation before you electively cardiovert. And how do I choose the drug? Minimal or no proarrhythmia, no organ toxicity. All the time look at the QRS duration, baseline, look for the PR interval, look for the QTC before you initiate the class of antiarrhythmic drug you would like to. What is the LV function upfront, and what are the pharmacokinetic and pharmacodynamic interaction of these antiarrhythmic drugs with anticoagulants, which you have to use in all the time. And proarrhythmia, as I said, this risk of proarrhythmia changes from time to time. So every time we have to, when we see the patients, we have to evaluate for proarrhythmia as well. So how do I minimize proarrhythmic risk? Evaluate the ECG before initiation and during every clinic visit. Evaluate periodically for organ toxicity, particularly amiodarone. Amiodarone is perhaps the most unsafe drug which causes toxic side effects head to foot. So we have to be knowing the side effects in great detail. Long-term Holter monitoring may be required. Avoid combination of antiarrhythmic drugs, so you may have potentially risky complications. How do I verify the efficacy? You have to estimate the burden of AF during therapy, ask the patient symptoms, and also keep doing monitoring. And any adjuvant interventions that I may do, yes, all the time, if patient has concomitant sinus node dysfunction or conduction disturbances, may start thinking of pacemaker along with antiarrhythmic drug therapy. And short term, as I said earlier, antiarrhythmic drug therapy can and be useful along with AF ablation. This slide has also been shown before, but then these two trials, AFCHF and Japanese rhythm, these both have heavily favored impacted our decision making in favor of rhythm control strategy. They are able to maintain rhythm control in close to 70% of patients if the patients are maintained, taken down the route of either ablation or pharmacotherapy as well. So amiodarone is recommended for long-term rhythm control in all AF patients, particularly those with reduced ejection fraction. So if you have a patient with LV dysfunction, the one safe drug in LV dysfunction with AF is going to be amiodarone, but the extra cardiac side effects need to be borne in mind, and wherever possible we should consider other antiarrhythmic drugs. So if you look at one by one, what are the drugs which can restore the patient to sinus rhythm? The pharmacological cardioversion, oral or intravenous flecainide, the class 1C drug flecainide propofenone. The dosages are given there. We have to see whether we are using this kind of doses. We are using actually 1/3 the dose, which is not correct. So we have to use the right dose. And what the caution is, patients should not have underlying ischemic heart disease. They should not have underlying structural heart disease. They should not have LV dysfunction. More importantly, if you use this class of drugs in atrial flutter, you can actually enhance the conduction down the node, can cause 1:1 conduction. All the time these patients, when you use class 1C drug for rapid atrial flutter, you should have concomitant AV nodal blocking drugs. Can cause QRS widening. Do not use for pharmacological cardioversion of atrial flutter, preferably for atrial fibrillation. So the other drug which we routinely use is amiodarone. The dose is pretty high. Again, we have to see what kind of dose, and acute success only 40%. Can cause phlebitis, so we have to use in a big vein. It has to be preferably a brachial or one of the jugulars. Preferably use an infusion pump. Can cause hypotension, bradycardia, AV block, and QT prolongation. Thankfully, amiodarone is not as proarrhythmic as the other drugs. And if the patient has hyperthyroidism, it can cause thyrotoxicosis, so we have to have that in mind. And more importantly, it can take up to a week before the patient goes into sinus rhythm, because it has got a mere 40% reversal rate to sinus rhythm. Ibutilide is a good drug which is available now, 0.01 milligram per kilogram body weight for those less than 60 kilogram. You give 1 mg over 10 minutes by an infusion pump. Success rate for fibrillation is about 50%, for flutter is better. So if you have a flutter, ibutylide, if you don't want to cardiovert, is a good drug, and it's perhaps more effective than any other pharmacological agent for atrial flutter. Amiodarone, when we give oral formulation, it has to be given something like 200 milligram 3 times a day for a month, and then 200 milligram once a day thereafter. It is perhaps the most effective antiarrhythmic drug. It is safe in patients with heart failure. Concomitant use with oral anticoagulant and digitalis, we should be careful because the dose needs to be reduced. Can cause torsades, but luckily compared to other antiarrhythmic drugs, the incidence of torsades is very less with amiodarone. But whenever the QT gets prolonged, more than 500, QTC rather, more than 500 millisecond, we need to be wary of. We will have to down titrate or even perhaps stop the drug. When you have a hyperthyroidism in the background, better to avoid amiodarone. And flecainide for long term maintenance of sinus rhythm has to be something like 100 to 200 milligram twice a day. It helps in prevention of recurrent AF. Should not be used in patients with CKD. It's contraindicated when the patient has a EF less than 45. If the patient has a baseline QRS prolonged, we should keep monitoring. If the QRS gets prolonged by 25 to 30% more than baseline, we have to stop the drug because it can cause torsades, and which can be troublesome, particularly when you give an oral formulation. So these patients need to be seen at frequent intervals. For atrial flutter, as I said earlier on, it can increases flutter cycle length so all the time and can cause 1:1 AV conduction. So better to use with the AV nodal blocking drug. Otherwise, you can have trouble, as we had trouble in one small child. She was treated elsewhere. She came with this ECG to begin with. She was on flecainide, and she's been then this was the ECG subsequently. She was on flecainide without a AV nodal blocking drug, and that was the ECG after cardioversion. This is the ECG she presented with. She presented with syncope, had to be cardioverted. There was a lot of debate, and then once we cardioverted, we started looking at the flutter waves, and then she went on to have ablation of the atrial flutter. So when we use flecainide or propofenone, particularly if it's flutter, all the time use the AV nodal blocking drug along with it. Propofenone works similar to flecainide. Again, the caution is should not be used in liver and renal disease background, and the dose is pretty stiff, 300 milligram 3 times a day, and the maintenance to sinus rhythm long term is between 40 to 50% at the best. Do not use with underlying structurally abnormal heart. Do not use in LV dysfunction. Do not use when the QRS is prolonged, or the QRS get prolonged at follow up 25 to 30% more from baseline. So again, propofenone also similar to flecainide. For flutter, if you are going to use, you should not use without AV nodal blocking drugs. But can also cause 1:1 AV conduction because it increases cycle length and can cause trouble. Dronedarone has since been taken away from our market. It is less effective than amiodarone, but has less side effects because it doesn't contain the iodine moiety. But those with heart failure, this drug doesn't work at all. It is one of the good drugs which came in the past about a decade ago for paroxysmal AF, but not for rhythm control. It has got a good safety data, but it is not as efficacious as amiodarone. So can be used when we use anticoagulant, should not use with dabigatran because it potentiates the effect of dabigatran several fold. When we use along with other blocking AV nodal blocking drugs like digitalis or beta blocker, we need to lessen the dose of dabigatran, dronedarone. There's a small but definite increase in serum creatinine when these patients are on dronedarone, but that's not a cause for big worry. So basically, dronedarone for those paroxysmal AF with a structurally normal heart when we don't want to use amiodarone. Sotalol is the other class 3 drug. It got beta blocking property as well, but it works as a class 3 agent only when the drug dose is more than 160 milligram per day. So if you're going to give 40 milligram once or twice a day, you're not going to achieve the class 3 effect of sotalol. It may not be effective. Importantly, it can cause torsades much more than amiodarone by virtue of it causing hypokalemia. So we have to monitor the potassium levels all the time when we give sotalol, and it can cause QT prolongation because of its effect on potassium. It causes hypokalemia as well. So it's better not to be used in reduced ejection fraction heart failure. where amiodarone scores over it, particularly patient has significant LVH and baseline prolonged QT interval, or baseline hypokalemia, or if the eGFR is less than 30 ml per minute. So many ifs and buts for sotalol. It's again, it's a potassium channel blocking drug, increases with increasing dose, and consequently the risk of proarrhythmia also increases when we use higher dose of sotalol. Disopyramide is also quite a good drug, and this is particularly useful in vaguely mediated AF and particularly hypertrophic obstructive cardiomyopathy, where it's believed to reduce the outflow tract obstruction. There is a higher mortality with disopyramide, hence this drug is not preferred. It has got atropine-like mechanism. And what is the indication for long-term rhythm control, which this has been discussed earlier on? We have to assess and treat all the risk factors and the comorbids. We have to use other drugs which are also have a favorable effect, like RAS blockers, mineralocorticoid receptor antagonists. There is some role for statins, but then it has been debated all the time, and we have to assess whether the patient has minimal or no heart disease, no structural heart disease, whether the patient has reduced ejection fraction or not, whether the preserved ejection fraction or not. Structurally normal heart, we can see the kind of pharmacotherapy which is a class 1A indication. Of course, dronedarone is there on top, which is not available in our country anymore because it's not as efficacious. And catheter ablation all the time scores over pharmacotherapy, so we have to have that in the back of our mind. And if the patient has reduced ejection fraction, the only drug you can safely give to the patient is amiodarone, or else offer them catheter ablation. The non-antiarrhythmic drugs which were believed to have favorable effect in atrial fibrillation, ARBs did not reduce. So there was some talk in the past that receptor blockers can reduce incidence of AF, but that has now been negated. Similarly, if you look at beta blockers, though it controls the rate, most evidence now pleads against a significant role of beta blockers in preventing AF. It's only going to control the AF rate of AF. It's not going to abolish AF altogether. So mineralocorticoid receptor antagonists, by reduction of atrial fibrosis, have some effect in reducing the burden of atrial arrhythmias. Statins have failed to show a beneficial effect. So it's very important. Statins have to be used as part of risk factor modification. It cannot be used in isolation for control of paroxysmal AF. So strong recommendations for antiarrhythmic drugs, class 1 level of evidence A, flecainide or propafenone, the 1C drug for long-term rhythm control, those only with normal LV function, because we do not want to buy the extra cardiac side effects of amiodarone. The moment the patient has LV dysfunction, we are looking at amiodarone as the only drug. We are not going to look at other drug. If amiodarone fails, then we are probably looking at catheter ablation of some sort. Dronedarone is recommended for rhythm control in place of amiodarone in those with normal or mildly impaired EF, but this is not available in a country. So this slide has been shown how we handle permanent from non-permanent AFs. I will not delve into it, but there are a subset of patients who do not do well with any rhythm control strategy, whether it is ablation or pharmacotherapy. You need to resort to AV node ablation and then give them pacemaker of some sort. If the EF is less than 45, we give them CRT. If the EF is above 45, we may do maybe a one lead pacing, probably a conduction system pacing. This slide also has been told very clearly. We have to draw our attention only to this half of the slide. Dr. Lawrence spoke elegantly about this. Whenever there's a poor rhythm control, then only we think of rate control. All the time we should try and achieve rhythm control. Of course, using rate control strategy along with rhythm control, whether it is by way of drugs or ablation. There are futuristic drugs in the pipeline, before I wind up, where we are looking at safe and effective alternative antiarrhythmic drug therapy. There are what is called small conduction calcium activated potassium channel inhibitors. They are showing promise. There's a TWIC related acid sensitive potassium channel inhibitors like potassium channel inhibitors, amiodarone and sotalol. Slow sodium channel inhibition, which acts on the phase 0, and multi-channel inhibitors acting on all the channels of the action potential. Thereby, in some areas it prolongs the action potential, some areas reduces the action potential. Thereby, it can get rid of AF on a long term. So there is a paradigm shift underway towards offering early rhythm control to all patients with recent diagnosed AF, which is at the moment not reflected in current guidelines. all the time, all of us who treat AF want to have our patients in sinus rhythm. There is overwhelming evidence which supports early intervention in all patients with AF that has not become long-standing. We should intervene early to prevent irreversible structural atrial cardiomyopathy, or those who have unmanageable symptoms, or who have a stroke or are at a risk of stroke. So all the time CHATS2 VAS has to be factored in. The continued evolution of treatment for atrial fibrillation, this very highly complex disease, will result in antiarrhythmic drugs with a better safety profile than previously available, because our patients do not have access to interventions of all kinds. Improved ablation in the form of cryo has been so elegantly shown by the previous two speakers, probably is the right way forward, where we can, without even offering pharmacotherapy, offer cryoablation upfront, so that we can not only reduce the AF burden, we can virtually eliminate AF recurrences, especially when we deliver it early in the course of the disease process. Thank you very much. I'll be happy to take questions if any.
Jaishankar, majority of our patients come to the OP with atrial fibrillation, start them on antiarrhythmic drug, they are controlled. No symptoms, no structural heart disease. How long do you continue amiodarone? Do you want to control till they develop side effects, or is there any study which has shown
so it's very
if
difficult.
there is no recurrence, only one episode, majority of them come like that only?
So very difficult, because we will have to keep monitoring and seeing if they are having any asymptomatic burden. So we know that 6 minutes of sustained AF is enough to cause stroke. So you will have to do some sort of monitoring. It has to be a Holter or a ELR or prolonged monitoring before you cut down on the dose of amiodarone. If the patient has a substrate for recurrent AF, I for one would persist with the drug, because I know it has maintained him. I may switch over from amiodarone to a friendlier drug, particularly if it is a structurally normal heart. But coming off the antiarrhythmic drug, I'll be a little worried if he has. So I'll do the CHATS2 VAS evaluation all the time. I'll probably monitor off and on for asymptomatic recurrences. And if it's a structurally normal heart, I'll switch over from amiodarone to a friendlier drug. But I may not come off the drug.
But not beta blocker.
Beta blocker,
you have shown clearly it doesn't.
At the best, it will control the rate, but it's not going to keep him in sinus rhythm. I mean, that's known.
The next is a very basic question. We all were doing maze operation and other things, thinking it is the islets of atrial tissue which has been separated, right? How did this theory of pulmonary vein started?
I think Dr. Nambudiri showed Hasagar's paper.
Yeah, but what struck him that it is emanating? Because it's not a conduction tissue, it's a vascular tissue.
No, there are.
And why should you ablate all the 4 pulmonary veins?
No, embryologically, there are atrial myofibers inside the pulmonary vein. I think you will.
Yeah. In fact, maze operation evolved in 1980s, even 80s and 90s people were doing, but predominantly in a structurally abnormal heart, maze 1 to maze 4. But this Hasagure's observation that this pulmonary vein triggers the ectopic coming from the pulmonary vein could initiate and perpetuate atrial fibrillation. It is primarily due to that anisotropic conduction, what we call. Once it comes to these triggers, once they come to atrium, if the frequency is shorter, I mean the cycle length is shorter than the atrial refractory period, if a wavelet comes faster than that, it breaks down. It causes fibrillatory degeneration. So it is anisotropic conduction at the antrum. That is, antrum is actually the fusion between the pulmonary vein, musculature and the atrial. So they may not be very linear. There you can have altered conduction properties. It causes fibrillatory degeneration. That is why a faster trigger point, like the case I had shown, those ectopics, breaks down into atrial fibrillation. If you throw stones into a pond, faster than that could dissipate, the wavelets could dissipate, then it can go into aortic contraction. Exactly that what happens. And he could reproducibly show that ablating these could terminate and make them AFib free.
So just to add to that, it's very interesting that you asked, why do you want to ablate all the 4 pulmonary veins? It takes me back to the time in 2008, I presented a paper saying culprit pulmonary vein isolation, atrial fibrillation. I remember Nambudiri There's this thing called culprit. I remember you asked me this. Culprit pulmonary vein isolation. So there was a concept like that at that time. You put a catheter in the pulmonary vein, see which vein is firing, and try to get a vein to fire by giving isoprenol and ablate that. But then later on, people realize that veins are often dormant. A vein which fires today may not fire tomorrow, and a vein which does not fire for the next 3 years may start firing the fourth year. So the concept changed to, okay, if you're going to go in, just isolate all the 4 veins and come.
It's three first class talks, and after these talks, I'm asking for these large number of physicians here. When they see an atrial fibrillation, paroxysmal, symptomatic, what should they do? Should they refer for ablation? Should they start drugs and anticoagulation? And if it is drug, there are only two options: amiodarone versus flecainide plus. And I think beta blocker, the most important indication is to give it along with flecainide when we use flecainide, because we cannot use flecainide alone. So flecainide plus beta blocker versus amiodarone is the drug therapy. Then who should be definitely referred for ablation? This patient is for ablation, no doubt. When you see such a patient, you should refer him for ablation. Who should be that?
Well, you have to see which are the patients who are going to have recurrence. You have to see the risk factors, and if the patient is going to have all the risk factors, then he is the guy who you have to be aggressive about. Even before I start antiarrhythmic drug, I am going to see whether he qualifies for an anticoagulation more than antiarrhythmic, because the effect of antiarrhythmic drug is at best modest. Nothing is going to be as good as the ablation. That much is sure. The reason we are discussing about pharmacotherapy is our patients do not have access to this therapy. Even when they come to us, we are not able to offer them this therapy for so many logistics. So antiarrhythmic drug, the simple thing is estimation of LV function, estimation of left atrial size, look at the risk factors, anticoagulation as per the CHATS2, and there are only two group of antiarrhythmic drugs. We are looking at class 1C or class 3. LV dysfunction, amiodarone; no LV dysfunction, flecainide, encainide, or no encainide, flecainide and propafenone. More than failure of one anti-drug therapy, straight away he goes for ablation. And even before he sent, if you go to achieve or maintain a rhythm control, whether he will maintain a rhythm control is what you see. And if he has, say, obese, he has got all the risk factors, you may not be successful even after an ablation. So that we have to have in mind. So LV function assessment is going to decide the type of pharmacotherapy. CHATS2 VASC will decide about requirement for anticoagulation.
And just taking it from what Dr. Jabir asked, I think we were just discussing the combination of putting a patient on a beta blocker plus flecainide. I think it's for the larger physician audience also. Sometimes in an elderly, you really have to be worried about the bradycardic episodes. This we have seen with fairly, a small dose of flecainide may be all right, but I think rather than trying to control them with a combination of these two, I think this is probably if you think that somebody needs more than one drug, that's a time when I think you should really be taking a referral. I think it's a very pertinent thing to do at that point of time.
Well, if we are going to not give the therapeutic dose of flecainide, you will not be able to maintain him in sinus rhythm.
The problem
You're
is
only going to buy the side effect of flecainide. So you have to do away with beta blocker.
Yeah.
Go up on the dose of flecainide as is described. So if you're going to give 50 milligram twice or thrice, it is not going to be effective.
But then I think in an elderly, we sometimes tend to
So
see
there
this,
is a time when they go into profound bradycardia, they will need one lead inside, a pacing lead, and then give the antiarrhythmic drug. That's what I said. Some of them will not respond to.
I think by the guidelines, the recommended dose is 200 milligram BD. But primarily it depends upon the basis sinus function. Like, if the sinus function is very good, they may tolerate slightly higher. Another pharmacological property, as sir mentioned, is if they have underlying sinus node dysfunction, flecainide can be very dangerous, especially regarding the post-termination process. We have seen they get exaggerated. This is primarily because of a property of use dependence of the flecainide. If the rate is very high, if the action potential frequency is quite fast, the sodium conductance as such would come down. So sodium, the most potent sodium channel blocker is flecainide. The most potent available sodium channel blocker, class 1C drug flecainide. So this will become very effective, and sinus recovery takes longer time. That is why patients already having an underlying sinus node dysfunction, if they somehow develop a breakdown AFib episode, the post-termination pause will be profound. We had patients going to ventilatory support because of the extreme bradycardia in this subset.
I think a pill in pocket is a very
good strategy.
Flecainide works best as a pill in pocket.
No, but this is the point I wanted to convey. Sometimes it's really frightening the kind of brady episode that it produces.
I mean, if you use pill in pocket, this is not going to happen. If you're going to maintain, you want to maintain sinus rhythm on flecainide, then this is going to happen.
No, particularly when it terminates. We have had episodes where they just gone in for
if for paroxysmal AF, it's a pill in pocket, this will not happen. Already the blood levels are there, then it's going to happen.
Dr. Nambudiri, I want to ask a question. Your data of 37 patients, 3 had recurrence, 1 had a TIA. So what is your anticoagulation strategy? Will you take off the anticoagulation after some time, or will you stop the anticoagulation after the radiofrequency ablation, or continue it, or only in a particular subset of patients you continue?
As a principle, anticoagulation strategy is totally independent of AFib ablation. It is based upon the chart score on it. This patient who developed a TIA had only one of the risk factors like hypertension or something, and chart score was 1 only. But having said that, in a rare case like a 25-year-old, 30-year-old having ablated something, and we generally put them all on oral anticoagulation for 3 months, even amiodarone or flecainide for 3 months, and then take off. That is actually the observation period. And after that window therapy, that window phase, if they develop, then only we reassess them. We generally don't take off oral anticoagulation after AFib ablation. That was just a patient that happened like that. Chart score was 1. Otherwise, also this patient was not indicated for a oral anticoagulation.
So one old question is the patients are digoxin verapamil combination, which we are using from our MD cardiology. Some of the patients still with the digoxin verapamil unstable. Whether I can continue it scientifically, I'm correct, or I have to switch over to amiodarone or other antiarrhythmic drugs.
As it is, it's a bad combination. Yeah, but no, it's because we are looking at 2 AV nodal blocking drugs. And on top of that, if you're going to add warfarin, that's going to be potentially harmful to the patient. So it's more harm than good. Now, next we have to see whether that's gone to permanent AF or we're talking about only a rate control. The only role we see for digoxin in atrial fibrillation is in the background of LV dysfunction. The LV function is normal. Digoxin is of no use. So I am looking at a rate control strategy in this patient. Patient has LV dysfunction, it is going to be beta blocker or digoxin. No LV dysfunction, is going to be either beta blocker or calcium channel blocker.
Let's say possibly one scenario, rheumatic heart disease with an atrial fibrillation. Yeah, digoxin works, and of course a combination of verapamil there. Sometimes some of them have bronchospasm.
Along with this warfarin, you're asking for trouble. That's when the INR is going to go haywire.
I think the principle is we have to individualize based upon the substrate. Look, certain scenarios like a patient amiodarone is actually a class 3 in the sense it's a contraindicated for rate control. But certain cases like when you have problems related to beta blocker or verapamil, significant RV dysfunction, rheumatic heart disease, post-Fontaine cases, these cases we like to use even amiodarone for rate control, not for rhythm control. But as per guideline, it is a contraindication.
Just to, what about ranolazine? In fact, some of them post-operative atrial fibrillation. Do you really use it these days?
I stopped using it. I also used to use it when there was about a period of time when there was a fancy of saying that, okay, a small dose of ranolazine would help in control of AF. I also used it at that time, but I now stopped using it because I don't really think it works.
It's VT post ACS, post So ranolazine has been mentioned as a pill in the pocket, 2 grams. Is it so it's worth using? It has been mentioned as a pill in the pocket, 2 grams stat.
I don't think there's any recent recommendation under that. Would be very old literature. There was a time in literature when ranolazine was proposed for treatment of atrial fibrillation.
Particularly for CABG. Post CABG atrial fibrillation, people told that 2 grams stat may convert atrial fibrillation. but I think a lot of us have used. I think we have not found it very useful. I think amiodarone is much better, safer, and in a early phase of maybe post CABG or a post PCA situation, cardioversion is much more desired than trying this. So we no longer use ranolazine as a antiarrhythmic for an atrial fibrillation. I think maybe 3-4 years back there were a lot of talks about this, and I think nowadays guidelines also don't mention anything about ranolazine.
Sir, is there who are the group of patients whom you don't want to refer for straight away for ablation, non-permanent AF?
See, you are asking about contraindication for ablation for proximal AF.
Yes.
Yeah. Proximal AF, I think there are some patients with proximal AF, even though they are paroxysmal, we have seen a larger LAs. So when they have a large dilated LAs, they don't well respond to catheter ablation by any modality. Second, the patients who have a clot. So Dr. Nambudiri sir was saying, I have one patient who is 36-year-old female with a proximal atrial fibrillation. CT done shows a clot in the LA appendage. I have not started on anticoagulation also because CHAT scores does not deserve anticoagulation for the particular patient. But she had a LA appendage clot. So some patients develop. I think when I was discussing with other colleagues across globe, they told that whenever they plan a ablation for any patient for a proximal atrial fibrillation, also they keep the patient on anticoagulation until they get ready or until they are willing, or some people they are a waiting list for ablation. So these patients you cannot take them for an ablation. They have a clot inside the thing. Otherwise, most of the proximal atrial fibrillations you tend to see a very smaller LAs, and I think Dr. Nambudiri sir also will accept. I think our age group of proximal AF is pretty low. I think I have out of our 28 patients with cryo so far, I think I have significant number of patients who are less than 45. And we have a significant group of patients with proximal AF in our population, at least, who are younger than the Western population. I think one thing we have to be very careful about AF is you don't allow them to be in AF for a longer period of time, young also. So you allow a 40-year-old to be in AF for another 8 to 10 years, you will end up at 50 years. I have a patient with a permanent AF at the age of 48 who has been diagnosed with PAF at 40. So it's as told, I think the drugs are very difficult to keep on for a longer period of time, except flecainide and propafenone. Amiodarone, you don't want to keep them for a longer period of time. With amiodarone low dose, they tend to recur. And amiodarone is such a kind of a drug. I feel some of our patients are addicted to amiodarone kind of a thing. You see a 50 mg amiodarone and you pull off amiodarone, patient recurs. Not only AF, VT. So you will see a patient who has just kept on 50 mg of amiodarone. You just take amio, then next week he comes back with an episode of AF or a VT. So I think all eligible patients with proximal AF, particularly young, should be considered for a ablation strategy. There are very few limitations and very few contraindications.
Any young patient, obesity, obstructive sleep apnea, and alcohol intake. These three things should be actively looked for and should be corrected before taking for a definite strategy. I mean, some of them are not correctable. So we have to adopt a different strategy like
rate of recurrence after ablation, sir. After ablation, the rate of recurrence, or will it offer a permanent cure, or there will be recurrence?
Sir, as I mentioned,
what about evaporating?
Atrial fibrillation is a spectrum of illness. The clinical spectrum, the landscape of quite varied, as I mentioned. So some patients having a pulmonary vein tachycardia in the initial course of illness, before the substrate changes happen in the atria, it is curative. It depends on the denominator, the percentage, but this happens, as Dr. Lawrence mentioned, young patients having pulmonary vein tachycardia leading on to fibrillary degeneration, like Hasaguri's article. It is curative, I should say. But in between, some of these cases, substrate changes are less, and pulmonary vein tachycardia, it controls the symptoms very well. In the subgroup, our series that I mentioned, this 90% of them remain in sinus rhythm with a limited, not more than 50 milligram of amiodarone or 100 milligram of flecainide in absolute sinus rhythm at the end of 1 year.
But so what about Evaporatin, read about evaporatin, sir.
Evaporatin
Inhibiting
has got
permanent
only
ATP.
one action, sir. It actually, this funny channels are inhibited. These patients actually, this will act only in an automatic tachycardia. In atrial fibrillation of non-automatic origin mechanism, it doesn't have any action.
It may induce even atrial fibrillation, isn't it? Dr. Lawrence, for example, a patient, young patient who is in a particular job like a loco pilot or a person who is flying an aeroplane or who is involved in public transport driving. So when they develop paroxysmal atrial fibrillation, it's better to go and ablate straight
True.
away.
Very true, sir. Very true. Like, kind of like that's what we are seeing. The recommendations are becoming pretty aggressive now. I think if you look at the ablation recommendation for atrial fibrillation, that's becoming more and more aggressive. That's what I was talking about future, because there's if cryo or next PFA is coming, these technologies are going to reduce the risk of or what do you say the complications. Then our recommendations are going to be more like how AV nodal reentry was there. We know AV nodal reentry initial recommendation. You will say recurrence on antiarrhythmic drug, patient wishes and all that. Now it's a class 1 recommendation. Any patient, first episode of AV nodal reentry, you can take him for ablation, not because of change in the disease, the way we delivered the therapy. The AV nodal ablation, AV slow pathway modification has become such a safe procedure that now it has become a universal recommendation. Same way, if AF ablation becomes more and more safer, I think we'll offer to more patients. And these are the group of patients who has to be offered present situation also. Even with the present, one thing what cryo was delivering was, which RFA could not deliver, is the expertise you need. The results of cryoablations, even on people who are starting, is as good as the experts. Where radiofrequency ablation delivers excellent results on a patient, on a people who do a very high volumes. Yeah, it's operator dependent. You need a very high volume to deliver a good results. In cryo, you don't need that because it's pretty anatomical. So that's the one thing which made cryo very good option. Second, that's the reason PFA is also coming in a big way, because these two options, once they come in, I think the recommendation will change very dramatically. I think with this, we'll close the discussion because we are running short of time for the lunch. Let me invite Dr. Jayagopal sir to felicitate Dr. Nambudiri sir. Sir, please stay on the stage. Jayagopal sir. Let me ask Dr. Jayagopal sir to felicitate our moderators. Dr. Pachepan sir, Dr. Krishna Kumar sir, Dr. Dr. Jagdishwari madam, Dr. Vikram Ingnesh, and Dr. Saranu Babu sir. And Dr. Suresh Kumar sir. Let me invite all of you to the lunch, which is at ballroom downstairs. We have an exit here. There are lifts and stairs which you take directly to the ballroom. I invite all you to join for the lunch and join us half an hour after the lunch for the next session on heart failure. Interesting 3 talks are there. So let me invite all you for the lunch and join us for post lunch session half an hour after the lunch. Thank you. Welcome all for the post lunch session. Let us start that session. Let me invite moderators for the session. Dr. Satish Kumar, Dr. Balaji Sundareshan, Dr. Vigneshwaran, Dr. Praveen Raja and Dr. Subaraja. So let me also invite Dr. Jayagopal sir for his talk on heart failure, initiation and titration of medical therapy in the present era.
Is it okay now? Yeah. At the outset, let me thank Dr. Lawrence for having invited me to take part in this academic session. Now, I know it's very difficult to keep you people awake after a heavy meal, and Lawrence has made sure that all of you guys are well fed. So anyway, let me go on to my task and of talking something about heart failure. The though this is the major epidemic of the country, and where cardiologists probably are going to be involved in a much bigger area, but I think this is a topic which is of equal importance to the physicians. Now, if you look at the scenario of the journey of heart failure, you know, right from the, I think the physician has an important role to not just diagnose heart failure, right from the time where there is no heart failure. For example, you have conditions which can be a stage A, where you could identify the risk factors like diabetes, high blood pressure, and then once the heart failure sets in, it's a journey where it's a continuum, you know, where the patient starts deteriorating if not properly attended to, and over a period of time they get into the sequence of worsening heart failure, and finally an advanced stage where perhaps there is nothing else to do except for a transplant or a mechanical device. So I think it's important for the physician to really identify this and look at this at a much more detailed manner. Now, I was fortunate enough to run a registry in this country where we studied more than 10,000 patients. And I must tell you that if you look at the heart failure today, the commonest is ischemic heart disease. So I think when you just see a patient, 90% of these heart failure patients have an abnormal ECG. So the moment you see somebody with breathlessness, I think the way to work up is just to look for an ischemic heart disease, because this is an eminently treatable condition where even if you think of the definitive therapy for heart failure, you need to sort it out. But unfortunately, these patients are not really worked up properly. That's why I thought that this should be the first thing that we need to attend to. Even in a country like United States, if you were looking at heart failure, only about 30% of them they get a coronary angiogram done. So this is very sad, because this is a treatable cause, and if you are able to have a patient who has who could be revascularized either by an angioplasty or surgery or even a good medical therapy, that's the first job. And of course, as physicians, you will be confronted with the problem of hypertension. This is no small deal today. I think about 35%, one third of our population. If you look at the latest Lancet endocrinology publication to 2003, you find that hypertension is close to the prevalence is about 30%. And of course, chronic kidney disease on the rise. You have an aging population, you're treating them well, they're surviving long. And of course, look for sometimes, reversible factors like, stress cardiomyopathy or thyroid. It is often neglected. So I think these workups are very important. I thought this should be the upfront thing before you start treating. Anemia, the very common thing. Arrhythmia. Sometimes, patients come to you with heart failure. You find we had a lengthy session on atrial fibrillation. These people are sometimes going in for paroxysmal atrial fibrillation. And if this is not recognized and treated, the heart failure improves. And of course, nutritional deficiencies, and of course, iron deficiency, which is a very major factor even in heart failure. So now, coming back to the definitive therapy, once you are diagnosed heart failure, I think today we know that there are foundational therapies. If you don't put them on any therapy, you find that 2 years, 35% of them they die. Whereas, if you start them, we call the AB, I would rather say it as A, B, C, D, in the sense that A is an ACE or ARB, B is a beta blocker, C is the mineral receptor antagonist, D is the SGL2 inhibitor. RNA would replace it's either A is ARB or RNA, which I'll come to a little later on. And of course, the D is the SGL2 inhibitor, the DAPA being the most cheaper drug available in the country. So you keep on adding this, you find the relative risk of the problems starts coming down, and then everything adds on, and so much so the 5-year mortality would definitely be less. The number needed to treat in this is just 4 out of 1 to get the desired reduction in therapy. So I think today in 2023 we are fairly clear. These are the pillars. RAS inhibitors, which I'm sure most of the patients today, most of the physicians would then start them on an ACE inhibitor. But I think those days are gone. Today RNA would be the first choice, beta blocker, MRA. These are the 4 pillars. And of course, the most important thing when you have a heart failure, they should also be decongested, because loop diuretic is important, not too much of a dosage, but at the right dosage. Let me just take you through a case scenario. This is a guy who had a young fellow, 44-year-old. No, I think seeing is believing. This patient had a old inferior wall myocardial infarction. We studied him by an angiogram, as I had mentioned earlier, rule out ischemic heart disease, but his arteries were fairly patent. But despite that, his LV had, once the insult happened, his LV deteriorated. He had heart failure. And in fact, so symptomatic. If you look at the ECG, the dilated, hardly contracting there, and you see the significant amount of mitral regurgitation. In fact, he was so symptomatic getting into the hospital. That is the time when we initiated him on this so-called 4 therapies, A, B, C, D. And initially we thought that this might end up in a transplant, the way he was going and all that. But you could see the difference over a period of time, remarkably improved. In 2021, within 3 years, he's back to about class 2 and back to his job. So I think that's the important message I want to tell you. If you put them on this appropriate therapy, you can at least improve their quality of life, halt the progression of the disease. That is what we are looking for in heart failure. And this is what we call as a guideline directed medical therapy, the 4 such agents. And you must understand that if you what you see on the right hand, the blue is what you see in green here is the guideline directed medical therapy. The moment you put them on guideline directed therapy, you find that all cause hospital, not just heart failure or cardiac, comes down. The cardiac also comes down. Not only that, the quality of life improves and the recurrent hospitalization also comes down. So I think that's the importance of really putting them to all these 4 drugs. And not only that, this is one of the most quoted articles today, Vadaganathan's article, where if you put them on all these 4 standard therapies, for example, a 54-year-old guy, you put them on that, you see the survival benefit is close to about 6.3. He gains another 6.3 years in life, which is a tremendous thing. Not only that, an event-free, a recurrent hospital event-free is even more, 8.3 years. So I think it's important to understand that somebody develops heart failure, it is the onus on the physician to put them on this 4 pillars of therapy to have a fairly decent quality of life, and that too, again, and also in terms of reduction of mortality. We just conducted this survey, which I was talking to you about it, and then we actually did this in 2 phases, 2018 to 19. This is the pre-COVID times. This is about 5,269. Subsequently, we had another 5,000, total 10,000 patient data all over the country. In fact, we had Kupasamy Naidu as one of the centers from Coimbatore. And we found that when you look at in India, what you find is, despite all this, even these are all tertiary care hospitals managed by cardiologists. You see that the RNE is a dismal 2.6%. The ACE ARB is about 42. Beta blocker is slightly on the higher side. And of course, they are all on a fairly large dose of diuretic. But the point I wanted to convey is that only 1/4 of our patients, even in the best centers in India, were only on this therapy. I think this is something which we need to understand. We still have to go a fairly longer duration to see that these are properly managed. And why is it so? When you look at the meaningful benefits of this foundation therapy, it is about, again, the physician should understand that somebody has heart failure, start them on this as early as possible, because the benefits start coming with an ACE as early as 14 days, beta blocker 28 days, mineral receptor antagonist 30 days. There's no point trying to put these patients beyond this. ARNI, even the first 30 days. SGLT inhibitors again. So within the first month, if you're able to get these patients on board, this has got a favorable effect in terms of outcomes. So because of all this, the American College of Cardiology, and they came out with the expert consensus pathway, where the question is how to switch on, how to achieve the optimal therapy, and that's exactly what I'm going to tell you in the next 10 minutes. So the major recommendation, I talked about the baseline therapy, but I think the major recommendation, the sea change that you should understand today is somebody has heart failure, don't wait them, start them putting on ACE, ARB, and then try to switch on. RNA becomes the first line, because today we know we have abundant data. RNA is a sacubitril valsartan angiotensin receptor blocker combination. So if you put them on this, this has a major achievement, and that's become the first line. Secondly, across somebody has heart failure. How do you diagnose heart failure? It's mostly a clinical diagnosis. And today, if you want to have, you don't need an echo. If you have to think in terms of an SGLT2 inhibitor, SGLT2 inhibitor, your molecule, which it could be any glyphosins, particularly DAPA or EMPA, across any spectrum of ejection fraction. The moment you have a heart failure, it is beneficial, whether it's a reduced ejection fraction or a preserved ejection fraction. And of course, the second important message, the third important message is you start them on low dose of everything at the same time. Now, this is all based on data, because the RNA, why I said start them initially, because the paradigm study, which was a study which compared this with an ACE inhibitor, enalapril, showed a 20% reduction. And today, I think we were all, when this medicine, the Vimada, got introduced, we were all scared to use this costly drug. But I tell you, the moment we started embracing this, the patient outcomes started looking better. And so much so
there was a 4.6% reduction in primary outcome. Out of 27 patients, number needed to treat was 1 in 27 to have the desired outcome. 20% decrease in sudden cardiac death. In fact, the only drug in heart failure which has shown a efficacy in sudden cardiac death is the beta blocker, but 20% decrease if you put them on ARNI. Of course, the physicians might say there is a symptomatic hypotension, but this could be overcome. There are some tips of doing it, but there is no worsening of renal function. This was a worry for some of the physicians, and these are things which are really cleared. And if you were to compare with the ACE or ARB, which is what the standard therapy was once upon a time, you find that the significant reduction comes with ARNI. So today, without doubt, I think the first drug that you need to put the patient on in heart failure is an ARNI or the angiotensin receptor blocker, sacubitril statin combination. And the initial recommended, this is all mentioned for chronic heart failure. But today we know, even in hospitalized patients, if you start, one of the measures, how do you diagnose heart failure apart from the clinical diagnosis? It's a biomarker called NT-proBNP. I keep telling people, these physicians, that this is just like your troponin T. Today you are so much comfortable. Somebody has chest pain, troponin is positive, you know it's an acute coronary syndrome. Similarly, if it is more than 125, this is high. So they looked at the NT-proBNP and they found that if you put these on patients on this RNA, the NT-proBNP comes down, telling you that this is very important. And not only that, very important message is that this is one drug which has shown there are no drugs which have shown such efficacy in terms of improving the LV function. Look at this, 9.4% improvement in the LV function in 12 months. And not only that, out of this group, 1/4 had an EF improvement as high as 13%. Again, proving the point that this is the way to go about. So to sum it up, ARNI, we know that there is an improvement in LV function. So this is the drug to go, and it could be used in de novo. Don't wait for an ACE or ARB. Start them straight away, even on ACE, ARB naive patients. And it lowers the NT-proBNP levels. And of course, even in low doses, I mean, in India, we have also seen that the target dose is 200 milligram BID. But today, we also know that even at the smallest of dosages, this is effective because these are drugs which will actually prevent the worsening. So once you have a heart failure, you must understand that the moment they get admitted, there is the trajectories that they deteriorate. You might stabilize them, but over a period of time, they deteriorate, enter into the early post-discharge phase and follow up. They start deteriorating, and one should actually start them as early as possible to have the benefit. So the management of heart failure is that start this therapy early, hospitalize patients, because this is a very important message which I wanted to convey. The best time to start this is when the patients are admitted in the hospital, not when they come to the OPD, because they always tend to believe the doctor during hospital. They don't want another hospitalization. And of course, the follow-up is based on the clinical trajectory. Now, is there any data to suggest this? We also know that when you have something started in the hospital, for example, the beta blocker, if you start them in the hospital, 90% of them are adherent to that. This is a famous quote by Fonoro in 2007. Similarly, if the ACE inhibitor start in the hospital, 71% would be adherent, whereas only about 19% if you start them on OP, it will be adherent. So I think start them early as far as the hospitalization. So the tips are, the major worry for the physician is in terms of hypotension. So the tips actually initiate during hospitalization the moment you take them off a IV diuretic. Secondly, you can use a low dose so that you don't have the hypotension. Avoid dehydration. This patient, hydrate them very well. And the third important, if you have a borderline BP, you're worried, reduce the dosage of diuretics, but keep the ARNIs going. And again, titrate to the guideline dosage at home. There have been studies which have shown that this is found to be effective. And direct to ARNI approach, don't start on an ARB or ACE, start them straight away. So these are the ways to go about to start them on ARNI. The second important drug is the beta blocker. When do you start them? Initiation is as early as possible. The moment they are decongested, don't start them in a patient with acute LVF, but the moment they are stable, same time as an ARNI, you could use it. And the heart rate, today we know that the most important drug which really prevents outcomes or deaths is the beta blocker. And the higher the dosage of beta blocker, the better. But then you need to take your time to start them on a small dose and initially, and then keep on increasing them. But the important thing is you gradually uptitrate over a period of 2 weeks and initiate it when these patients are less congested or dry. And of course, the only problem is that no beta blocker if the resting heart rate is low. And avoid carvedilol. The most important thing, though many people, I'm sure a lot of cardiologists actually believe in this drug, but the problem when you combine carvedilol with ARNI is the hypotension. So if you have a hypotension, borderline blood pressure, the drug probably you could depend on is probably bisoprolol. The third important drug is a C melanoreceptor. Again, whether question is whether before or not, but this is a safe drug. You only need to look at the renal function, the potassium. But believe this is not for a diuretic effect. It is for actually to prevent the LV from enlarging, to prevent the remodeling. Efficacy again when started within 7 days, but beyond 28 days, it may not be effective. So I think all these drugs should be started as early as possible. And of course, you tend to see hyperkalemia. Today, as per the guideline, even if you see hyperkalemia, there are agents like the patramir which are useful in trying to sort out this hyperkalemia. And of course, the fourth drug in the group is the SGLT inhibitor. I don't have to go this into detail. The DAPA-HF and the Emperor have really shown there's clearly about 20% reduction in the hospitalization mortality. So these remain the four major pillars of therapy. Along with that, we have a very high resting heart rate. Despite on a beta blocker, you could add ivabradine. And the new drug, which is very promising, Versiguard. In fact, we have all started using this in a much bigger way. When you have a worsening heart failure, is an add-on in the armamentarium heart failure. Digoxin, sometimes recurrent hospitalization, there still is a role. Small dosage, 1.125 milligram. And of course, PUFA and potassium binders are also in addition. Now, when you start ivabradine, I think there is a tendency for the physician to start this as early, but it should not be done before a beta blocker. If still on beta blocker, the heart rate is more than 70, it's fine. Or up titration when you are not able to increase the beta blocker due to some reasons. Or for example, you have a bronchospasm, you're not able to use a beta blocker, it's a good choice. But 50% of the on target dose ivabradine use is supposed to be beneficial. But a word of caution, shift data sub-analysis shows it's not useful in when you have a atrial pace rhythm, chronic atrial fibrillation, and also in unstable situations never use an ivabradine. And also there is also a tendency for ivabradine to produce paroxysmal atrial fibrillation. In fact, it was seen in about 40% of the time in patients even in normal sinus in the trials. But the new drug which I have mentioned is called the Versiguard, which actually is through the signaling the cyclic guanyl cyclase GMP pathway, which acts like a vasodilator. It's almost like a nitrate-like effect. And this not only has an effect on the myocardial system, also got an effect on the vascular function. And this trial actually was terminated very prematurely in about 10 months' time because it gave, even in patients who were getting recurrent hospitalization due to heart failure, there was a 10% reduction in hospitalization. In fact, this is one of my patients post-cabbage where a patient came with very sick on most of the drugs could not be used because his renal function was not very good. He had hyperkalemia. The pressures were not good. The only drug he would tolerate at that point of time on 23rd of January was this. And he made a remarkable improvement. Today he's just class 2. And you see the kind of improvement in the LV function. So this patient was started on this Versiguard 2.5, went to 5. Today is on the dosage of 5 milligram and doing very well. So I think the simplified algorithm is initiate all 4 I just mentioned earlier, A, B, C, D, beta blocker, MRA and DAPA there. Assess the clinical situation. And of course, when you put this patient, you need to reassess the LV function. And there was a time when we thought that the way to go about is by a conventional system, but today that is different. You keep on adding, even at the smallest dosage initially, a beta blocker, SGL2, then of course an ARNI and melanoreceptor. And today we also there is a data called the strong heart failure, which is got published in Lancet, where you put them on the small dose, keep on increasing at 2 weeks, and by 6 weeks on the highest possible dosage. You find that the high intensity care, they are all, when they are randomized, they are all on much higher dosage of ARB, beta blocker, and this actually translated to clinical events in terms of reduction of mortality by about 180. And again, this was prematurely terminated. So much so, the ESC today has made this as a guideline, and we are trying to push off. And in fact, there is another trial which has also shown that rapid sequencing on data, there is an algorithm there. If you do that, the outcomes are better in terms of reduction of mortality as well as recurrent hospitalization. But despite saying all that, this is a recent publication in the European Heart Journal, which shows that the number of patients on what you see on green is the number of patients on this therapy who are added, and the chance of uptrading is still low even in the Western countries. Maybe because of a variety of reasons. For example, somebody does not have the blood pressure, the physician is reluctant, the heart rate is low, you can't add a beta blocker, chronic kidney disease, the potassium is high, presence of absence of AF, so many factors. But I think the key is actually there is a large non-adherence, old age, frailty, hypertension, many reasons. But I think it's important to understand that we need to really push this. So despite all this, the CHAMP registry showed that only 1% of the patients were on therapy. And we also have disparities. For example, if you find that women, patients without health insurance, cost, everything is a big factor in the low middle income countries. So there are a lot of reasons, and other important challenges. Even in this is a recent publication, the Evolution Heart Failure Trial from UK, which has shown that even if you put them on that, the best drug, the SGL2 and the ARNI, which I was talking at length, they are not really utilized the way it should be. You see, what is there in green is the dapagliflozin. It's not in a really desired way. There's still a long way to go. So I think we need to go one step further. Maybe there are a few things to look into. For example, the generics may be cheaper. In diabetes patients, SGLT could be the way. Reduce the therapeutic complexity because polypharmacy is a problem. And of course, a careful medication. More importantly, I think once you have started them, please follow them up. It's 2 weeks, titrate the drugs, evaluate the renal function, ventricular function maybe once in 3 to 6 months. More frequent if the patient becomes symptomatic on these drugs. And of course, routine echo to identify candidates for advanced therapies. And of course, if you have the facility, do an NT-proBNP to see how well they are doing. And sometimes you may have to go to the extreme when the patients really keep deteriorating to specialists, send them to specialists and to look at the invasive peer pressure monitoring. So I think the accelerated and personalized therapy, this is a new way to look at things. I mean, this is actually, if you put them in all this, within a short time, 1, 2, what you see here is the weeks, 1, 2, 5 and 4, the sequencing, you find there is a 40-50% reduction in terms of mortality at the end of 1 year. So I think that's the way to go. So the final message is that heart failure with reduce is a serious and challenging problem. The guideline-directed medical therapy, which I was stressing, is a very improves the quality of life and mortality. Early initiation is the key. All 4 ARNI, SGLT inhibitors have shown remarkable efficacy, and these are the drugs to be used. Follow-up is crucial, identifying poor responders, and newer therapy and interventions are really encouraging. Thank you all for the kind attention.
Thank you, sir. Thank you for the wonderful talk on heart failure. I think we have 3 related topics, so we'll take questions after all 3 together. Let me invite Dr. Palanisamy sir to felicitate Dr. Jayagopal sir. Let me invite Dr. Jabir Abdullah sir for the next talk on heart failure, managing side effects, complications of medical therapy.
As Dr. Jayagopal has already shown the way we should go forward, but then everybody have the doubts in their mind. Is it safe? What are the problems? Of course, when there is polypharmacy, especially powerful drugs in a complex disease like heart failure and reduced ejection fraction, there can be a problem. So these are multiple the trials over the last 3 decades. We have accrued data with multiple trials, multiple drugs, multiple devices. And finally, we could pick 4 ACEs that Dr. Jayagopal was telling that these 4 ACEs are ARNI, beta blocker, MRA and SGLT2 inhibitors, which became the pillars of therapy. So I'll show a case for 54 years old male, anterior volume in 2014. We did a primary angioplasty to LAD at that time, but his LV did not improve. He developed heart failure and reduced ejection fraction. AF progressively, later on he developed CKD, is diabetic also, NYHA class 2 till 1 year ago. Now he developed worsening of heart failure with recurrent admissions. These are the medication, the last admission, beta blocker, MRA, ARNI, SGLT2 inhibitor, vericiguat, aspirin, statin, OHA and rivaroxaban. And at the time of last admission, that's 1 month ago, his recent admission was with fatigue, dyspnea, pedal edema, blood pressure borderline, heart rate low, pedal edema, bilateral crepes, grossly elevated JVP. And you can see the heart rate, it is AF with almost something like a very low ventricular rate and broad QRS complex. These are his serial electrolytes. Blood urea start with 151. With treatment, we could reduce it to 99 over a period of almost 3 weeks. And the creatinine at the time of admission, it was 7.38, which was 1.7 or 1.8 before the admission. This acute kidney injury. But there is a prevailing CKD. We could stabilize him to 2.373. 37, sodium 127 to 134, and potassium from 7.6 to 4.3. So this is the trajectory of heart failure with reduced ejection fraction and the treatment. It's a progressive disease. It stabilizes the underlying that stability, which is a clinical symptom stability. The heart failure progresses because of the apoptosis and the fibrosis going on. So they stabilize, deteriorates, stabilize, deteriorates, and finally will start deteriorating and will end up in LVAD or a mechanical cardiac support device, or finally transplantation. And in between, these are the problems that we come across: hypotension, hyperkalemia, renal dysfunction, and arrhythmias. So this guy, finally, I discharged him on 2310. No much guideline recommended medication. Twice-imide, isoleucine or isosorbide dinitrate plus hydralazine, vericiguat, warfarin, and linagliptan. So now I'll be calling him back and then see whether I can restart him on the guideline recommended medical therapy. So there are problems with treatment. If you look at the earliest study, the carvedilol, which was the first, the US carvedilol study, they showed us the benefit of beta blocker, and later on we got that benefit from bisoprolol as well as from the metoprolol succinate. So if you look at it, what are the major adverse effects with carvedilol in a very sick, sick group of patients? It was predominantly fatigue, sorry, not fatigue, it was bradycardia, which was in 0.9%, and then dizziness. Hypotension was not that great, and syncope was not great, and then other things were not significant. So dizziness and bradycardia were the most important side effects. And with the spironolactone, it was gynecomastia or painful gynecomastia or a breast pain in males, 10%. Serious hyperkalemia in 2%. And the drug discontinuation rate was only 8% versus 5% in the placebo. But these early trials, this was not with the 4 drugs on board. It was the ACE inhibitors were there in the carvedilol trial, and this drug had beta blocker and ACE inhibitors. And we'll come to the most important drug, that is ARNI, which showed the best outcome benefit in heart failure and reduced ejection fraction. Symptomatic hypotension in 14%, impaired renal function in 5%, hyperkalemia in 12%, angioedema in 0.5%. And symptomatic hypotension was the statistically significant thing which was different from the placebo, 14% in the vericiguat and 9.2% in the enalaprilam. And blood pressure of less than 90, 2.7% and 1.4%. And the reason for discontinuation of drug only in 0.9%. And if you look at the elevation of creatinine, more than 2.5 or more than 3, elevation of potassium, these were more with enalapril rather than with ARNI. And action taken, mostly dose adjustment in 50% of patients or a temporary interruption. And the permanent discontinuation was 3.3% for the sacubitril valsartan when you look at the side effect signals. And change in concomitant medications, 12.4%, non-drug therapy 2.6%, and adverse effect leading to hospitalization was 7.4% in the ARNI arm. So majority of these problems could be managed with change in the concomitant medication and other non-drug therapies, and discontinuation was required only in 3.3%. So in the Pioneer HF, which was the most sick patients, acute heart failure admitted, and ARNI was tried for the first time. In the Paradigm HF, it was chronic ambulatory patients with heart failure and reduced ejection fraction. They are stable patients. Here, worsening of renal function, hyperkalemia, symptomatic hypotension, and angioedema were not significantly different from the enalapril. And record of down titration or discontinuation of the RAS inhibitors therapy due to hyperkalemia is so small. So adverse effects do occur, but not as great as what we think, and many of them are manageable. So hypotension, you look at whether there are other drugs that can interfere with the concomitant medications, calcium channel blocker, alpha blocker, nitrates. Remove it. They are not going to help in heart failure except nitrates in certain situations. Diuretics, if possible, reduce it. And if not possible to continue the sacubitril valsartan in that particular dose, reduce the dose of sacubitril valsartan. Renal impairment, look for hypovolemia, intravascular volume depletion, correct it. Adjust the dose of diuretics and sacubitril valsartan. But if there is a serial increase in the creatinine, it goes more than 50% from the baseline. If it goes above 3 mg per deciliter with the treatment, then you may have to discontinue sacubitril valsartan, then may wait and reintroduce. Hyperkalemia, look at mineralocorticoid receptor antagonist, reduce its dose. and if needed, stop it. Then try to continue sacubitril valsartan, but if it doesn't permit, you can wait up to 5.6 millimoles per liter, and if it goes above, then we may have to stop it. This was also shown by Dr. Jayagopal. Don't worry, if you are reducing from 100 to 50, that dose also gives some benefit. May not be the benefit as a 200 milligram twice a day can give, but some benefit is always better than no benefit. So something is better than nothing. There is no need to worry about reducing if it required. Dapagliflozin, there is no significant difference in the side effect profile. The event rate was only 9% with the dapagliflozin, and the major difference that was seen with dapagliflozin is only one thing, an increase or excess of genital mycotic infection. So other things, volume depletion, renal adverse event, fractures, amputation, major hypoglycemia, even in patients who are non-diabetes, no difference. No difference in adverse events leading to treatment discontinuation, and no much actually any serious adverse event was lesser in the dapagliflozin arm. So 4 pillars of therapy, it's reasonably tolerated drugs. Adverse effects can be managed. So what are the serious issues which requires drug discontinuation? Symptomatic hypotension, that is a major problem with ARNI. Hyperkalemia, renal dysfunction, bradyarrhythmia or severe bradycardia. And in symptomatic hypotension, the most important agent is the vasodilator, ACE inhibitor, ARB or ARNI. Look at the volume. If there is volume depletion, correct it. That most important concomitant problem that leads to hypotension is volume depletion. Look at the postural fall in blood pressure. That is important. And diuretic dose. You keep the minimum dose of diuretic to reduce the congestion. Clinically, by looking at the JVP, edema, or you can use the ultrasound and look for the lung comets. Look at the NT-proBNP, whether it is coming down or not. If the NT-proBNP is not coming to less than 1000 millipicogram per ml with your treatment, this patient is going to do bad. And look for any non-heart failure drugs which is causing hypotension, like a diltiazem, a verapamil, a calcium channel blocker, even amiodarone. And change carvedilol. Dr. Jayagopal was also telling. If you are not able to push the dose of ARNI or continue that dose of ARNI, look at your beta blocker. Is it carvedilol? If it is carvedilol, which has an alpha blocking action, change it over to another beta blocker like a nebivolol, a bisoprolol, or even a metoprolol succinate. It may help. And then, if not possible, patient develop postural hypotension, patient is symptomatic, reduce the dose of the drug. Then patient walk into your OPD, he is doing all his regular activity, he is not symptomatic, his blood pressure is 90. What will you do? If his renal function is stable, if his volume status is stable, there is no evidence of postural hypotension, and the patient is absolutely okay. There are a lot of patients, everybody who is treating high heart failure may be seeing on ARNI, blood pressure 90 or blood pressure 87 or 88, patient is absolutely asymptomatic, no need to touch that ARNI, because discontinuation may create a problem. The cutoffs you should have in mind. Systolic blood pressure, usual cutoff is 100 millimeters of mercury to start the ARNI, and there should not be any postural fall of more than 20 millimeters of mercury. Potassium cutoff limit is 5.4. You may go up to 5.6. Nephrologists feel that even up to 5.8. Okay, watch. EGFR is 20 for the SGLT2 inhibitors and 30 for the ARNI. But now, an off-label relaxation is a practicality. Even those patients who are on renal replacement therapy, most of the nephrologists feels that to derive the cardiovascular benefit, you may continue the SGLT2 inhibitors, and for that matter, if the hyperkalemia is not a problem, you can even continue the ARNI. But I always discontinue the ARNI if the EGFR is less than 30, and SGLT2 inhibitors if the EGFR is less than 20. The initial fall in GFR is a hemodynamic effect. Don't worry about it, it will fall. But it should not fall by more than 10 and should be more than 25 ml per 1.73 per meter square body surface area, EGFR. Serum creatinine may go up to 50% from baseline, provided the absolute value should be less than 3 milligram per deciliter. So it is not a very tight compartment. You can relax, but only thing is you have to keep the patient under strict surveillance. Hyperkalemia, mostly if you combine the RAS inhibitors or ARNI with MRA. So, and it is found that if you start the ARNI first, later on all the MRA, usually the MRA is well tolerated. And also in patients with renal dysfunction, patients with some types of diabetes and distal tubular renal tubular acidosis, like a type 4 renal tubular acidosis. Look at the diet of the patient. Is he taking enough more fruits, more fruit juices, more nuts? These are certain things that we miss. Strict potassium restriction diet. Reduce the MRA, or even you can omit the MRA for the time being. Can we change to the new drug Finrinon, which is little more potassium friendly? We don't have a data in heart failure. Basically, the data is in renal dysfunction. But judiciously, I think we may change to Finrinon. It's the same group of drug. And spironolactone is very potent drug. So you can change our spironolactone from eplerenol, which is a weaker drug, so that the potassium increase may be less. We don't have this drug, patiromer or sodium circonate, which is now the tendency for patients who derive benefit out of ARNI, and potassium is the limiting factor. You combine potassium with patiromer, potassium sparing diuretic with and ARNI with patiromer, so that potassium is not an issue for you. And these are the cutoffs which I have already discussed. AZ inhibitor, ARB, systolic blood pressure should be more than 100, EGFR 30, and potassium should be less than 5.4. Look at the symptoms for postural hypotension, creatinine, potassium, and we may reduce or discontinue if this increases, especially increase in creatinine by more than 30% in a month's time. So early rise in creatinine, as I said, is an anticipated effect. Remove the other drugs and all. Beta blocker, better to have the heart rate of more than 60 beats per minute and a systolic blood pressure of more than 100. We don't have any laboratory parameters to look at the beta blocker effect. It is heart rate and systolic blood pressure. Better reduce the dose if the heart rate goes less than 50 beats per minute. MRA, again potassium, 5.4 is the cutoff. Up to 5.5, okay. Increase in serum creatinine more than 30% within 4 weeks of initiating, we may have to cut down the drug. SGLT2 inhibitor is very friendly drug. EGFR up to 20 with empagliflozin. This also produces an early rise in creatinine, which will settle later, and look for genital mycotic infection. I'll tell a word about the use of diuretics. Patients with significant congestion needs decongestive therapy. No doubt their creatinine will rise, their blood urea may rise. Usually it settles, and renal vein congestion is there. Relief of the renal vein congestion and the renal edema helps the renal function to improve. So increase in creatinine during diuretic treatment is common and do not always necessitate stopping or decreasing the loop diuretic dosage, especially if the congestion is persistent. There is data which says that if you discharge the patient with persistent congestion, these patients are going to come back with heart failure hospitalization again. And the clinical data suggests that these changes in the creatinine are usually transient, associated with the similar or even better long-term outcomes in the setting of effective decongestion. Then with the heart rate, the patient needs beta blocker. He has some amount of left bundle branch block. Or if he requires a pacemaker and you want to continue beta blocker because the heart rate is coming down, you are not able to start the beta blocker, put in a pacemaker, and better to go for a CRT rather than a pacemaker alone, because you may need upgradation later. This helps to use beta blocker safely in those with bradycardia. And borderline blood pressure, if no symptoms, GDMG should be continued. And both the drugs, ARNI and MRA, may be permitted with potassium up to 5.6 millimoles per liter under proper surveillance. Look for renal artery stenosis if there is a sudden deterioration in the renal function with RAS inhibitors, and change to eplerenone if gynecoma stay with spironolactone. And bronchospasm is the problem. Continue the beta blockers, shift to the bisoprolol, which is the most selective agent, especially carvedilol is a non-selective agent. It may induce more of the bronchospasm. And take the help of the pulmonologist, put him on aerosol bronchodilators and continue the beta blockers. Never ever discontinue the beta blockers. And for genital mycotic infection, you can suggest even a circumcision for the males and continue the SGLT2 inhibitors. So to take home, side effects are common with heart failure medications, especially polypharmacy. It's more in elderly, frail and CKD patients. Try your level best to continue the GDMT. Since it prolongs life, it improves the quality of life. Meticulous control of the fluid, food, drug dosing, concomitant medications. This will help us to continue GDMT. Discontinuation may be required in 2 to 4% of patients, not more than that. And sometimes we may have to discontinue the drug which is required due to the life-threatening side effects. Thank you.
Thank you, sir. Thank you for the wonderful talk. Let us move on to the next one. So the final talk of the day. As a continuation to what we are discussing on heart failure. So this is about heart failure treatment across left ventricular ejection fraction spectrum. I think we have had two interesting talks on heart failure with primary focus on heart failure with reduced ejection fraction. We all know we have different varieties of heart failure. We categorize them according to the ejection fraction. You can have heart failure with reduced ejection fraction. The patients who have signs and symptoms of heart failure with ejection fraction less than 40%. Heart failure with mid-range ejection fraction where EF can be between 41 to 49%. And heart failure with preserved ejection fraction where you have symptoms and signs of heart failure with ejection fraction more than 50%. With objective evidence of heart cardiac structural or functional abnormalities consistent with the presence of LV diastolic dysfunction or raised LV filling pressures including elevated natriuretic peptides. So we have these patients, they move across the spectrum. The patients whom you have seen with a reduced ejection fraction can have a recovery and end up in mid-range or preserved ejection fraction. Same time, the patients whom you have seen with normal ejection fraction can slowly progress into other way around with a reduced ejection fraction also. The prevalence of different types of heart failure is changing over the time. If you look at the earlier decades, 1985 to 94, the most of the patients presented with heart failure with reduced ejection fraction. Now you could see more and more patients are presenting with heart failure with preserved ejection fraction. So with the increasing life expectancy and aging population, we see more patients who are presenting with heart failure with preserved ejection fraction. And there is also a significant change in the way patients are living after a cardiac event. You know there is an increased survival after a clinical cardiac event like coronary artery disease. And rate of AF is increasing as the population is aging more. And not only that, we are also able to recognize and diagnose more patients with heart failure now with better diagnostic facilities. Every patient who has a heart failure, each hospitalization will bring the patient close to the mortality. So the most important concept in heart failure management other than other cardiac diseases is prevention of hospitalization. It is a hard endpoint in heart failure where not only you look at mortality, you also look at heart failure admissions also. So if you look at all three types of heart failure, you could see there is not a significant difference between readmissions and mortality. If you look at most of them look same. Heart failure has highest 30-day readmission rates compared with other diagnoses. So you admit a patient with heart failure, the chances that he has to get admitted within 30 days is pretty high. And mortality significantly increases after every admission. So mortality rate risk remains urgent and life-threatening for patients with heart failure. You could see as the patient progresses further and further into a heart failure journey, you could see a significant increase in the number of admissions and mortality. So whenever you see a patient with heart failure, you have a definite goals in your management protocol. You want to reduce mortality, the primary aim. And the second primary aim is prevention of recurrent hospitalization due to heart failure. And definitely, the more importantly, you want to improve the clinical status and functional capacity and quality of life. So if you look at the new heart failure guidelines, they have become pretty simpler now. You have to put the patients on pillars of heart failure management. You put them on ACRB, ARNI, beta blockers, MRA and SGLT inhibitors. If patient has a signs of fluid retention, you consider adding a loop diuretic. If patient has an ejection fraction less than 35% and QRS is less than 130 milliseconds, if appropriate, particularly in a ischemic heart disease patient, you can consider putting a ICD for prevention of sudden cardiac death. If a patient has a ejection fraction more than 35% and device therapy not indicated or appropriate and symptom persist, you can consider other therapies which are available, class 2 therapies which can be added, like Sir told about Versigad and other newer drugs, you can add them. If a patient has a sinus rhythm, EF 30% and QRS is more than 130 milliseconds, these patients are candidate for a CRT. If it is a ischemic patient, you consider putting a CRT-D, which has a ICD inbuilt, or CRT-P in case of a non-ischemic cardiomyopathy. So, if you look at patients with preserved ejection fraction, there is a significant difference because there are few drugs which you use heart failure with reduced ejection fraction which have a good outcome trials in patients with preserved ejection fraction. SGL inhibitors is one of among the drugs which have shown good benefit in patients with preserved ejection fraction. If you have a patient with preserved or mid-range ejection fraction, the management is little different compared with patient with reduced ejection fraction. Here you may need more diuretics because a lot of these patients are congested more, and you have to use either DAPA or EMPA for disease modifying effect. ACE, ARB, ARNI, MRA, beta blockers all have a limited role, except that ARNI has shown in some group of patients, particularly patients who have ejection fraction in a range 40 to 50 has a role. When you cross ejection fraction more than 50%, there are very few drugs which have shown outcomes. One among them is a SGLT inhibitor. So SGLT inhibitors we know has a multiple mechanism of action, and if you look at guideline directed medical therapy, the guideline directed medical therapy, when you combine all together, ACE, ARNI, beta blocker, MRA and SGLT inhibitors all in combination has the best possible outcome. So whenever you have a patient with heart failure, your primary aim should be to add all the drugs possible. And slowly introduced as a diabetic drug, SGLT inhibitors has become primarily a cardiac drug, particularly in heart failure management. Now you see lot and more indications are evolving for SGLT inhibitors. Starting from heart failure with reduced ejection fraction, now we have recommendations for heart failure with mid-range or preserved ejection fraction also. So we have data from a large trials that DAPA or SGLT inhibitors have a significant reduction in cardiovascular death and worsening heart failure in patients with reduced ejection fraction. So when you have an ejection fraction more than 40%, as I told you, we have very limited options. If you look at sacubitril valsartan, if you look at spironolactone, if you look at ARB or ACE, most of the trials have not been very fruitful. The data was not very convincing. None of the drugs have shown a clear benefit in patients with preserved ejection fraction. EMPA was the one among the drug where it could deliver a good data even in patients with preserved ejection fraction. SGLT inhibitor as a group shown to improve patients with ejection fraction which is in the mid-range or a preserved level also. DELIVER is a good trial. It's the largest and broadest trial to date in patients with heart failure and mildly reduced or preserved ejection fraction, where you could see a significant improvement. A primary composite endpoint of cardiovascular death, heart failure admissions, urgent heart failure visit has been significantly reduced with 18% relative risk reduction. And one thing you always see in most of the trials with SGLT inhibitors is the early onset of benefit. This is one among the drug with heart failure which has a very early benefit. You could see a benefit as early as 2 weeks. To compare with beta blockers, most of the beta blocker trials, you could see benefits at the range of 3 to 4 months, while SGLT inhibitors can deliver a benefit as early as 2 weeks. This benefit was consistent across all the subgroups. So this has put DAPA or SGLT inhibitors across full spectrum of EF, and if you look at the pooled analysis of both DAPA HF, which is on reduced ejection fraction, and DELIVER with preserved ejection fraction, you could see there's a significant improvement across the group. If you look at death, heart failure admissions, or major cardiovascular outcome, all were significantly improved when you look at SGLT inhibitors in these groups. If you look at comparative benefits of DAPA and EMPA, the two good drugs which are available, So both have shown good benefit. DAPA has a more data on patients with reduced ejection fraction, while EMPA also has a good data on patients both with reduced and preserved ejection fraction. So that the benefit is spread across the spectrum of ejection fraction. So if you look at SGLT inhibitors, DAPA is the one drug which has a disease-modifying therapies across LV ejection fraction spectrum. This is the reason SGLT inhibitors are recommended across the ejection fraction spectrum in patients with heart failure. We have shown benefit even on patients who had ejection fraction more than 50%, which was not with the case with most of the other drugs. If you look at the effect of DAPA, which was consistent with patients with or without ejection fraction less than 40%. Even on patients who had consistently better ejection fraction, still DAPA was able to show a better benefit. So if you compare head to head, EMPA has a good data even on patients with preserved ejection fraction. But if you look at patients overall cardiovascular death, that's a one area where Emperor reduced or Emperor preserved could not show a lot of benefit. And there was a one criticism which was there for EMPA preserved, where the mortality benefit was an issue. So if you look at the patients with heart failure, you could see that the drug DAPA has a better effect on patients across the spectrum of reduced, preserved and mid-range ejection fraction. So so another thing which always we are worried is when you have a lot of other drugs available, like you have a lot of generic brands available. So one thing we have seen is most of these trials, what we see as a data are done with innovator brand. So it's very difficult until unless you prove that the preparations are same. Very difficult to postulate that all the outcome benefits what you achieved with original brands can also be brought to the generic brands which are available in market. To summarize, DAPA has a significant improvement in mortality and it has a significant effect on mortality reduction. It is recommended across spectrum of heart failure, including preserved ejection fraction, and most of the guidelines recommend one of the cornerstone of medical therapy for heart failure as SGLT inhibitors, and DELIVER, which was done on heart failure preserved ejection fraction, was shown significant reduction in composite cardiovascular death, worsening heart failure with all the components delivering the benefit. The pooled data also is positive. So when you have this data, I think SGLT has clearly shown that this is a one drug which have to be added in most of the patients with heart failure, and it has shown benefit even on patients with ejection fraction more than 50%. With this, I'll close my talk. I think the questions on whole heart failure will take, I think, starting from the panelists.
So regarding this talk on this innovator brand versus the generic brand, there are a lot of patients now taking generic rather than this innovator brand. So how often you see patients with benefit of those molecules and complication of those molecules in your routine practice?
I think the major difference one must understand is mostly in the pharmacokinetic. The raw materials, people keep on mentioning this. The raw materials are same, but then when you have a brand, for example, when enoxaparin was marketed in the world, the way you get the active form of enoxaparin, it goes through a really polychromatography, many phases. So the kinetics become different. For example, when you have an innovator brand, you know that the molecule is supposed to act for 12 hours and then you give a BD dosage. So molecules like that where you're worried about bleeding and things like that, it makes a huge difference because the kinetics might different. The sequencing, all that they have is a raw material. They probably have only patented few of the steps which will not come out. So that's one worry. Exactly the same thing when you have a ticagrelor. But then molecules like this where, on a day-to-day basis, when you have a patient on a stent and then ticagrelor, I would always prefer the innovator as far as possible. Somebody could afford it. But again, like I have shown in my talk also, one of the things with Arni also, Vimod is such a wonderful drug. But the problem is the cost factor. So, something is better than nothing. So there, instead of 100 milligram, maybe 50 milligram of your, they may be equivalent to the 100 milligram. I don't know. I cannot really. But then, so in that context where it's not really going to be a problem in terms of bleeding or some of the, I would prefer the generic brands. What do you say?
This is a difficult question to answer because our patients comes and ask, sir, can I buy the drugs from Janaushadhi? Is there a difference in the quality? I'll tell them I do not know.
No, that I can vouch because I've been following this, tracking this very, very frequently. What I tend to see is that the easiest thing is cholesterol. If somebody is on a because that is the only area where you're controlled, because sugars might vary. Somebody is very stable on atorvastatin 40 milligram, 130. Next time when he comes on a visit, it's gone up to 230. Then you know that that is happening. And this has been I think that probably the main message comes from other physicians in town as well. So that's the only area where we are very sure.
We are finding difficult when there is oral anticoagulation about. Lot of INR difference between this.
Warf.
Yes.
Yeah.
Sir, what's your advice on vaccination, sir, for regarding influenza and pneumococcal vaccination?
I think Jabir is the right person to answer that. He did a trial on that.
Yes.
We had a trial across, it is a world trial, including India. We could not find actually much difference. But those people who were vaccinated during the season, they had a benefit. Otherwise, there was no remarkable benefit. But there are certain data which shows that there is some benefit when you could cut down the infections. Now it's a class 2B recommendation using vaccination. So at any time, I would prefer to give vaccination if the patient can afford.
I think I have two comments to make. One, actually, the main author of this paper was Ambuja Roy from India. So he is convinced beyond. In fact, this topic was given to him. I did give him as a talk also. So these people, they have the data to say that this is definitely helpful. But though it's not become there is a recommendation to use vaccine. But I think going one step further, when you find, for example, the seasons, this is probably more relevant in the Western countries, but then even in India also during the cold months, if you start looking at the CRP levels, and you find that the CRP levels, I'm talking about HSCRP, not the usual CRP, and if you find that these levels on the higher side, there is an infection which is going on. And today, both of us are into another trial. This is again another global trial where we have gone one step further. How do you bring down this HSCRP? It is actually the infection. So you can prevent that by using a vaccine. Number one, that's your question. Or you can go one step further, use monoclonal antibodies. So there is a new drug called siltevecumab, which both of us have done about 15 patients altogether. So this is a drug which has been shown during COVID times to reduce the HSCRP. So there are a lot of indirect evidences, and today the recommendation is to give a pneumococcal, I think the vaccine, the influenza. So I think all heart failure patients, and most of them, they succumb because of coexisting infection towards the end of the heart failure status.
The group I meticulously following this vaccination recommendation is the pulmonologist. Though there is recommendation for diabetes, COPD, and also for heart failure.
Sir, with respect to SGLT2 inhibitors, is it advisable to start at a lower dose and go upwards, or to start at a maximum dose at the upfront?
I think there is no doubt. This is only drug and MRA which you start at the accepted dose, 10 milligram. Because this is, even in a non-diabetic patient, it's found to be safe. So you start with 10 milligram. There's no need for a 5 milligram. MRA also, you start with 25 milligram Valdactone. If you find that there are few patients where the potassium might go up, in that case, you can even bring down to 12.5. It's again not the dose which is important. It's the way they prevent the fibrosis. That is the main role for MRA.
In fact, this 5 milligram dose has never been tried in any of the clinical trials. And that's the beauty of SGLT2 inhibitors. The beginning dose is the final dose, no titration.
But I think there's also a very important factor in your question, because EMPA, if you looked at it, it is not 25 which is tried in the trial. It is 10 milligram. So by the same logic, 5 milligram should work. But this I have asked, in fact, Professor McMurray also, we asked this question. So why not 25 milligram? So is it 10 is good enough? And again, Dr. Lauren showed a slide. DAPA is effective in the only drug which has shown a mortality benefit is DAPA, not EMPA. So was it because they were on 10, the EMPA was on 10? So now there is a trial where they're trying to hike it up to 25 and see. But the official explanation from the people who did the trial is that the EMPA had sicker patients, and that is probably the reason why they did not show the mortality benefit. 10 milligram, 10 milligram, 10, both 10. EMPA and DAPA both 10. No, both. Heart failure it's 10. The drug was used at a dose of 10, and 10 is recommended. But EMPA 10 is enough. For diabetic control, you might need 25, but 10 is enough for EMPA.
It's possible the more dangerous is both the ticagrelol and the oral anticoagulation, which is very harmful with this generic. Yeah, and low molecular.
My question is, see, a good number of people in the cardiac failure die of arrhythmias, ventricular arrhythmias. Is there any role for antiarrhythmics as part of treatment? And the second thing is clot formation in the LV. Some of them can be very documented by the echocardiogram. Others, is it any role for anticoagulant prophylactic anticoagulants forms part of the treatment for cardiac failure?
A patient without atrial fibrillation and no LV clot at the time when you do or an in-text echocardiogram, there is no indication for prophylactic usage of anticoagulation. But if you come across a clot, then you have to use anticoagulation. And for an LV clot, the data is all for vitamin K antagonists. The data is sparse for NOACs. But we all use NOACs. Data-wise, it is warfarin. And second thing is, one situation where I may start prophylactically is if the patient has a spontaneous echo contrast in the LV, I may start on an oral anticoagulation. The oral anticoagulation is pretty difficult in these heart failure patients because they are on multiple drugs.
I think so I think the question is there is no doubt when you have a large anterior infarct and an LV apical clot, atrial fibrillation, I think the way to go about is number one is warfarin. But then there is also a trial which is conducted today. This is a trial which has been followed up with apixaban and even in LV clot, and they found that over a period of time the clot burden comes down, it comes down. But then it's not there was a trial called Commander trial in where they used dabigatran in heart failure, and there was actually no difference in mortality. So routinely using this Command HF, routinely using this is not indicated in. No, I'm talking about anticoagulants. Now coming to the antiarrhythmics, I think the best data, if the sudden cardiac death is brought down by two agents. The best is beta blocker. Higher the dosage of beta blockers, the better the reduction in mortality. So second important drug is ARNI again. In fact, many patients, what they've seen is patients who are candidates even for CRT. You start them on this, the Vimada group, it comes down, the LV improves, and then there is no need for a CRT. And that essentially translates into, but then I think I'm sure Lawrence will be able to answer that better. But sometimes you pick up ventricular arrhythmias very frequently, somebody comes to your clinic and then you put them through a Holter, then you have monomorphic or polymorphic tachycardia, then it becomes a different game. I think then it becomes Lawrence headache.
So regarding anti-arrhythmics for heart failure, I think when you look at anti-arrhythmics, we have to look at two parts. So the true anti-arrhythmics, which are beta blockers or amiodarone, which we use most in heart failure. Other anti-arrhythmics, like all other heart failure drugs, including ARNI, including ACE, ARB, statins, all have shown benefit in reduction of sudden cardiac death. The reason being the remodeling. So one of the major contributor towards arrhythmic substrate in a heart failure is remodeling. When you have to have a lesser fibrosis, lesser negative remodeling, you tend to have a better arrhythmic outcome. That's the one way by which most of these drugs are able to deliver. And among these drugs, one drug which has delivered extremely good was ARNI, which was 20%. See, the 20% antiarrhythmic risk reduction was close to what beta blocker delivered. In double digit, the only other drug which could deliver double digit reduction in sudden cardiac death reduction was beta blocker. So next drug was ARNI. So it had results more and above the remodeling effect. So there are, when you look at paradigm data, they have looked at ICD shocks. They could see a significant reduction in ICD shocks when patients are started on ARNI. So I think when you treat heart failure as a wholesome, you look at heart failure as a whole disease, the drugs which you, whatever you are going to give to create a good remodeling effect on heart, they're all going to be antiarrhythmics. So you may not require an antiarrhythmic as a separate entity until unless you have a documented ventricular arrhythmias. In that case, antiarrhythmics will not suffice. You may ultimately end up putting a device, because these are the high risk patients for a ventricular arrhythmia. So these patients will require more than antiarrhythmics. So role of antiarrhythmics is very limited. So if you find out an arrhythmia in this group of patients, you are going to put an ICD. Post ICD, if the patient is going to have a recurrent shock or recurrent event, then you are going to use an antiarrhythmic. Otherwise, very limited usage of antiarrhythmic. Prophylactic, we don't use antiarrhythmic. The only antiarrhythmics is beta blocker, maybe.
No, but what about the KMCH and the MEH trial? This is where amiodarone had really shown a benefit in terms of reduction of ventricular ectopy. Of course, flecainide was one drug which has shown excess mortality, but this is KMCH and MEH showed that amiodarone is useful.
Both are secondary preventions. Both are secondary prevention.
True,
the problem
in a patient with heart failure. Mostly these are all ischemic heart disease patients.
Yeah.
So in that context, is there a role for antiarrhythmia? That's a question.
No, the problem is like most of the secondary prevention trials, when you have a proper ICD trials, the role of primary antiarrhythmics for a primary prevention for ventricular arrhythmias were not good. They either had a worse outcomes with other antiarrhythmic agents, maybe a neutral outcome with amiodarone. So they could not show a significant benefit with prophylactic antiarrhythmics. So when you have an arrhythmia, yes. The problem with arrhythmias in heart failure is the moment you are going to have a heart failure arrhythmia, you are going to put an ICD. Once you put an ICD in, the drug which you usually upregulate or uptitrate is beta blocker. You go on a high dose beta blocker. If a patient develops an arrhythmia on beta blocker, then amiodarone comes in. And ultimately, it will be a very low dose amiodarone in most of the patients. We don't use amiodarone also for a longer period of time. So the first thing I do after putting an ICD is take out amiodarone. So if a patient is already on amiodarone for arrhythmia, the first thing I do after putting an ICD is pull out amiodarone and keep only on beta blocker.
And one of the problems that you see, the patient has an ICD and the patient is on amiodarone, they come to you with a very slower VT then where the ICDs won't shock also.
So amiodarone will create a slower circuits, and these slower circuits have to be ablated. And I think with improvement in heart failure management, the arrhythmic load is definitely coming down. And heart failure, you all know that heart failure, the primary people who are going to have a heart failure, like arrhythmic deaths are stable heart failure, 1, 2. So 3, 4, class 3, 4, NHA class 3, 4, they are mostly going to die of a heart failure. And the arrhythmias, what you are going to see in class 3, 4 heart failure are end stage arrhythmias, where you are not supposed to intervene. That's the reason, if you look at ICD indication, ICD is not indicated for a patient who is on class 4 heart failure. If you have a patients with severe LV systolic dysfunction, and you have a documented ventricular arrhythmia, but patient is class 4, putting an ICD may be problematic until unless you plan a CRTD on him or a transplant on him. Otherwise, preventing these arrhythmias are end stage arrhythmias. Here, you are unlikely, you are most probably going to make that patient's death very painful. So, because this device is going to shock all the time. So, in a class 4 heart failure, they allow only to put ICD only when you have indication for CRTD or a plan for a transplant. So, otherwise, you don't put an ICD also. That shows that your heart failure management is more important than arrhythmic management in most of the patients with heart failure. Okay, so with this, we'll close the discussion, and let me invite Dr. Jayagopal sir to felicitate our moderators. Dr. Subburaja, Dr. Vigneshwaran, and Dr. Praveen Raja. Thank you all. I think it was an excellent meeting. My first sincere thanks to all the audience. I think post lunch session having a reasonably good crowd is really difficult thing to achieve, and I'm very happy that you all stayed back. And all the faculties who attended the meeting and gave wonderful talk and made this wonderful session, and all the moderators, and not the least all our team, uh, pharma team, the sponsors, particularly the sponsors from device side, Medtronic, Abbott, and Biotronic, and our pharma partners, Novartis, Astra, and Sun, and our marketing team who worked tirelessly. I think this time it was little different. I think I was a little worried to start with because my involvement was not as much as what it used to be in previous years. I was always worried that this is going to be. I think this was a better show than the previous years. All the credit goes to our marketing team. So my sincere thanks to all. So we'll meet next year. Thank you.